उठा दो जरा। हेलो हेलो हेलो।
यहाँ रख लें या यहाँ रख लें?
कहीं आपको जब कंफर्टेबल हो।
ये ठीक है।
और आपका ऑडियो जा रहा है।
अच्छा, वीडियो वीडियो स्टार्ट करो, वहाँ पे को कनेक्ट करें। और वहाँ कौन बात कर रहा है?
यस सर। सर हॉल में सर अभी कोई है नहीं।
हाँ, डॉक्टर प्रवीण को बुला लो।
मैं सर पूछ लेता हूँ एक बार।
हाँ हाँ, हॉल का हम लोगों को दिखेगा नहीं?
नहीं सर, हॉल का नहीं।
हॉल का नहीं दिखेगा।
तो हॉल में इसलिए नहीं करते कि सर्जन ऑपरेशन करता है, हॉल में ना।
कोई बात नहीं, उसमें क्या है? अरे सर्जन पागल होते हैं यार, कोई देख रहा है नहीं देख रहा है उससे कोई मतलब नहीं है, उनको करना है अपना काम, है ना? हाँ, हॉल में बिल्कुल पता रहना चाहिए। लोग नहीं है तो फटाफट सर्जरी निपटाओ, और लोग हैं तो धीरे धीरे चलो। सर्जरी तो करनी है, सर्जरी तो वैसे भी करनी है ना पेशेंट की। इतने
सर
पेशेंट।
डॉक्टर प्रवीण सर इज नॉट हियर अभी हॉल में।
अच्छा, हु इज देयर? भार्गवी इज देयर और कौन है वहाँ?
सर आई जस्ट गो एंड चेक।
एक प्रवीण है वहाँ पे, हमारा जो स्टाफ है।
हाँ हाँ सर, वो अभी यहाँ पे है नहीं हॉल में। मैं एक बार चेक कर देता हूँ सर।
एक विवेक है, प्रवीण है, सब बाहर होंगे। देखो ब्रेकफास्ट की तरफ होंगे।
सर प्रवीण सर आ गया।
हाँ, ब्रेकफास्ट में होंगे यार।
मॉर्निंग सर।
हाँ भाई प्रवीण,
सर
ब्रेकफास्ट हो गया?
सर आई वाज गेटिंग माय टीम बैक। यस सर।
अच्छा, ओके। So we are going to start cochlear implant surgery,
यस सर।
and let's start with the final day today, Sunday,
यस सर।
and probably we will be doing 7-8 cases today.
ओके सर।
So let's start with cochlear implant, and तुम हमेशा कह रहे थे सर आप cochlear implant सिखाते नहीं हैं।
सर ये हमेशा कहते थे।
Now you have the opportunity that only teacher and student are there.
यस सर, दैट इज
ठीक
द
है,
बेस्ट थिंग।
अब मैं स्टेप बाय स्टेप तुम्हें सिखाने जा रहा हूँ।
100% सर।
ठीक है, enjoy the surgery.
थैंक यू सर।
Okay. तो checklist we had already gone through yesterday,
यस सर।
and CT scan। देखो जूम करो, ऑडियो विजुअल। एक मुझे कुछ पॉइंटर दे दो, कुछ इंस्ट्रूमेंट या कुछ दे दो, कोई चीज़ एक दे दो, फॉरसेप दे दो, कुछ दे दो, पेन दे दो, पेन दे दो। Okay. So you have the axial cuts here, Praveen.
यस सर।
Zoom in on this. Yeah. So this is a good cut which shows you the mastoid pneumatization,
यस सर।
which shows you a good middle ear,
यस सर।
which shows you the basal turn of the cochlea,
यस सर।
shows you the middle turn, apical turn, and it shows you the round window niche and shows you the round window membrane,
यस सर।
and it shows you that the niche has to be drilled if you want to reach the round window membrane.
यस सर।
ठीक है? So similar cuts if you see, so this is the most important cut. मैं एक cut ये देखता हूँ बस.
यस सर।
Rest of the cuts are okay. You can have a look, you can see them, but this is the most important cut. And similarly in coronal,
So any cut shows sir 2.5 cut turns of the cochlea, sir?
yeah. So if no, this cut is showing you 3 turns, no?
Yes sir.
Basal turn, middle turn, apical turn.
Okay sir.
क्योंकि ये बीच में देखो white दिख रहा है.
Yes sir.
That's the scala.
Okay
तो
sir.
तो you can see all the 3 turns in this only.
Okay sir. Okay.
But otherwise, if you want to see the coronal cuts, so you can see here. Again, you see the 3 turns.
Yes sir.
Okay. So this is the HRCT. MRI लगाओ. So कल कोई पूछ रहा था कि रेडियोलॉजी में MRI, डॉक्टर राजकुमार पूछ रहे थे
Yes sir.
कि is MRI necessary for cochlear implant? So it is the basic requirement for cochlear implant.
Yes sir.
If you don't do MRI, you can't do cochlear implant
Yes sir.
because you have to know that the nerve is intact,
Yes sir.
right? So the first step is the audiological workup. The second step is radiology. Radiology, we have the scan and the MRI. दूसरा लगा और कोई है नहीं और कोई है नहीं छोड़ दो ओके कैमरा zoom in here. So you see the lateral semicircular canal on the MRI?
Yes, sir.
And now we don't have that cut which shows the nerve exactly. Okay?
Yes, sir.
But you can make out somewhere here that this is the bifurcation of the nerve.
Yes, sir.
Okay? And then you have the sagittal cuts showing the four internal aortic canal, the four nerves.
Yes, sir.
But these cuts, I think we need more scans. अभी यहाँ पे scan और नहीं है. So we will, and then we go for the surgery. Yesterday, Dr. Raidu showed all of us a beautiful cochlear implant surgery.
Yes, sir.
Today we will show you different technique. He starts from the inferior part, we start from the superior part as we do.
Yes, sir.
Focus here. So this is the facial nerve monitor.
Okay, sir.
You have the electrodes over the orbicularis oculi and the orbicularis oris.
Yes, sir.
Okay, and then we can now test the facial nerve once we are reaching near it.
Okay.
So Medtronic's nerve monitor is an important tool to have, especially in cochlear implant surgery, and even lateral skull base surgery it is mandatory. Even mastoid surgery, if you have the facial nerve monitor, Praveen, it's a good thing.
So for beginner, it is a very important thing, sir.
Yeah, because it's an important thing, because it tells you the level of the facial nerve. So all these equipment, whether it is facial nerve monitor, whether it is the navigation system, these are all important.
Yes, sir.
Right?
So some word about Varia technique, sir. What is your hold on that, sir?
So Varia, when I started doing cochlear implant,
Yes, sir.
I did a few cases of Varia.
Yes, sir.
But then I shifted to posterior tympanotomy
Yes, sir.
because I have been mentored by Dr. J.M. Hans,
Yes, sir.
and he is a master of Varia.
Yes, sir.
So, but during my post-residency days, I was with Dr. Kirtane, and he got me convinced about the posterior tympanotomy technique, and so I shifted. Overall, my take is that posterior tympanotomy is done all over the world,
Yes, sir.
and it is a much safer technique, safer in the sense that for the patient, the implant is totally secluded. I feel in Varia, the implant is a little superficial, closer to the skin.
Yes, sir.
Electrodes, chalo, local lagao, start karo. We have to do it our way.
So that is, sir, we regularly revisit mastoid, sir.
Local
Going in
local
our
लगा
own area.
Local
doing
लगा दिया?
Tympanotomy is much
हाँ तो
easier,
इतनी
sir.
देर से कर क्या रहो? हाँ, प्रवीण?
So we are regular in mastoid, sir. So this area we visit regularly, sir. So going through the regular way, sir, is the better way, sir.
Correct.
sir.
So, and posterior tympanotomy, usually what you do is, you have the electrode safely in the mastoid cavity, the canal is absolutely away, So in my feeling, posterior tympanotomy in my hands
Yes, sir.
works better.
Yes, sir.
But then everybody has their own style of working, and some people follow Varia.
Yes, sir.
So it's okay. But out of almost 2000 cochlear implants that we have done,
Yes, sir.
I think we may have done 10 or 15 by Varia and rest are by posterior tympanotomy. Okay.
Yes, sir.
So that's the way it is. So now patient is under anesthesia. I'll just wash and come.
Yes, sir.
Okay. Local anesthesia, I think Dr. Raidu had taken us through. So
Yes,
we
sir.
will skip that
Okay, sir.
and we will straight away go to the incision.
Yes, sir.
Chashma. ऑडियो विजुअल ऑडियो विजुअल कहाँ है माइक ऑफ
स्टेपर फाइल नहीं ना वहाँ पे
नहीं नहीं अच्छा तो ये गाउन के अंदर रहेगा तो कोई प्रॉब्लम तो नहीं है ना ओके Dr. Praveen?
Yes, sir.
Okay. So the picture is clear?
Yes, sir. Very clear, sir.
Okay. So you have the now we use this drape. Yesterday Dr. Raidu was showing a different drape.
Yes, sir.
So it's all right as long as you have covered everything and it is sterilized,
Yes, sir.
you don't need to worry.
Yes, sir.
And all our instruments now go through ETO, so the sterility is quite good. So we have not seen any infection in the last 1,000 implants that we have done.
Yes, sir.
Initially we had few issues, but since then with the grace of God I think we are doing reasonably okay. So this is the post-oral groove.
Yes, sir.
We will give incision very near to it, and it is a small incision, 3.5 to 4 centimeters, just above the mastoid process. So it is very similar to the mastoid incision that we give for cochlear implants.
Okay,
Yesterday Dr. Raidu took this incision like this.
So lady S.
Yeah, the lazy S.
Yes.
So we don't do it.
Okay, sir.
We don't feel the need to do it now. We just do it like this. Okay?
The similar mastoid incision, sir.
It's smaller than the mastoid incision.
Okay, sir.
So, क्या हुआ? Okay, Prashant, the live link is working?
Yes, it's okay.
Huh?
Yes, it's working, sir.
Acha. So the live link is also working now.
Yes, sir.
So we are on the YouTube, and Prashant, if there is any chat, any question, you can
Yes.
just convey to me.
Yes, sir.
So this is the Cochlear company implant that we are using, and Prashant from Cochlear is already in the OT. We are using the facial monitor of Medtronics, and who is here from Medtronics? नाम क्या नीरज? Neeraj is here from Medtronics. Okay. Apurv, you have made any changes for the facial nerve monitor in terms of muscle relaxation? So the only thing with facial nerve monitor, Praveen, is that you have to the muscles, the muscle relaxants have to be off.
Yes, sir.
So what Dr. Apurv is saying, that as soon as we reach the mastoid, he will stop the muscle relaxants. The effect of the muscle relaxant would have worn off.
Yes, sir.
Okay.
Yes, sir.
So we are starting.
Yes, sir. So Dr. Ashish has joined us.
Okay. Welcome, Ashish.
Thank you, sir. Good morning, sir. Thank you.
Good morning. So we are starting with cochlear implant surgery,
Yes.
and so this is the incision that we use.
Okay.
So undermining just above the temporalis fascia, and then feeling the canal wall. So the idea is to just take this flap over the where the canal wall is there. So we have reached that. Then we undermine here also. So this idea is to create a flap. So you can use monopolar, bipolar till you open the implant. Once you open the implant, then monopolar is a complete no. But even if you can avoid the bipolar, it is always a good thing. So whatever bleeding is there, you have to control it.
Approximately how far behind the incision do you go in this undermining technique?
So undermining, I think, would be about roughly 2 centimeters,
Okay.
1.5 to 2. So you want a good flap here. So I think done with the bleeding a little bit here. Okay. So once we have done this, this incision I give with the cautery. So this is a vertical incision parallel to the canal wall.
Okay.
So this is one vertical limb, and then you turn it and you bring it like this. So one vertical and one horizontal here,
Okay.
and then you take it behind a little bit and bring this incision, cutting the temporalis muscle, and join it with this incision.
Okay.
So you have this incision like this, then vertical, and then this.
Okay.
So now you have a posterior based flap,
Okay.
which now is till the periosteum, and you can easily lift up the flap. You see how easily it comes,
Yes.
and it's a big flap now. You see?
Yeah.
So it's completely loose, and this has a little bit of muscle and rest of the tissue and fascia. So we are done with this. We elevate the temporalis muscle a little bit, and I like to see the canal because that gives us a fair idea where we are. So you can see this is the canal,
Mm-hmm.
spine of Henle.
Okay.
So I am happy with my exposure here and exposure for the mastoid. Now I'll just introduce my elevator behind and make a pocket. Acha, one thing Praveen, you would have noticed, we have not used any, ye kya hai? We have not used any, yesterday there was lot of marking, lot of
Yes, sir. Using
implants,
of templates.
and a lot of templates.
Yes, sir.
They are good for the beginners,
Yes, sir.
but later on, like we don't use it now.
Okay, sir.
So we know where I will just tell you last, when we reach the bone, the distance from the canal wall is important. So if that you have maintained, rest of the things follow. So I think we are good. We have made the well, and this is a Cochlear company electrode. So it has a ground electrode also. Tissue le lo. So first we will take tissue. Tissue is from the periosteum below the temporalis muscle. The picture is clear, Ashish, Praveen?
Yes, sir. Yes, sir.
Very good. So we have taken the tissue. The tissue is for sealing the cochleostomy opening later on.
Yes, sir.
So good. So we are good here, a little bit of ooze. There is always a ooze from the muscle and the periosteum. So, maaf karo. Make sure that you cauterize this area. Otherwise, it will keep on bleeding later on. Elevator. So now we will make. Yesterday, Dr. Raidu used the middle ear, the metal company implant, which does not have a ground electrode. So the ground electrode is inbuilt inside the same implant in metal and advanced bionics companies. While in the Cochlear company, you have a ground electrode that is separate. So we have made the pocket for the ground electrode under the temporalis muscle. We have made the pocket here for the implant for the well.
Yes, sir.
Now we are putting our mastoid retractors and we are going for cortical mastectomy. The initial steps are all over. So we go for cortical mastectomy, followed by posterior tympanotomy, followed by cochleostomy. Okay.
Yes, sir.
So looks good, Praveen?
Yeah, it looks good.
Simple.
Simple.
Anybody can do it? The answer is yes.
Probably after some practice.
That's sure. That's for sure. Skill wise, there is nothing much in cochlear implant except posterior tympanotomy. Sir, हमारी तरफ करो. Now turning of the head and turn और थोड़ा सा is the key in cochlear implant as is in mastoid surgery. Turning the head, keeping the position tight. चलो. Perfect. Done. So, what Dr. Raidu did yesterday was that he started from the mastoid tip
Yes.
and he cleared this area. Now you see I have not cleared this area.
Okay.
I don't want to go to the mastoid tip. So that is why every surgeon is different and every technique is different and you have to learn and master one technique and follow it. Kotri?
True.
As soon as I came today, my OT assistant was very impressed with Dr. Raidu कि सर ज़ाइलो कार्ड देते हैं कल उन्होंने दिया था ओके फॉर लोकल एनेस्थीसिया
Okay.
आई सेड नो जो करते आ रहे हो और जिसमें बढ़िया रिजल्ट्स हैं लेट्स कंटिन्यू विद इट लेट्स लर्न न्यू थिंग्स पॉन्डर अबाउट इट एंड देन डिसाइड वेदर यू वांट टू फॉलो इट और नॉट नथिंग ब्लाइंडली
That's
डॉक्टर
very
विजयेंद्र ये कहते हैं कि 25 साल 30 साल 35 साल से ये कर रहा हूँ एंड माई पेशेंट्स आर हैप्पी सो आई कंटिन्यू टू डू इट सो नाउ द डिफरेंस फ्रॉम yesterday is we are doing a typical mastoid behind the spine of inlay and we are trying to make the cavity. We are collecting bone dust. So yesterday there was no bone dust put. We put bone dust now. Initially I did not do, but then I saw somebody.
We lost the picture.
And as I was telling a little while ago, that you see new things, ponder about it, and then use them, follow them. You can hear me?
Yeah, we can hear you. The
You can
picture
hear me.
It's a bit of focusing. It's blurred.
The picture is a little blurred. Just a second. I was collecting the bone dust. Okay. ऊपर माइक्रोस्कोप लगा. Better now?
Not exactly. It's still blurred.
नहीं नहीं कैमरा कहाँ से ऑफ हो रहा है?
After every few seconds, we lose the picture and then it comes back. This is what is happening.
Just a second. They were changing the wire, the connectivity. Okay. Okay. What about the clarity now?
Bit better.
Bit better. Okay. Let's go through it. इसको tight करो. We'll wash. Maybe the bone dust is you're looking at the bone dust.
Okay.
Wash करो. Drill दो. कस के wash करो. हाँ. Is it better now?
We lost the picture again. Now,
क्या बात है भाई? Audio visual. कहाँ से कैमरा ऑफ हो रहा है?
no, the person who is holding the camera behind you needs to adjust his position because your hand comes in between while you are operating.
ऐसा क्यों हो रहा है? क्या चीज? अब आ रहा है? अब आ रहा है?
आ रहा है, आके चला गया.
नहीं तो ये हमारा थोड़ी हो रहा है. सामने मॉनिटर पे देखो. सामने मॉनिटर चलाओ. ये कल तो ये प्रॉब्लम नहीं हो रही थी. तो क्या प्रॉब्लम है? उसको निकाल के ठीक से लगा दो एक बार में. निकाल के बच्चे दोबारा लगा दो अच्छे से. बार बार प्रॉब्लम क्यों करे वो? We are sorting it out, Praveen. Just a second. नहीं ये इधर क्या आ रहा है और इधर क्या आ रहा है? ये आपका कैमरा है और वो माइक्रोस्कोपिक पिक्चर है, तो इतनी डार्क क्यों आ रही है माइक्रोस्कोपिक पिक्चर जबकि लाइट जल रही है?
नहीं तो मॉनिटर हमारा हल्का है ना सर, वहाँ अच्छी जाएगी।
अच्छा, कर लो तुम 2 मिनट ले लो बेटा, लेकिन ये प्रॉब्लम हमारी ख़त्म करो। Praveen, you can hear me?
Yes, sir. We can hear you, sir.
Okay, we are changing the wire.
Okay.
I think there was some wire problem. Now let us see if it. Okay, is the picture there now?
Picture is there, but clarity is not good.
Why clarity is not good? Yesterday though it was pretty good. क्या बात है, क्या चेंज हुआ है?
फोकस थोड़ा सा करिए, फाइन फोकस।
I think maybe magnification.
मैग्निफिकेशन कम करके देखिए।
Okay.
बट सर फोकस करिए सर।
इसका
One
fine
step
focus.
below magnification would be better.
One step below.
Yeah, this now we can see the entire thing.
And it is clear also?
It's clear but not a very good picture. If you have, do you use microscope drape? Sometimes the plastic of the microscope drape creates a problem.
क्या क्लियर हो गया? तो पहले क्लियर नहीं आ रहा था? क्यों? How is the picture now?
Now it's better.
So it was from the audio visual, I think.
Okay, now it's okay.
Now it's okay?
Yeah.
Okay. So we'll continue with the drilling. So this is the spine of Henle.
Okay.
So simple as you would do your mastoid, except the difference is that keep on thinning the posterior canal wall
Okay.
as you are proceeding. So this is a Metronics drill that I am using. Wonderful drill.
True.
These are wonderful equipment, and in the group some time back I had put a comment which Metronics did not like. Wash. But still they are sponsoring our event. So what I was trying to say was that Metronics is like Mercedes Benz. So you have lot of cars in your house and you have one Mercedes. So Mercedes is to be shown off and driven when you are taking your girlfriend, not your wife. Right?
Right.
Because it is high maintenance and very expensive. Each bits cost a lot of money.
True.
Maintenance costs are very high.
True.
So for a young budding surgeon, so the message is that if you can afford, go for the best, but keep other equipments as well as handy. So I have one Metronics and we have 3-4 more drills. So that is how the OT runs well. So if you are a high volume center, then you will need all this. So we know that the dura is somewhere here. So we are not going up. We don't need to, because you can see you have thinned out the canal. See the advantage of thinning of the canal right from the beginning. So you can see the short process of incus very clear.
Very clear.
Thinning of the canal wall. ऊपर ढीला करो. The picture is clear?
Yeah, it's clear.
Good. Wash. So simple step till now, and we change over to the diamond drill. Sikalia point of the. So for the junior resident, if he is awake early morning, so he can see. If he is not awake, then it's okay. No, I don't want it at my back. ये क्या है? नहीं नहीं, इसका बंद करो बेटा, पीछे पीछे मुझे नहीं चाहिए इतना. हाँ. So this is the short process of incus. This is the long process that is going down.
Yes.
You can see the facial nerve here,
Yes.
the horizontal segment, the lateral semicircular canal bulge.
Okay.
So you know the facial is coming here,
Yes.
right?
Yeah. Right.
Now what I have devised is that last year there were days when we were doing 4 to 5 implants a day.
Okay.
So the traditional teaching is that you delineate the facial nerve, delineate the chorda tympani, see the facial recess, then go in the posterior tympanotomy.
True.
ठीक.
Take.
So I have changed that, and what I say now is ऊपर थोड़ा ढीला करो माइक्रोस्कोप, थोड़ा सा focus better हो जाए. Right. So this is 10 times magnification,
Okay.
and now I know, looking at this picture, that my facial nerve will be coming here. So, and my posterior tympanotomy, the middle ear looks very wide here. So I don't need to go to the facial, na?
Yes.
See, the idea is not to go to the facial. The idea is to put the implant.
Agreed.
So what we'll do now is, we use the diamond drill to further thin out the posterior canal wall, and the thinning happens right in the line of the short process of incus.
Okay.
So this is safest.
Okay.
And then, as yesterday I was saying, and in the dissection also I keep saying it, keep repeating it, golden words by Dr. Kirtane, आधा ऊपर आधा नीचे. So the drilling should continue along the line of incus, आधा ऊपर आधा नीचे.
Okay.
I can guarantee that you will never hit the facial nerve.
Okay.
So what we do here is that we drill this area, smoothen this area, keep thinning this area along the line of incus.
Okay.
Now the traditional teaching is that you keep drilling till the facial nerve. I don't. I have thinned down this area. Now just behind the incus, I will go for my posterior tympanotomy.
Okay.
And I know I will be very, very safe. You see this? And in one go I have gone into the posterior tympanotomy.
What size burr are you
So
using?
quick. This is 2 mm.
Okay.
ठीक है? So now you have gone into the posterior tympanotomy in hardly few seconds. Okay, because you were sure. पानी डालो यार, तुम पानी नहीं डालो. So because you were sure of your landmarks. So you are getting it.
I got it.
Now you can widen it, and now you can go lower also. There is no problem. But all that stuff about spending so much time, like, see, I must have visited at least 100 cochlear implant centers all over the world in the last 25 years.
Okay.
And in Europe, especially Germany, they would take about 4.5 hours for one implant.
Okay.
They will delineate the facial nerve in about 1.5 hours, then chorda tympani, but that's the way they operate. There are standard protocols, they follow it. I don't say they are wrong, they are correct, but everybody has their own,
Priorities.
their own limitations, I would say, their own style of surgery. So what I am doing now is, I know that we are much away from the facial now. Wash karo. So I have made a decent opening of posterior tympanotomy now. Okay, and the facial is nowhere. Okay.
Yes.
Now I turn my microscope. Upadila. And what do you see? So this structure that you see is the promontory.
Okay.
Okay. Tight. So I know that this is the promontory, and I know just inferior
And posterior.
to the promontory would be the round window, and I want to see my stapedial tendon, and I want to see the incudostapedial joint. So a little bit of drilling in this area. पानी अच्छे से. रो कौन रहा है? तो अंदर क्यों ले आया उसको? अंदर क्यों ले आया? अच्छा. So I am still using the 2.2 mm burr,
Okay. You
And-
can see the round window.
and now section 22 इस हाथ में. Now if I just turn the head, you see the stapedial tendon and you see the incudostapedial joint. Can you see it? No. A little bit of blood is there. I'll just section it.
Probably some mucosa too.
Okay. Sickle.
Now it's visible.
Sickle needle. So a little bit of mucosa is there.
Yeah.
This is the incudostapedial joint,
Yes.
and this is the stapedial tendon.
Please reposition your microscope.
Okay.
The picture is not in the center. Yeah, now it's better. No, it has gone down. But it's okay, fine.
So you can still see it, no?
Yeah, we can see it.
Okay. So you can see the stapedial tendon. You can see the incudostapedial joint. If you want to see more, you can still drill this area and see a little bit more.
Okay.
है ना? And then क्या हुआ पर? All good?
All good.
नहीं नहीं ड्रिल आओ 18 सेक्शन और ड्रिल. Just for the sake of demonstration, I am spending a little time here.
Okay.
In routine surgery, I would have not done so.
Okay.
Because my idea is not to go superior, my idea is to go inferior. ऊपर ढीला करो सर. हाँ टाइट. Okay. Needle. That's the part of the mucosa, and you have the tendon here. Drill more. इससे छोटा लगा. So we'll switch to 1.5 mm burr now.
Okay.
A little smaller burr to just delineate the tendon and the incudostapedial joint. My round window is clear, but I am not going in that direction at the moment. Just trying to show you this area. Okay. I think it's clear now.
Yeah, it's very clear.
You can see the anterior crura of the stapes also.
Yeah, we can.
The posterior crura, everything clear.
Yes.
Sir, मेरी तरफ करो. Turn the head towards my side. And as soon as we turn the head, microscope.
That's around.
Yeah, so that's the round window niche. Tight. Good.
Good.
Okay. Can I have the facial nerve monitor? Probe. So we'll just test the monitor whether we are near the facial nerve or not. So Neeraj, should I touch it? Okay. So no stimulus here. No stimulus. No stimulus. So we are much away from the facial nerve. No? Okay. No? Okay. So we have tested with the facial nerve monitor that we are much away from the facial nerve. So that's a good thing. So Praveen or Ashish,
Yes, sir.
yeah, so you realized we are nowhere near the facial nerve.
Yes.
I have not delineated the facial nerve
Mm-hmm.
and still I am seeing the round window very well.
Yeah.
So my purpose is solved.
True.
So where is the point in going near the facial nerve, risking it?
Yes.
Okay.
Yes, agreed.
So now we use a 0.8 burr or a 1 mm burr, 1 mm. Round wala? So we are using a round burr, round diamond burr 1 mm
Okay.
to drill this round window niche.
Niche.
Okay. In the scan we had seen that it had a very prominent round window niche. So we know that we have to drill a little bit before we get to see the round window membrane. Bice. Now here the direction is important. This is promontory.
Okay.
The basal turn, the cochleostomy or the round window should be in this direction.
Okay.
If you go here, you will end up into trouble.
Okay.
The second thing to remember is that there are a lot of tunnels in the hypotympanum area.
Mm-hmm.
And there are people who put the implant in the hypotympanum
Yes, sir.
thinking that it is cochlea. There is a subcochlear tunnel in which sometimes people put the implant.
Okay.
The implants have gone into the carotid canal, into the eustachian tube. So I myself was guilty of putting it in the carotid canal once in an abnormal cochlea.
Okay.
So the anatomy was not clear at all. And I put it in the carotid canal. When we did the X-ray, we found it is inside. Then we had to take it out. So I am drilling little by little this area of the round window membrane. So round window niche is completely cleared. I can see a little bit of round window. I don't know whether you can make out.
It's
There's-
not very clear.
Yeah, there is a little bit of mucosa there. Okay.
You can see a glimpse of it now.
Yeah, ऊपर ढीला करो. Yeah. Can you see it?
Yes, we can.
So almost we are reaching it. Okay. Needle. Dexona. So this is the round window membrane.
Sir.
Can you see it?
Yes, sir.
Very clear. Okay. Dexona. डालो 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 भाई अंदर डालो हाँ बस. So we have put a little bit of Dexona there,
Yes, sir.
and with a needle we just open the round window membrane. Okay.
Okay, sir.
I think it is clearer now.
Yes, sir.
Because this is a complete hearing loss, profound hearing loss, so we are not doing it, and there is nothing to preserve in the residual hearing. So in the interest of showing you, I am just using a suction. Otherwise I would never use the suction near the opening. Okay.
Yes, sir.
So trying to show you the membrane, the opening. Is it clear?
Sir, very clear, sir.
Very clearly seen?
Yes, sir.
Okay. Now the idea is that this seems to be good enough, or you can drill a little bit of anterior lip, so that you are going into the scala tympani
Yes,
and
sir.
not in the scala vestibuli. 22. Vice. Class me. So we will be drilling a little bit of the anterior lip. Okay.
Sir, Dr. Pachauri sir is asking, sir, आपने section रखा है वो round window पे. It's fine.
हाँ नहीं वही मैंने अभी बोला.
Yes, sir.
अच्छा, you didn't hear what I said.
Yes, sir. Yes, sir. Yes, sir.
I said that I don't use the suction over the round window when I am going to preserve the residual hearing. But this child is a bilateral profound sensory hearing loss. There is no residual hearing. And in the interest of showing you the round window opening, I use the suction over it. Okay.
Yes, ji.
The idea was to show you this. So the idea is to show you this. This is the opening of the round window.
Yes, very clear.
Absolutely clear. So now you know you can easily go in, and this is the scala tympani that you are seeing. Tight. Now we will put steroid into it. The idea of putting steroids is that you want a potent anti-inflammatory inside, and then we pack with gel foams soaked in Dexona. Okay.
Yes, yes.
So what's the time, Praveen?
9:45.
9:45. Okay.
You can start other surgery. Which is the other one?
The other one is another cochlear implant, and then the mastoid surgery. One mastoid Dr. Chitranshi has to do.
He's there?
He is on the way.
As usual, lazy boy.
Huh?
As usual, lazy boy.
नहीं सर ने बहुत डांस किया कल, so he must be tired. So now our first steps of cortical mastectomy, posterior tympanotomy, cochleostomy are done. Now the most difficult steps are done. Now we go for the making of the well, as Dr. Raidu was saying yesterday. Now, I want to show the retractor. यहाँ रखो. Can you see this instrument?
Yes, Dr. Kirtanes.
This is Dr. Milind Kirtane's retractor, known as the K retractor, built by Kalelkar, made by Kalelkar. And this is such a wonderful instrument because it has reduced the size of the incision. Earlier the lazy S and the bigger S's were because you were not able to make the well. Now if you have the K retractor, you can make the well easily. So what we are doing now is tooth. So this was the flap that we had made.
Yes, posterior vest.
Yeah, this was the flap. Now we put our retractor into the pocket that we had made. See how beautifully it has gone in.
Yes.
And the moment you put it completely in and then you take it like this, now you see complete area, which we were never seeing beforehand. Okay? Section. Bada section.
How much you keep from the spinal family, this bed?
Yeah, so एक मिनट ये जरा retract करो, there is some bleeding. Okay, yeah.
Venus.
There is some bleeding from a venous. Either it's a imagery vein. You see this one. This is the one. So diamond bar. 2 mm से बड़ा वाला. So you encounter these imagery veins sometimes. Is not a problem. So you can just drill it. Okay. Gone. Okay. Now what we do is, so what we use, now we use the measurement. We don't measure in the beginning. Now the measurement is from the spine of Henle bleeding आ रही है कहीं. There is some bleeder which we have to see. Let me see. काट रही था. नहीं तो थोड़ा सा दो. I think it's in the flap. हाँ, touch. Touch. So while elevating this, sometimes you may encounter bleeding, not always. Touch. touch. हाँ बस हाँ touch बस ना touch pack. So almost stopped. I'll put a pack here. Patla pack then. And in the meanwhile, explain how do we measure. Okay. Retractor here. So this is the spine of Henle. We are measuring from here now, and we have to go 4.5 centimeters away from the spine of Henle. Got it?
Okay, that is the starting of that marking.
Yeah, so this would be 45-degree angle, and the distance from the center of the body of the implant will be 4.5 centimeters from spine of Henle.
Okay, that is a better one.
Yeah.
More.
So we now know where we want to place the implant, and we know that just by this measurement our outside BTE processor will be more than 1.5 centimeters away from the body of the implant, which is what we measure in the beginning. So beginning wala jo hai doesn't translate into the bone, so we have to have some other measurement, and this is what we do. So this is our center. This is 422. Goal wala hai? Haan. Right. So this is the 422 cochlear company implant, diamond drill, which has a round body. Okay. So a couple of bleeders here. There is one coming from here also. I think we need to address it a little bit. Okay. Okay, so this looks good. So this is 45-degree, this is the center, and so we will start somewhere from here. Okay, cutting.
This is 422.
Yeah, this is a 422 implant. So again we are collecting a little bit of bone dust. अभी अगर बच्चा उधर ले लें तो अंडर करा के तुम लोग सब रेडी करा लोगे वहाँ पे? हाँ अपूर, टेक द सेकंड चाइल्ड, थोड़ा सा हेल्प कर देना प्रिपरेशन में. पढ़ रहा है इसका मतलब नहीं पढ़ पा. अपूर यू विल हैव टू सी. अगर 1 घंटे से पढ़ रहा है तो okay, so this is the well. प्रवीण,
Done.
हाँ भाई प्रवीण,
Yes, sir.
गुरु आज जाने नहीं दूंगा,
Sir, I'm not going anywhere, sir.
है ना। आज के बाद तुम्हें शिकायत नहीं होगी कि कॉकलियर इम्प्लांट दिखाया नहीं,
Yes, sir. Yes, sir.
ठीक है। So this is how we are making the well.
Yes, sir.
We are near to the dura
Yes, sir.
and there is a bleeder here.
Yes, sir.
Okay, so nothing to worry in this area with the bleeders. Use the diamond bar. Diamond bar नहीं काम कर रहा, use a little bit of Sagicel. नहीं कर रहा cautery, नहीं कर रहा bone dust, नहीं कर रहा bone wax.
Yes, sir.
There is no bleeder that will remain all these 4-5 things.
Yes, sir.
So don't worry, even if the bleeder is like this. Okay. So you see, wash. Now I am making the edges a little better. Then we will measure how are we right with the size or not. I make this well a little bigger. Has my friend Dr. Sumesh Sharma woken up today morning, or is it a lazy Sunday morning for him?
Still waiting for him.
Huh?
I'm still waiting for him, sir. He's not in the hall.
उनके रूम में खटखटाओ, वहीं रूम में है,
Yes, sir.
उठाओ भाई उनको, उनसे कहो wake up. No, just joking. Let him come at his own pace. Okay. So you see,
Yes, sir.
this is the well that is right up to the dura. Can you see?
Yes, sir.
The bone is, you can move the bone.
Yes, sir.
So this is the island of the bone over the dura. And this is a little larger than the size that we needed, because we will be using the bone dust.
Yes, sir.
Okay?
Yes, sir.
So this I feel is quite good. So we have done with the well. Now this is the exit marker, where the exit array will come. So we mark the exit array. Huh? Which one? हाँ वो exit array फिर से दो. Prashant, keep telling. So this is the exit array. From the body, the exit array will come like this, and you want the exit array perfectly placed inside the bone. You don't want it jutting out. Okay?
Yes, sir. Yes, sir.
So I mark it with my section, and we go for the tunnel. So simply we start making the tunnel that will go up to the mastoid cavity. This we want a little wide and a little deep. This is our mastoid cavity. So this will keep on coming like this. And as Dr. Raidu was showing yesterday, he makes a tunnel. He taught me, Dr. Raidu is my teacher, he taught me how to make this tunnel. So see, the tunnel is already there.
Yes, sir.
Anna. But what I do is, I am not a good student, so now I don't follow him. I break this.
Sir.
And I make an opening here. Okay?
Yes, sir.
And I undermine these edges so that the implant will safely be here.
Okay, sir.
So the idea is keep learning and keep innovating. Diamond. So a little bit of bleeding in the tunnel and a little bit of ooze here. We will see from where it is coming. हाँ नहीं नहीं डाल दो नहीं नहीं डालो मतलब you have to make him ready now. We don't want to lose time. Okay. So just using the diamond drill to completely for complete hemostasis. And now I see wash. I see a little bit of blood still here. Wash. Wash again. कस के वॉश करना आता है अरविंद जी को. हाँ. Again wash. So we are just washing the whole area clean. Okay. So you see this is the well, this is the array, this is the tunnel coming into the mastoid. Now I'll check. I'll check my exit array will lie. See, it's lying beautifully. See it? So it's lying beautifully in. No problem there. Everything good. Except that bleeding is still not there so much. But you have to make sure before you open your implant. So because after that you don't want any use. So we'll try and figure out.
Dr. Rohit, can you tell the name of this retractor again, the one which is designed by Dr. Kirtane?
Dr. Kirtane named it the K retractor.
K retractor, okay.
So
And
it
it's
is.
with Kalelkar.
Yeah, now many people make it. So I think we are okay. एक double lock retractor या जर्नी दे दो कोई एक. So we'll just counter check with our bleeding because that is most important. You don't want any bleeding afterwards. It looks good. Looks good. So now we are all set. Tooth forceps. Wash. Wash again. So I have washed the area completely. That's important. Dry gauze piece. Again seeing if there is any bleeding, any issues. पैक वैक सब निकल गया था ना अरविंद? पैक निकल गया था. So looks good. Okay, Praveen. Good morning, Dr. Rajiv. Welcome. Dr. Rajiv is here in the OT. And so why don't we take Dr. Rajiv's case? तो बच्चे को ले ले फिर. we have 2 implants. So we can take a kit there. ये implant almost over है. So I'll start implant on that side. By that time we'll under your mustard and you can go for the mustard. Gauge piece. Yeah, Praveen, any questions from your side?
Presently, sir, everything is fine, sir. A good learning curve,
Okay.
sir.
So now we are through. We are ready for the implant now.
Yes, sir.
Okay. So a change of gloves is mandatory
Yes, sir.
before you go for the implant. एक पेयर ग्लव्स यहाँ दो 7.5. Implant. So, 1 minute. Show the implant. उल्टा करो. So that's the implant.
Yes, sir.
This is the cochlear company. हाँ तुम दिखा दो. So he is showing you. I was taking the microscope picture. I forgot there is a overhead camera also. So you see the implant. So this is the implant. We open this and this is the body of the implant with the magnet. You have the exit array coming here. Can you see it?
Yes, sir.
Is it clear with the overhead camera?
Sir, very clear.
Praveen?
Yes, sir. Clear, sir.
Okay. So there are 2 wires that are coming out. One is a ground electrode.
Yes, sir.
The other is the actual electrode.
Yes, sir.
This has a ballpoint tip. These are older implants. So this has a round body tip. Now you have a elongated tip.
Yes, sir.
The other is the main implant, which has, I'll show you under the microscope. Tight karo. So you see, ball point,
Yes, sir.
ground electrode.
Yes, sir.
This has 22 electrodes and it has 2 white markers and then it has a wing. You can see the wing,
No, sir. No, sir.
a little bit of flange.
Sir, it is out of focus, so we are not able to see. Yeah. Now it's clear.
Clear now?
Yes, sir.
Okay. So this is the cochlear company electrode, which is a 4 to 2 electrode.
Sir.
So 4 to 2 अब almost मतलब obsolete हो गया western world में, but government programs are still giving us this. This is a good implant, works well, but then you have the newer models now.
Yes, sir.
Okay. Overhead camera. Can you focus here, Sanjeev? यहाँ focus कर सकते हैं? Okay. So now I am putting the implant like this, goes in and goes into the well and the exit area that we have designated. Okay?
Yes, sir.
So the implant is well in place now. Now the ground electrode, catch hold of the ground electrode and it goes into the under the temporalis muscle the pocket that we had created here.
Yes,
Okay.
Sir. Yes, sir.
Prashant, is it coming on the live?
Yes, sir.
Coming well. Okay. Any particular chat or something? Nothing. Any questions? Okay. Fine. So the implant is in place. The ground electrode is in place. Now we are going to put the electrodes. Tight. Section. So we are removing the gel foam soaked in Dexona that we have put over our round window opening that we have created.
Yes, sir.
Now can you see the round window opening?
Yes, sir.
Is it clear?
Yes, sir.
See, this is the opening, huh?
Yes, sir.
Now I am reducing the magnification because then you can see the implant as well. So while putting the implant, we just catch hold of the flank and I am just using my fingers. Okay, no instrument to put the implant. And look at the direction of the implant. Can you see it?
Yes, sir.
Going in the scala tympani. Then I catch the flange with the EOS forceps. And we are just going slowly. Now hearing preservation says that you take 2 minutes. But as I said, these cases are bilateral profound. You don't need hearing preservation. You can go a little faster. And that is why Dr. Rajiv, I feel robot will take over here. Insertion will be robotic. Because as surgeons we don't have the patience to wait for 2-3 minutes when the implant is in our hand. And the insertion tool, by the time you will go and have a cup of coffee, the robot will take 5 minutes to put the implant. So, Praveen,
Yes, sir.
can you see the white marker here?
Yes, sir.
नहीं दिख रहा है तो बोलो यार.
Yes, sir. Yes, sir. Clearly see.
I am magnifying it. ढीला करो. Okay. Needle. So our implant is to the first marker, first white marker. Can you see this?
Yes, sir.
So this is complete insertion, all 22 electrodes are gone. But then here also I don't follow the rules. We put the implant, yes, further in. Because we have felt in our experience that the implant little bit comes out later on. So I'll put it further in, almost till the second marker. Okay, somewhere less than that.
Okay.
Now can you see the marker?
Yes, sir.
This marker is the second marker and it is at the cochleostomy or the round window niche border tissue. Now we will seal the opening with the soft tissue. That we had collected. बड़ा बड़ा है periosteum there. This sealing is very important. Tissue. Tissue. Gel form. Praveen, Rohit has come?
Good morning, sir.
Rohit Mishra.
Yes, sir. Good morning, sir.
अरे गुड मॉर्निंग, जल्दी आ गए?
Yes, sir.
तो तुमको तो ओटी में होना है।
जी सर.
अभी नहीं, we'll call you.
Okay, sir.
हाँ, gel form. So we have sealed it with the tissue, packed with the gel form. That's it.
जी sir.
So the electrode is in, it's fine, the implant is in. Now the last step is to fold the wire into the mastoid cavity.
जी sir.
Now this will go into the tunnel that we had made,
Yes, sir.
and simply curve it, and it goes into the tunnel that you have made.
Beautiful, sir.
So this remains there, this will not come out. Then we will put our bone dust. Now this I have started recently, I was not doing earlier.
Yes, sir.
There's a lot of debate on this, whether to put the bone dust or not.
What is the advantage of bone dust, sir?
Earlier people used to say don't put bone dust, it
Yes.
causes infection.
Okay.
Then I went to this center in Europe,
जी sir.
and they were using this bone dust for almost last 30-40 years, and they say this fixes the implant because we are not
Stitching the
because we are not stitching the implant, fixing the implant.
fixing the.
It is better that we put bone dust,
Yeah.
and it fixes the implant, and the implant will not move.
Bone dust have also osteoblastic activities, so it grows and fixes the implants.
Correct. And as I was discussing yesterday, day before yesterday, Dr. Rajiv, almost 2000 implants in our series, and we have not had a single migration. So I was talking to Dr. Muller, he fixes the implant, and Dr. Kirtane taught us never to fix the implant. He never fixes it. So I told Muller that we have not had any migration, and almost a series of 2000 implants in 10 years.
Yes, sir.
And he looked at me and said, wait another 10 years.
Okay, sir.
So 10 years is a short time for migration. So you need to wait and see how long this is going to take. Tooth for
Actually, this bone dust, if you put around the receiver stimulator and this part, it doesn't make miss. It is a good stabilizing agent. I think migration maybe issue later on, but you are never sure. Even with the stitching, you can get the migration because.
Is it Pachori?
Yes.
Oh, welcome. Yes, Rajiv, what I have realized is bone dust is a good thing, so I have started using it. Stitch.
We had a discussion, I think, last year. That time
Yeah.
you were not using it.
I was not using it, yes. I was not using it as I was skeptical whether we should use it or not.
In fact, a few people use that bone dust in the posterior tympanotomy also. But that is more, you can, sometimes you have to explant the implant, sometimes it will be difficult.
Correct.
But at this place, it is worth to use it.
Correct. So simple, the flap that we had made. So what I like about posterior tympanotomy, Rajiv, is that your implant and everything is safe in the mastoid.
Yes, that.
Nothing is in the canal. Nothing against Varia. The various people are doing well, the patients are doing well. but I feel it is closer to the skin somehow, and closer to the external aortic canal. So sometimes you may have external aortic canal cholesteatoma, or you may have issues there.
Sir, Dr. Rajan Bhargav sir arrived in the hall.
Oh, welcome, Dr. Rajan.
Good morning. Good morning.
Good morning, boss. Welcome. We have just finished one implant, and we are going to start the other one.
What about the radiology? You do means X-ray, on table X-ray or C-arm, anything?
Yeah, so on table we have a portable X-ray. So we will immediately do a X-ray, and we will also do NRT. NRT laga. So Prashant is here from Cochlear, and he will show us the NRT picture. Although with experience now, we know that when we have put the implant, we know all electrodes are in, we know everything is.
Just for
Yeah, but as a Rajiv, as a protocol, X-ray and NRT in every case. Every case. Cut.
And that is that never ask your assistant to do this step. You should do it yourself, whether or assistant or even the assistant surgeon, because you know exactly where that your electrodes are there. Sometimes they get a
Absolutely, absolutely. Agreed. First line closure you have to do.
yes, yes.
Skin, it's okay.
Seen two cases being reported, means where the stitches are around the electrodes.
छोड़ो नहीं लगा. इसको उठाओ नीचे से. फ्रेश ग्लव्स.
But while the NRT goes on, whether you are 100% sure, even then you have a feeling everything is fine or not.
Yeah, Rajiv?
Means when the NRT is on, even if you are 100% sure, even then you have a feeling that everything is sure or not, everything is in place or not.
Yeah, you have to check. You have to check because one, by protocol, protocols are there to protect you, and I was telling in the beginning that the implants have gone all over the place: subcochlear tunnel, hypotympanum, carotid canal, eustachian tube. So every place the implants have been put. So NRT and X-ray will guide you whether you have put it wrong or not. And I was telling them, Rajiv, I was guilty myself 2-3 years back putting it in the carotid canal in a very, very abnormal case. And it was done at a different hospital, so you are a little, and there was no X-ray, so on table X-ray. So we put the implant and there was a little bleeding, I thought, but it looked very good. And when I did the X-ray, I found it is in the carotid canal. So we had to take the patient again and then remove it. Okay. So NRT दिखाओ.
It's a good.
Camera focus.
Impedance is good.
Impedance are good. You can go for NRT, Prashant. Okay. क्या कर रहा है यार, इसको इधर से क्यों नहीं लगाता है?
Better than good.
हैं? 2 बार गिरा, ये तो अच्छी बात नहीं. लगाओ, चेंज हो ग्लव्स, फिर से दो. अब आप इधर से ले लीजिए और अपना हाथ यहाँ रख लीजिए. So impedances are fine. That has just fallen off. We'll put it again and show you the NRT. Open circuits are not a problem because many times you have blood clot or something
Bubbles.
around the electrode, and later on it will be all right. Short circuits are bad. I have never seen a short circuit. Have you, Rajiv?
Never.
Short circuits we have not seen. Open circuits, yes. ठीक से तुम्हारा चिपक नहीं रहा है तो अच्छे से इसको लगा के और उधर से ले लो, इधर से ले लो, ब्रिंग इट फ्रॉम हियर, हाँ इधर से ले आओ और अच्छे से चिपकाओ पहले उसको, अच्छे से चिपकाओ, आगे ठीक, ड्राई मॉप, so you see Rajiv,
Yes, yes.
the closure is absolutely fine, everything is under the two layers. So posterior base flaps, some people use superior base, some people use anterior base, all are good.
All are good. All are good.
As long as the flap is covering the implant, everything is good.
That is okay on 22nd. So means all electrodes are in. That's
Yeah, what is the NRT showing?
20 and 2 and 1.
Oh, so all are good.
All are good.
So both are in. So for the people who don't understand this, so what you are seeing on the screen is 22 electrodes, 1 to 22, and this is checking each electrode. So checking means that it is giving signals and the brain is catching it. So that means your cochlear nerve is good, your auditory pathway is good. So you are checking for the entire auditory pathway. And so you check the 22 first and 1 last, and if both are there then it is fine. So now it will keep on checking every electrode.
Yes, yes, almost 22.
So I think we are fine. We'll go for the X-ray now. Rajiv, I have got a portable X-ray unit here. उसमें क्या है कि it cost me 80,000 rupees, and you can wheel it in, do the X-ray, and then the plate you can send to your diagnostic center across the road,
Okay.
or wherever. So I am fortunate that I have my own diagnostic center. So owned by the Home Ministry, and so I send the plate quickly, and they know that they have to give the X-ray. They send the X-ray on our mobile in 10 minutes. So that is how it is done.
Just show us the X-ray machine. Which how?
Yeah, chalo X-ray karo. Wheel the X-ray in.
This is the confidence.
The file. Next child.
Next case, what you're doing?
Next case is another cochlear implant, Rajiv.
Okay.
I thought we'll quickly do 2 implants, and then Dr. Rajiv Chitranshi will show you a good mastoid. CSM with central perforation, his technique, how he does it. Rohit Mishra in the audience?
Yes, yes, he.
Dr. Rohit Mishra की डिमांड पे है ये.
Sir, good morning. Sir, we would like to go for the presentation by Dr. Rajan Bhargav in memory of Dr. Subhash Garg, sir.
So you want to
Lecture.
start now?
Yes, sir.
Okay. So 10:30 हो गया क्या?
Yes, sir. It is.
Exactly 10:30.
Yes, sir.
Perfect. Then you go for the. Can you see the X-ray machine, Rajiv?
We can see very clearly. This is 80,000 only.
Yeah. So देखो, see, Arvind, हटो एक मिनट. So this has wheels, and this has a X-ray machine. You just put it here and you take it. इसमें plate लगी हुई है इसके
Okay.
नीचे.
Hmm.
So you just take out that plate,
Okay,
and
good.
then you send to the developer.
That's good. That's good.
हाँ. So this is a good thing. ये Elangers की है. Okay, Rajiv.
Yes.
You can go for the Dr. Subhash Garg Memorial Lecture, and there are some photographs with the audio visual of Dr. Garg sent by his daughter. So can you put them on the screen? Dr. Rajan, are you there?
Yes, sir.
Yeah, I think who's got those AV?
Sir, they were given them. There's
X हो गया? हैं?
Sir, Dr. Rajan Bhargav, sir. Sir, we welcome you, sir. Sir, few words for Dr. Subhash Garg, sir. Please. Ready? Was chairing this session, sir, Dr. Sanjeev, sir. Please. Sorry, sir. And sir, Verma, sir, please, for chair this. For paperwork and photograph के लिए sir आइए वो photograph है भैया प्ले करो
थैंक यू तो वो प्रवीण वो एवी आपको प्ले करना था पहले
हाँ सर वो एवी करे आपके पास है
नहीं
किसके पास है एवी किसके पास है फोटोग्राफ किसके पास है
थैंक यू
फोटोग्राफ पे करीब है क्या प्रॉब्लम सर
थैंक यू शुड आई Good morning, everybody. My special thanks to the organizers for giving me an opportunity to share my thoughts. But more importantly, I think there is a somber moment of remembering Dr. Subhash Garg, who was my very, very special person, a friend, colleague, guide, mentor for over 20 years. We worked together in the same hospital, part of the team. So his passing away left a huge void, and it's very difficult to fill. Many times we still remember his anecdotes, his jokes, his way of doing things. But more importantly, I think if there are some junior colleagues and friends, his people-centric and patient-centric approach, I think, which is lacking many a times nowadays that I get to see. But his patient-centric approach, he would do the best for his patients. He would at least try the best. He had no hesitation in seeking help in case the patient was getting benefited, and that's a greatness of that person, that he had no problems and he used to be happy at everybody else's achievements, which is a difficult trait for most of the people. So his ability to be enthusiastic if you do well was very infectious, and hopefully we carry the same legacy in our department. Now we have 4 ENT surgeons with us. So it's just that we still miss him, and endless cups of teas and coffees after the theater with him. So it was a great moment for me to come over and share my thoughts. That appears to be of secondary importance. More importantly, I get to remember Dr. Garg. So I'm so happy that this has been labeled as a Dr. Subhash Garg Memorial Talk, and I'm still in touch with his daughter Ritu and Gitu, who are both lovely people in Pune. He has left a very wonderful and a loving family. So with due regards to him, a great soul, I would start my talk, which is which was possibly on skull base surgery, but I'm going to limit myself to anterior skull base just now. And I just hope that all of you who are juniors try and emulate to become 360-degree surgeons. So don't limit yourself to any specific area. Go all out and become 360-degree surgeons, which means you take care of anterior skull base and you also take care of lateral skull base, which is an essential part. So if you don't do it, somebody else would take it up. If you don't do it, or ENT surgeons don't do it, other specialties will take it up. So put in the effort to become skull base surgeons. And what do I do when I label something as anterior skull base surgery? My area of work, which goes back a couple of decades now, I remember the first time when I started doing pituitary surgery. I think Rajiv must be knowing that also. Rajiv Pachori is there as a chairperson. I think the first time we started doing pituitary surgery, our understanding of the anatomy was not that great. And you will not believe that I used to use C-arm in the OT to just check whether we are in the sphenoid sinus or not. That was the level of confidence that we had, and we grew from there. So we took our baby steps, started doing, and we were lucky that the first couple of pituitaries that we did were people who had pituitary apoplexy. So the moment you opened up the pituitary and they opened the dura, everything used to flow out, the patients used to get better, their vision used to improve, and we used to get a huge pat on our back that we have done a wonderful job, unknowingly that these were easy cases to do, and there were very, very bigger challenges more to come later on in our life. So this was a great learning for last 15, 17 years, and a span of over 200 pituitary cases that we have done. So what do I do when I label something as anterior skull base surgery? Is CSF leaks, pituitary tumors, sometimes beyond pituitary, which are not very many, but occasionally we are happy to do a meningioma, a chordoma, a sinonasal pathologies, malignancies with intracranial extensions as CFRs, endonasal CFRs. So this is the kind of work that we do, and we are happy to present. So why do I do it? It value adds to whatever we are doing. So beyond doing your tympanoplasties, mastectomies, try and do more than that. It's professionally very satisfying. It expands your surgical horizons. and it is minimally invasive if you do anterior skull base or lateral skull base. Imagine doing a CSF leak by an open craniotomy approach vis-a-vis a transnasal approach. You can understand the kind of morbidity the patient has with a transnasal approach vis-a-vis an intracranial approach. So just look at it, and we are doing it so well now. We are doing it so well now that the referrals that I get maximally for doing CSF leaks are from neurosurgeons actually. So that's the kind of confidence that we have got into them, that we do it well enough, and they are sending their patients of CSF leaks to us that, why don't you close this leak? So this is the kind of thing that we should be inculcating in ourselves, the kind of confidence, the kind of building up exercise that people refer patients to us. So what is important is that you need to build up your equipment. You need to have good camera systems. You need to build up your skills, which comes when attending conferences like this, where you get to do cadaver dissections, where you get to see senior surgeons operating. So you build up your knowledge as well. And more importantly, evolve as a human being, evolve as a person, and do team building exercise. Not everything you can do very well. There will be people who will do it better. So get them into your team, build up your team, and then start doing these things. Because once you do things well, everybody is there with you. But once things go wrong, you are all alone. But in case you have a team, you have other shoulders to take on the responsibility. So it's very important that you do a team building exercise. So once we started having these things, now I have come from an era, a time when a standard endoscopic sinus surgery course, Rajiv, you would agree, was usually punctuated by questions that, sir, if you are doing an endoscopic sinus surgery, what would you do if you don't have a debrider? Now, do we get to hear these questions at all? Everybody has got a debrider. So times evolve. So what happens is, over a period of time, you get to see that we don't have these questions, that do you have a debrider, or because it is a done thing. Without a debrider, you won't be able to do a good surgery. So get your skills right. And how do you get your skills right? Do observations. Go to good centers. I'll be happy for anybody who wishes to come over, and if we are doing a good case, they can come and observe us. Whatever we do, good, bad, or whatever. Learn from cadaveric dissections. Attend good workshops. This is a great way to develop your skills. Get your anatomy correct. I think enough number of times this has been said that you need to get your anatomy correct. You get your understanding of endoscopic surgery very correct. Acquire enough skills to raise up your levels and go to the next step. So if you are a postgraduate or have completed your post-graduation, I think the way forwards will be to acquire your endoscopic skills to a level, do it for a couple of years, and then go on to skull-based surgeries. So until unless you get this kind of a frontal sinus with you, until unless you get this confidence that you're going to look at the frontal sinus like this, then without that, don't think about doing your drafts. So get your anatomy correct. Be very, very confident of that, and then you can go on to your drafts 1, 2, 3 or whatever. So this is the kind of exposure that you need to have when you do your ethmoidectomies and sphenoidectomies. Until unless you become confident that you know where your carotids are, where your optic nerve is, where is the recess. Without that, going into the skull base doesn't make sense. So get your bearings correct. You need to know where your optic nerve is. You need to know where carotids are, where your pituitary fossa is, and you need to clear up your ethmoids. Until unless you do that, you won't be able to do justice to anything more than that. Again, get your vascular anatomy correct. So untilness you are very sure of your anterior and your posterior ethmoidals, doing transbasal procedures, impossible, impossible. So get your bearings on your anterior ethmoidals or your posterior ethmoidals, your skull base, and then only you can go on to transdural procedures. So aim would be, Amin Kassam has labeled the whole category of skull base surgery, and the level 5 of skull base surgery is doing a transnasal aneurysmal clipping. So look at that. That is the kind of skill that one can look at. And if you dream high, nothing is impossible. So start dreaming, start working for that. So as I said, that evolve as human beings, become better people, and get your team building. You can't do everything on your own. Get your neurosurgeons, your radiologist, your endocrinologist, anesthetist, ophthalmologist, whole group of people. Give them that kind of a respect that they do the best for you so that you can do the best for your patients. That is very, very important. You see, I don't want to preach here, but it is very important, and I have come through a long way, and I can actually write a book on complications, whatever I have faced. So I can really tell you that it's a journey that you have to follow. Your case selections are very important. Difficult cases only when you are confident. Problems can be catastrophic. This is a pituitary. This has been actually reported in an international journal. This was one of the pituitaries that we did, and this was a pituitary where it was a malignant pituitary. When we took it out, we did a subtotal resection followed by radiation, and this female actually ultimately passed away, and this has been reported as one of the rare cases in an European journal. But this is not the first case that one should be doing when one is venturing into pituitary surgery. This is not the first case. So do your pituitaries, but possibly this would be the most common lesion that you would get to see. It's because it's a very fairly direct approach, straightforward. This is the kind of lesion that you would like to do as one of your first cases. Straightforward. You end up opening up and the tumor is actually staring back at you. Just a coronal to see whether it is there. Pointer doge ek minute. Pointer. Thank you. So if one has to look at doing the pituitary, this is the sphenoidal ostium that one has to look at. And you would be surprised when you look at non-diseased sphenoid sinuses. Finding the ostium is not very difficult. It's all a game of good decongestion, a good preparation, and sphenoidal ostium is staring back at you. So this is very important. And this is just to show a cavity and a half approach. So if you are able to get your sphenoidal ostium correct, then putting a down bite forceps into your sphenoidal ostium, and it opens up the pituitary for you. So once you start observing people and you start doing things, it opens up a vista for you. And then going into the pituitary fossa is not very difficult. So what one has to look at is that if you are getting a good direct approach, then one of the key things that this intersphenoidal septum, I love to talk about this, never ever pluck this septum. Use your drills, use your skull-base drills, or if you don't have skull-base drills, then use even through cutting forceps. One third of our patients, we have actually kind of analyzed somewhat the radiology. 1/3 of our patients, the sphenoidal septum actually goes on to the carotids or to the optic nerve. So if you want to plug this out, you want to damage that area. So use sharp cutting instruments. This is very, very important. This comes with certain amount of experience, and so this is the kind of approach, and right up to the floor of these sphenoids, you should be able to see, and the tumor then stares back at you. And then its rest is all how you take out the tumor and you complete the resection and then reconstruct it. So most importantly, if you're going to avoid complications, once you take out the tumor and you are clean, you are happy with your surgery, then reconstructing your skull base defect is something that you will need to learn. So that is also very, very important. And that's where your workhorse, all of us who have gone through the works know that reconstruction of the defect is very, very important, and Hadad flaps are the workhorse. So if you know how to raise your Hadad flaps, if you can raise all kinds of Hadad flaps, the reverse or the otherwise flaps, then reconstruction of skull base defects becomes much easier. Reconstruction of CSF defects becomes much easier, and it's not very difficult. It's not very difficult because, and especially for ENT surgeons, Hadad flaps is second nature to us, because all of us raise these flaps when we do septal surgery. So Hadad flaps is very simple. It's just that the marking out and the kind of defect that we look at is something that we need to look into. And there are certain things that one has to look at, that they don't traumatize, they don't kind of tear the flap, so that you give a good repair. And I said that this is a journey. We have had our shares of setbacks. We have lost a few patients. We have had problems of hypopituitarism. We've had problems of SIADH. And we used to take help of endocrinologists. As I said, this is a team building exercise. And when you have a SIADH, then managing sodium potassium, I admit, as an ENT doctor, an ENT surgeon, when it comes to hyponatremias or all this, I am at all sea. And that's where my endocrinologist helps me, because in case I have this problem, then they can actually look into it and they can help me out and salvage the situation. So we have had all kinds of problems. We have reported also, and it is published, of how we traumatized the pituitary hypothalamic axis in one of our patients, becoming super confident and going beyond the pituitary, and we hit the pituitary hypothalamic axis. I think we hit one of the main vessels there, and we lost our patients. In this patient, we lost one of our patients because of excessive bleeding which went into the third ventricle, because we possibly hit the diaphragm and the blood flew into the third ventricle, where despite doing shunts and clearing out, we lost the patient. So we've had our own shares of problems. We've had people where we had to go back for controlling the bleed. We've had situations where we have had to go back to control a CSF leak. So as I said, that when you do things over and over again for years on end, it becomes a journey, and that journey teaches you. So each complication, rather than shirking away from it, rather than hiding from it, go and meet up people, talk to people who are very experienced, and tell them that this is what happened honestly, and get a feedback so that you don't repeat your mistakes. So for my junior colleagues, be upfront and honest about your problems, and unless you learn from your own mistakes, you will not go on to the learning path. So this is just another video, MR of the same thing, and the kind of bleed that we had was catastrophic. So my kind of learning, if you start this journey, avoid extremes of sizes, don't try paracellular extensions immediately, don't go for supracellular extensions, and in addition, please don't go in for functional tumors. Removal of functional tumors is not that easy, and they can be very messy and very fibrous. Thick pituitary floors, try and avoid, because you will be lost with the drilling. So these are things that I would really tell people who are starting this journey to avoid. My final bit of advice, all ENT surgeons, if they feel that they are skilled enough and have the interest, can do this kind of surgery, build up a team for successful outcomes, and be very, very confident about your anatomy before you undertake these things. With these words and my eternal thanks to the great soul, Dr. Garg, who gave me all the confidence to go ahead with all kinds of work and taking all risks, because he always had my back. So whenever things were bad or whenever I had to deal with a aggressive patient or relatives, he always used to be there with me. I will take care of that. You just do your work. That is the kind of senior I still miss, and I wish that I become even half of what he was. With these words, I'd like to thank all the organizers for giving me an opportunity. Thank you. I hope I am able to send you a good message, and maybe it makes a difference. Thank you.
Thank you so much, sir. I would like to request the moderators and Dr. Praveen Saxena, sir, to felicitate sir. Yeah, thank you so much everyone. Now we have the live surgery going on. Please connect to OT.
Hello, OT? Hello? Hello?
हमारी माइक्रोस्कोप की पिक्चर दो.
Sir, hello?
हेलो.
Sir, we are back to OT, sir. The presentation has been done by Dr. Rajan Bhargav, sir. It was a nice presentation, sir.
Praveen,
Yes, sir.
you can see the picture.
Yes, sir.
So we have completed cortical, thinning down the canal wall. Now this has a challenge. This patient has a slanting canal wall.
Yes, sir.
Okay. So that will deter us. इसे छोटा दो, छोटा cutting. How is the picture?
Good, sir.
Good.
Some focus is needed.
ऊपर ढीला कर. Better now?
No, sir.
So a little bit of focus issue, huh?
Yes, sir.
Audiovisual team? Is it from audiovisual side?
Picture is not sharp, sir.
Just a minute. इसका वो कहाँ है?
Better. No, no. फिर गड़बड़.
Better?
No, sir. अभी बीच में हाँ अब now better. Now better.
बढ़िया?
Yes, sir. Better.
नहीं, better कि बढ़िया?
बढ़िया.
बढ़िया. तो बढ़िया means that I stop, better means that I continue to correct it.
नो सर, स्टॉप कर दीजिए.
ठीक. ये तो रोहित की आवाज लग रही है.
जी सर.
तो क्या प्रोग्राम है? नाश्ता वाश्ता हो गया?
जी सर हो गया.
रोहित, we have lost them. डॉक्टर रोहित, ये माइक हट गया क्या?
हेलो डॉक्टर.
हेलो, कैन द हॉल हियर अस? डॉक्टर पचौरी, डॉक्टर प्रवीण.
हेलो.
हाँ रोहित.
यस सर.
हाँ, कैन यू हियर माई वॉइस?
यस नाउ सर.
Okay. So we had lost the connection.
यस सर.
What I was saying was कि नाश्ता वाश्ता कर लिया है तो ओटी में आ जाओ फिर.
ओके सर.
ठीक है,
जी सर, आई एम कमिंग.
आ जाओ.
ओके सर.
ओके. सिकल. फाइल चेक कर लो विथ साइड. अरविंद, कट फॉर सब. So again we are doing the same way. We have done cortical, and if any residents are watching,
So residents are there from UHM and GSM both, sir.
Sikil. Praveen?
So residents are there, sir. They are listening to you.
Okay. So for the residents, this is the short process of incus. This is short process of incus, and this is the facial nerve.
Yes.
This is the horizontal segment of the facial nerve. So this is the second genu, and the vertical part will come like this, and it will exit from the stylomastoid foramen. So we have this space. So that is why they say that facial nerve is much medial to the incus. So if your incus is there, you need not bother about the facial nerve. So once we have done our cortical, we have thinned down the canal wall, we will follow the short process of incus and drill like this.
Yes, sir.
We will never hit the facial nerve. And then again I keep repeating Dr. Kirtane's dictum, आधा ऊपर आधा नीचे. So short process of incus, this line, आधा ऊपर आधा नीचे, you will never go into the facial nerve. So I wish and I want every ENT surgeon in UP can do posterior tympanotomy. Because if you can do posterior tympanotomy, drill आओ, डायमंड लगाओ इसमें, बड़ा वाला जो posterior tympanotomy के बड़े वाले 2 mm. If you are well versed with posterior tympanotomy, believe me, you can do any ear surgery. Because then you have already mastered the facial nerve wash. So I have taken a large mastoid burr. My assistant has given me the bigger one, which I don't want, but I will use it for hemostasis, not for posterior tympanotomy. So I am drilling along the facial nerve. Posterior tympanotomy का जो बड़ा वाला है, एक सबसे छोटा है, एक बड़ा है, हैं? ऊपर ढीला करो. Okay. So, how is the picture now?
Better, sir. Better.
Clear?
Yes, sir.
Okay. 18 number. So, anybody who wants to learn posterior tympanotomy, simple steps, get this picture first. Getting this picture means that you have to thin down the canal wall. And then use a 2 mm bar here. So as I said, I am not going for the facial nerve. Why should I? Why should I search for the facial nerve? I have to put the implant. So I straight away go and do the posterior tympanotomy. हमें facial nerve और quadra tympani क्यों देखनी है? Half the time I see that in looking for the facial you cause facial paresis. In looking for the quadra tympani you pull the quadra tympani. So you don't need to do that. So this drilling is in the direction of the short process of incus. Simple. And then we just नहीं ये वाला तो डॉक्टर राजीव करना है ना अच्छा ओके 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 मैंने कहा रोहित मिश्रा आ गया हाँ एवरीबडी इज रोहित Okay. ढीला करो. Any questions from the audience? हाँ tight. So I am widening the posterior tympanotomy.
Yes, sir.
Trying to look for the stapedial tendon.
Sir, meanwhile, if doing posterior tympanotomy, if we bridge the posterior canal wall, so we can reconstruct with the cartilage or repair the posterior canal wall.
Your voice is a little. Say that again. You are talking of the posterior canal wall.
Yes, sir. If during this procedure, if we bridge the posterior canal wall, so
if you breach the posterior canal wall, one, never breach. Two, if you have breached, close it with bone dust and bone wax.
Okay, sir.
No problem. You can even cover it with a temporalis fascia.
Or
So
we can use cartilage, sir. Or if
or even yes, even cartilage yes. अगर बहुत ज़्यादा breach कर दिया तो cartilage use करना पड़ेगा.
Okay, sir.
लेकिन छोटा hole है, bone dust and bone wax.
Okay, sir.
अच्छा आप देखो now very quickly we have gone into the posterior tympanotomy. ठीक है, facial nerve हम नहीं देख रहे हैं. It is much below here. Now what we are doing? We are just enlarging our posterior tympanotomy to the extent that we can see the round window niche.
But posterior tympanotomy opening is how far away from the short process of incus?
Posterior tympanotomy opening is
How far away from the short process of incus?
so between the short process of incus and posterior tympanotomy there should be a very thin buttress.
Okay, around 2-3 millimeter.
Around 2 millimeters.
Okay.
and depending on where you find the round window membrane, a round window niche, you can even make it thinner, or you can have a large buttress. It will change according to the round window. See, your what you are doing surgery is that you want to see the round window. That is your aim. थोड़ा सा रमा इधर नहीं ओके माइक्रोस्कोप ढीला करो ओके व्हाट कैन यू सी नाउ व्हाट कैन यू सी
So stapes is seen, sir. Anterior curve and sir promontory.
And the stapedial tendon.
And stapedial tendon, sir. Yes, sir.
So for the juniors, this is the short process of incus. This is the head of the malleus. This is the stapes head. This is the incudostapedial joint. This is the stapedial tendon.
Yes, sir.
This is the anterior crura, posterior crura, and the pyramid.
Yes, sir.
This is the pyramid. The
Yes,
stapedial tendon comes from the neck of the stapes to the pyramid. And this is the facial nerve, the horizontal segment. If you can see it, this is the horizontal segment.
Yes, sir.
ये horizontal segment आगे आता है. So if you know this much of anatomy, I can tell you can do any ear case. सारी प्रॉब्लम इसी एरिया में है और सारा डर इसी एरिया का है. सर मेरी तरफ. Now I'll turn the head a little bit and tilt the microscope a little bit. Change of position of head, change in position of the chair of the surgeon, change of position of the microscope is most important when you are doing cochlear implant. ढीला. ढीला. हाँ. Okay. Now can you see the round window niche?
Yes, sir.
So I have done nothing, I have just changed the position of the head and of the microscope. This is the round window niche and this is the promontory. Round window membrane will be somewhere here. Cochleostomy. Now you can enlarge the posterior tympanotomy to gain more access. You can go to the facial nerve for more access. But with experience I know that this much is enough and I will be putting my implant easily. Now this is a 0.8 cylindrical burr. This is not a round burr. If you
Yes,
can
sir.
see, if you can see the burr.
Yes, sir. Yes, sir.
So this is a cylindrical 0.8 burr.
Okay, sir.
So this is a special burr for the round window niche and the surrounding areas. Dr. Abu? Dr. Abu? Dr. Abu?
So he is not in the.
Can you show the other case audiogram to the audience? Dikao. So on the other table we have taken up CSOM with central perforation.
Yes,
Patient
sir.
is already under anesthesia. As soon as Dr. Rajiv comes, he will start that case. We will shift to the other side.
Okay, sir.
Because you have already seen the implant.
Yes, sir.
Till then, you will have to bear with another one.
No, sir, we are enjoying.
Dr. Rajiv को एक mic दे दो. He can take them through the.
Sir, Sir, residents are asking which company burr you are using, the cylindrical one.
This cylindrical burr is a special burr which is, I think it is from Medal.
Okay, sir.
So now you have an interesting scenario that you don't see the round window membrane, or there is a little bit of atresia here. Okay?
Yes, sir.
This is a very common problem. Many times there is a little bit of fibrosis here, or there is some atresia, or you can't see the round window membrane, it is covered. So what I am doing is drilling the round window niche and then drilling for the round window. Dr. Pachori is there?
No, sir. No, sir.
Dr. Pachori, have you encountered this? I encounter it
He is
quite
not
often.
in the hall, sir.
Yeah?
अभी hall में नहीं है, sir.
Okay. So, as a cochlear implant surgeon, I can tell you we encounter this quite often.
Yes, sir.
That the round window membrane is either fibrosed or ossified. So then you have to drill the round window membrane area.
The next case. Hello. Hello.
So Dr. Abu Bakar, our fellow, will tell you about the other case. Can you hear his voice?
Hello.
Yes, sir. So you like to see
Patient-
the drilling part, sir, of the round window, first of all.
Hello. Patient Ria, 16-year female. The diagnosis is CS1 bilateral ear, having a discharge from.
So the voice is not coming clear, sir.
Hello.
So the voice is coming, sir, please hold the mic nearer to. Sir, voice ठीक से नहीं आ रही, sir.
22.
Hello. Ria, patient Ria, 16-year female patient, having a CS1 bilateral ear. Discharge.
Voice of Dr. Abu Bakr is not clear actually.
Are you able to hear me, Dr. Praveen, now?
A bit louder. Please, your mic near to your mouth.
Are you able to hear me now?
Yeah, now it is better.
Is it better?
Now it is better.
Okay. So you'll be hearing Dr. Abu now?
Yeah.
Steroid.
Hello. Patient Ria, 16-year female. Diagnosis is CS1 bilateral ear. Discharged both ears since childhood with decreased hearing since last 2 years. On examination of bilateral ear, having the large TM perforation. On Pionton audiometry. On the right side, 30 decibel hearing loss. On the left ear, 32.5 decibel hearing loss. Now I am showing Pionton audiogram.
Bas. Okay, you have shown. Okay, am I still on the screen?
Yeah, you are.
Praveen?
Yes, sir. Yes, sir.
You are still with me?
Yes, sir. Yes.
We are.
Microscope ढीला करो. Can you see the round window opening now?
Yeah.
Beautifully seen. So what I had to do in this, I had to drill through the round window. because the round window membrane area was ossified. Now there can be two reasons. One is round window atresia, which is congenital, or it got ossified during this period. And this is a situation which we see quite often.
Can it be seen on MRI prior to it?
It is difficult to make out on the MRI because round window area is the membrane is very thin, and even the ossification is very thin. If there is more ossification, yes, you can see it on the CT scan. So we are ready with our cochleostomy. Stapes, I'll go through the landmarks again. ये क्यों बंद कर दिया भाई? So going through the landmarks for the residents, short process of incus, facial nerve, lateral semicircular canal, stapedial tendon, pyramidal process, stapes, round window niche, round window opened, promontory. Chorda will be here, facial will be here. This is the chordofacial angle that you keep reading about, known as the facial recess. Sinus tympana area is below. Facial recess is above. Lateral semicircular canal is here, superior, posterior.
Can we have better focus of inside round window? Better focused.
Better focus. Actually, in the depth, sometimes the cameras. Better now? Is it focused or is it blurred?
Sir, little bit blurred, but it's okay. Fine focusing is required, sir.
Just tell me when to stop.
खराब हुआ सर अभी.
Better हो रहा?
Okay, sir. Okay, better.
Better.
Fine, sir.
बस ठीक है. So you can make out the anatomy very well.
Yes, sir.
And the opening is absolutely good. Now this opening should be between 0.8 and 1 mm.
Yes, sir.
Generally 0.8 opening is the best opening because 0.6 is the implant.
Yes, sir.
So I was using the 0.8 bar and I think this opening is about 1 mm.
Yes, sir.
So this is perfect for this implant because cochlear company implants, especially 422 and 522, even 622 and 632 are very easy to put. Gel foam. So we will put gel foam soaked in steroid.
So Dr. Kanajay sir has arrived in the hall, sir, and Dr. Sumit Sharma sir also.
Dr. Sumit Sharma and
Dr. Kanajay sir.
Oh, welcome to both. How is Dr. Kanojya's injury? He is fine?
Sir, I am giving the mic to her.
If he has come, then that means he is good. Dr. Kanojya, you are good?
No more injury, sir.
All settled?
All.
Chalo, bahut badhiya. Welcome. So, Dr. Sumit, welcome. Late morning. We have finished with one implant.
Yes, I know that. I saw it.
We are through the second one.
Yes.
So we have finished with cortical mastectomy, posterior tympanotomy and cochleostomy.
I've been sitting here for 40 minutes now.
Oh,
I've seen
great.
everything.
Great. I was asking you in the morning.
Okay. Wonderful surgery, dear.
Thank you, Sumit. Thank you. Dr. Sumit and I go a long way. We did our MS together in KGMC. The other musketeer was yesterday there, Sumit.
Yes.
Pankaj was there.
Yes, he left.
He left in the night. So it's good for both of them to come whenever I call.
Always.
Praveen, you have to see when you can put the lecture of Dr. Sumit. It will be a very good stuff for the residents. Dr. Sumit is a great academician, head of the department of Mayo Medical College, and is doing a wonderful work as editor of our journal.
Thank
After
you.
a long time, we are getting a good journal of ENT. I hope the juniors are listening. Get your registered so that you can get your journal. Section दगा. I'm bleeding हो रही. मोटा लगा. Touch. So this touch करो, कॉटी touch करो. नहीं आ रही. कॉटी ठीक करो बेटा. So whenever we lift the flap, sometimes we get this pack layer. Sometimes we get this bleeding. Not always. I think we were lucky to get it in both the cases today. But not in every case.
So the picture is not clear, sir. It is coming blood.
What is it showing?
So completely blood it is.
Completely blurred. Yes, just wait for a second. हाँ. 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 हाँ, बैक ला. Okay. Now is it clearer?
Yes, sir.
यहाँ retractor लगा बेटा. This is 4 to 2, 5 to 2. Same. Okay. कागज 2000. So forceps. So again we are measuring from the spine of Henle 45 and again going Laudrilla. So this would be my center. ऊपर ढीला करो. हाँ, done. So picture is clear?
Yes, sir.
Okay. So again the well. पानी डालो अंदर की तरफ, अंदर की तरफ, अंदर की तरफ. समझ में नहीं आता है ऐसे. बस. So we are collecting a little bit of bone dust more.
Yes, sir.
ये रिट्रैक्टर लगा. So the dura is very, very close. Can you see the dura?
Yes, sir.
Dura is very superficial. So this is a usual story. So you have to be careful. But the dura is, God is very kind to us. Dura is very, very thick. You cannot damage it unless you are very, very careless. So the idea is that you want to lower it to the dura. And if the dura is too superficial, then you want to expose the dura completely. See, I am still using the cutting bar, but then you have to learn how to control the cutting bar. Let me check. Check. Circular wala check. हाँ नहीं तो वीडियो अभी कनेक्ट नहीं करना. हाँ हाँ चेक चेक चेक. कई सारे हैं भाई. व्हाट इज द प्रॉब्लम अरविंद? क्या बात है? चेकिंग गेज. Okay, so checking gauge has come. Very good. Exit. We'll put the implant, then we'll shift. Cutting tunnel. अरविंद आप इधर आ सकते हैं? अच्छा ठीक है. हाँ उधर रेडी कर लो. उधर सब रेडी करा दो पहले. हाँ बस. नहीं आप स्टार्ट करिए ना. Whenever you want to shift, you can shift. As you are ready, you will shift. Boss, you are the boss. Whenever you want, you can shift. We will shift the screen and the mic. So again, we have made the tunnel.
Yes, sir.
And I don't make the bridge as I told you. I just undermine this area.
So any advantage of keeping the bridge?
Suction change. See, the advantage of bridge is that yesterday you saw Dr. Raidu putting the implant under the bridge.
Yes, sir. Yes,
so the alignment of the implant, the trajectory comes very good if you can do that.
Yes, sir.
Suction नहीं on है. तुम दोनों मिलके परेशान कर रहे हो. चलो. So under the bridge, the trajectory is very good. But if you are experienced, you don't need that bridge. Later on, you can make the bridge with the bone dust.
Okay, sir.
But for beginners, I feel that you have to use the bridge initially and then decide what is best in your hands.
Say, actually, the bridge was also helping the implant not to come out, extrude, because it was holding in the upper part.
So that we are doing with the bone dust, na?
Yes, sir.
यहाँ सक्शन बेटर मिल जाएगा. इसको खोलो. So Praveen,
Yes, sir.
Dr. Rajiv is ready with his case.
Yes, sir.
Whenever he will signal, we will shift the picture and the mic to Dr. Rajiv.
Okay, sir.
Okay, because I think implant we have already seen.
Yes, sir. Yes, sir.
So we want to see a good mastoid, central perforation in the hands of the master.
Yes, sir.
ये retractor लगा. So just drilling, making the pathway of the implant smoother.
Yes, sir.
Exit. Exit area. This is again blocked. So this is quite good. Coming into the tunnel very well. So we are through with the well, we are through with all the steps. We are just going to put the implant.
Yes, sir.
Easy, Praveen?
Yes, sir. Very easy, sir.
Rohit is here. रोहित उधर डॉक्टर राजीव रेडी है तो चलो हम इम्प्लांट डाल देते हैं फिर बस वॉश क्या हो रहा है यार खोलो So we are just washing the cavity and then we are going in for putting the implant. So washing it well, seeing that there is no bleeding because that is important. ड्राई गॉच पीस दो या निचोड़ के दो सो प्रवीण यू कैन सी
Yes, sir.
सो एवरीथिंग इज गुड ड्राई नाउ वी आर गोइंग इन फॉर द इम्प्लांट सो अगेन द चेंज ऑफ ग्लव्स एंड देन गो फॉर इम्प्लांट
So the next case is ready, sir. We are waiting for that also.
Yeah, next case is ready. Dr. Rajiv, being a good senior, is waiting and he wants me to put the implant, share that to you and then shift.
Okay, sir.
So again a change of gloves, and we ask for the implant. The implant is again the 422. So you have already seen the implant.
Yes, sir.
Can you see it?
Yes, sir. Yes, sir.
Okay. So we have placed the implant in the well. Now we are going for the ground electrode. They are all in a sheath. To take out the sheath, take the alligator forceps, catch it just behind the ball, take the temporalis muscle, इसको retract करो थोड़ा या छोड़ दो, कुछ मत करो, and put the ground electrode below the temporalis muscle. Once you have put the ground electrode, you are ready for the implant. Yes, now you can shift. So we will shift, Praveen. Dr. Rajiv is ready. Hello. Picture change हो गई?
Sir, there is a question from resident. The ground electrode, sir, is it needed to be fixed, sir? Fix करने की उसको जरूरत तो नहीं होती ना, sir?
No. नहीं, अभी रुक जाओ. No, Praveen.
Sir.
Hello.
Yes, sir. Yes, sir.
So ground electrode does not need to be fixed. You just put it below the temporalis muscle. No fixing of any of the electrode or any part of the implant.
Yes, sir.
It just needs to be in place which has been made for it, and
Yes,
it will stay there once you put it well.
Yes, sir.
Any other questions on this implant case? So then we can shift to Dr. Rajiv.
No, sir.
Okay, Dr. Rajiv is taking over.
Yes, sir.
Good morning, everybody. Namaskar. Praveen.
Good morning, sir.
हाँ, मेरी आवाज़ सुन रहे हो?
सर थोड़ा वॉइस सर लाइटर आ रही है सर, थोड़ा सा जोर से माइक थोड़ा पास.
देखो भैया, माइक पास करो जरा.
बस सर, इट्स फाइन सर.
Fine? Okay, very good. Namaskar, everybody. And very good morning. So you have watched 2 implants, wonderful surgeries done by Dr. Rohit. And are you getting the visuals now? Hello? Dr. Praveen?
Yes, sir.
Are you getting the visuals?
Yes, sir. Yes,
Okay.
sir.
So I am just cleaning the ear canal and will show you the total perforation. Is the picture clear to you?
Yeah. Yes, sir. We are getting.
Okay, okay. The cleaning of the ear canal is must, because if you have a very clear, clean ear canal, it is going to help you in getting good results. Can you see the handle of Malleus?
Yes, sir.
So it's a total perforation. थोड़ा पतला दो जरा. Section. It's a total perforation. You can see the promontory. Hi, yes. Now you can see the picture is clear. Hello?
Yes, sir.
Praveen?
We are seeing, sir.
Okay. So you have to clean the ear canal very thoroughly, initially with the betadine and then with your, because you are dealing with the infective pathology, so you have to make sure that things are clean. Okay? Now, okay. So I'll shift to external camera now to show you the incision. लगा दिया, लगा दिया. So you have to give an incision in the crease as far as possible, so that later on when somebody sees that you got, can I get the top light? This is more for the juniors and the residents to see that where you should give the incision, and see, you can see how I am using my knife to clear and expose the temporalis fascia. Okay? So now the fascia is exposed, and I'll harvest the graft. I don't infiltrate or push any saline under the fascia. See this? Scissors. This is the graft I have harvested, and will see with the help of a microscope. Can you see the graft? Hello?
Yes,
Yes, sir.
So your take on taking a dry graft versus a wet graft for tympanoplasty, sir?
This is just now the wet graft. I will make it dry.
Yes, sir.
And at the time of insertion, I'll see, because a little bit of fat or so you have to remove.
So generally,
इधर देखो. Okay? And then it's a good size graft. This is a piece of gel foam. I squeeze it over the graft, and then see this. See how you can spread the graft and this portion I am going to insert under the malleus so that it has become a little conical. Okay? Why I am doing under the microscope? Because I just don't want that any fat or muscle should be there on the temporalis fascia. Is it ready now? Okay. I'll take a flap. Pottery. Try not to take the muscle so that it's a bone deep flap and it goes up to the tip. Okay? I'll expose it up to the canal and you can see the spine of Henle. Okay? So your exposure has to be very good because unless until you expose the whole thing, it is very difficult to eliminate the disease. Small, chota wala kariye storage. To make sure that you are there, you just elevate the posterior canal wall a little bit. Give me a knife. And see how I make a incision in the posterior canal wall. It should be abutting the bone. Maaf karo. It is like this. I have entered the canal. Okay? So a good exposure टच करो touch. That's all. ड्रिल लगाई? बंदा कहाँ है ड्रिल वाला यार? बेटा इसको यहाँ नहीं लटका सकते क्या इसको? इसको हटा दो ना, इसको हटा दो। हाँ, शाबाश, वेरी गुड। इसका वो कहाँ है हमारा? बताओ। श्योर 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 हाँ 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 नहीं क्या फुट स्विच किधर है मेरा यार थोड़ा सा मदद कर दो बेटा जरा यहाँ पर आके फुट स्विच वगैरह लगवा दो मेरा हाँ ये वाला नहीं इसको हटा लो ये वाला हटा लो इस हमारी ड्रिल का फुट स्विच लगा दो है इधर रखो हमारे पास फुल कर दो इसको फुल कर दो ये क्या हो रहा है नहीं शिफ्ट कर डॉक्टर रोहित यू वांट टू से समथिंग ना वो बोलो शिफ्ट करा लो शिफ्ट करा
कराओ तो हम फटाक से बस 1 सेकंड बता के हेलो प्रवीण कैन यू हियर मी इन द हॉल
Yes, sir, we can hear you.
अच्छा स्क्रीन पे यू आर सीइंग माय दिस इम्प्लांट पिक्चर
Yes, sir.
Okay, I just wanted to show that this is the closure that this is the closure that we have achieved. Okay.
Yes, sir.
And this is the closure that we'll get.
Yes,
okay.
Sir. Yes, sir.
Okay. So this is a 4 centimeter incision, and this will get closed with a subcuticular suture, and that's it. So no lazy S and no S. Okay.
Yes, sir.
Okay. Back to Dr. Rajiv.
Thank you, sir.
Okay, sir.
Yeah. Okay. Thank you, Rohit. So, as you know with the anatomy, this area is safer. The moment you enter this area, you might encounter the dura or the sinus here. So, start drilling from here. See this. Okay? Go like this. And deepen deep चश्मा उतार ले यार मेरा चश्मा उतार ले मेरा you can deepen the cavity as you drill and don't put pressure on the drill. It should cut with ease and start drilling slowly, 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 and you can see the air cells. It is looking a sclerosed mastoid, but yes, slowly, slowly, when you drill out, so for the beginners, it will give you confidence if you keep yourself here and then slowly move out. Okay?
Sir, Dr. Kanodia here. Please explain the landmark for the cortical mastectomy because there is some resident.
I didn't hear the question. What happened? Dr. Kanodia, what happened?
Boss, for the benefit of the beginners, please explain the landmarks.
This is the zygomatic. This is the posterior canal wall. This is the middle fossa, posterior fossa, and this is the tip of the mastoid. Okay. So now this is the spine of Henle. Okay. You slowly, you keep on drilling. Now, if you can do a very good mastectomy, then only you can think of doing the more tedious surgeries, because a good mastectomy see, I'm now encountering the air cells. Funny. Never be in a hurry to drill the mastoid, because you might encounter sometimes the dura and the sinus. So slowly you see, you observe where you are drilling. वो एक कहावत है ना, सावधानी हटी और दुर्घटना घटी. So in each and every case you have to be very careful and try to be near the posterior canal wall. It is a safe area. Sometimes you get very contracted mastoids where you are not able to enter the antrum. See how I am slowly, and it should be wide mouth. It should not be a well-like thing. You see how I have drilled so that later on, when you are seeing the editors, you don't have any problems. Slowly you drill, peel off the bone. And never try to push pressure on the bone. It should be slow and steady. Okay? Now, when you start doing like this, see how I am going from inside and trying to open up the mastoid antrum. Slowly and steady. Watch my movements. This is more for the beginners and the juniors and the residents, how you have to expose the mastoid antrum. This is for the tip. Slowly, slowly, and wash कर दो. बस बस बस. When a diseased mastoid bone is there, you have to be extra careful that you might not get access to the landmarks. Now I will your policy should be that yes, everything is under your vision, so that you are not doing any harm to the patient. If you are vigilant, you will cause less complications. Now if you see here, I don't have to drill till the tip. A small area I will clear here. This is, I am reaching the mastoid tip area. This looks clean, so you don't have to drill out here. You can see the semicircular canals. Okay. Dr. Rohit has showed you beautiful dissection by cleaning this area. This is the posterior canal wall. Okay. Clear this area so that if there is any disease, if so you don't have to concentrate all the air cells. Now there it looks like there is no disease here. Now I will move towards the adductus and try to see the incus. things should be under your vision all the time, all the time. Find out. If you want to see the image of the incus, see, if I put water here, you can see the image of incus here. Can you see that? Hello? Praveen?
Yes, sir. Yes, sir.
Can you
Clearly seen. Clearly seen, sir.
See the image of incus here?
Yes, sir.
If you put water like this, you will see. It is just to ensure that you are now nearing the incus, and you have to be careful.
Yes, sir.
Because you have to preserve hearing here. Now see, I am already seeing the incus. Okay?
Yes, sir.
Can you see that now? Little bit of
Very
more
clear.
drilling here. That's all. So you have a clear additus now. A good exposure to the mastoid antrum. Cut. Another thing I want to point out that you have to clear this area. Definitely, if it is blocked, then you have to clear this area so that the additus is patent. I will like to go short pick. See what is all this? Mucosa. I have not touched the mucosa here. Can you see that?
Yes, sir.
So this will prevent the closure of this area later on after the surgery in due course of time, because sometime it is told that if you drill too much here and leave the bare bone, it might close later on. So I will clear this incus here. Suction. Now, why I am emphasizing that you have to clear this area also, in case you have to remove the incus, then you will not have enough space to remove it, because you are going to remove it from here. And if you don't have enough space, then it will be very difficult for you to take it out. And now this whole thing is clear for the aeration. Okay? And you see the movement? Hello?
Yes, sir.
See the movement? Good. So now bone work is almost complete. I will move towards the canal work now. Wash.
Good demo, boss. Raji boss, very good demonstration. Plus that, I think all are sitting here. Just see the mastoid mucosa is well intact.
Yeah.
There is no damage at all. That is the main point of doing mastectomy.
Yes,
You should not damage
yes.
the mucosa, and if it is damaged, then at least cover that area with. It is just like FAS, endoscopic surgery.
Yeah. Now I gave a circumferential incision in the canal.
So what about posterior canal wall thickening? It is little bit thickened. So
Yeah, it is
will you
thickened,
take
but
it out?
Yes, no. There is no point in taking out this.
No, posterior canal wall is skin.
This
Yes.
I'll show you. Wait a minute. Now I will take a circumferential incision hairline to the canal wall, okay, like this, and then like this.
So you have modified your original version.
I don't know. Now see,
Kitne sir used to do take a little bit down, means medial incision.
Yeah. Now you see how I will take out the canal wall. See the movement. The pressure is on the bone, and I am sucking it with a small suction. I take out the whole canal wall like this, slowly, slowly, going down.
You do all the cases in a GA or local?
I do 90% cases in local, only 10% in anesthesia, general anesthesia. Here we have general anesthesia because
this is a conference. Conference, I think better to do the local.
Yeah.
Any demonstration you should do with GA?
Now you see I am taking out the canal wall, and see, for the beginners this is very important to understand. You have to rub against the bone and keep on suctioning, and as I am emphasizing every time, things should be under vision. Where are you situated? So if you see this, I am slowly going down.
You do mastectomy in all the cases, boss?
100%. Because see, invariably, you might not get disease in every 100% cases, but yes, about 80 to 90% cases you do get some disease somewhere, and if you are left with that, then again there will be a discharge, there will be a recurrence or whatever it is.
Beeping ear.
Yeah, so see, we are working for the patient, not for ourselves. For the patient, a surgery is a big trauma. Psychological, physical.
Actually, many of us just open first see the middle ear, elevate the canal wall, see how is the editors. They do the patency. They do the patency. And suppose patency is very good, then they avoid it. So it is
This is what I am saying. If patency is not the only criteria to see that,
yes, sir,
because sometimes you do get disease in the attic, but if you push the water there, water will go. Or you have disease somewhere in the bone.
Your preoperative radiology, your preoperative X-ray,
see, all the investigations have their own limitations. When you go inside, then you see sometimes, yes, this is what, and it surprises you.
Pulse rate is high, I think. BP is little high because it is oozing. That is a little bit disadvantage of GA.
Yes.
And we are a bit casual while giving local anesthesia in canal wall, so that one more cause of the oozing. So what about, suppose like in this case, you cannot see your annulus very clearly.
Just now I am showing you.
So would you go for canaloplasty little bit?
I will see. Let me take out this canal wall, and then we'll see. So I am already there in the annulus. See this?
We can see.
No, you're not able. Okay, I'll show you.
So the concept of overlay, underlay, interlay, any changes means yeah, what you follow?
It is mixture of both. It is interlay. I take out the whole canal wall with the tympanic membrane and then put the graft over the annulus.
Over the, it is a mixed variant
Mixed,
of.
yeah. See this? I'm there on the annulus.
But sometimes we get a little bit granulations or not, means unhealthy middle ear because of sometimes unhealthy annulus. So what you do? You take.
Let me come to that point. I'll explain to you. So this is total circumferential clearance.
Yes.
Are you able to see or not?
Yeah, we can see. No problem. Focus is good.
जरा वॉश कर देगा ब्लड कुछ ज़्यादा ही दिख रहा बंद हो गया
That is the advantage of having in the local. We don't see any such oozing.
Yeah, that you're right, but while doing the demonstration, it is easier.
You can keep a little bit adrenaline soaked gauze or something.
That is okay. That is okay. Adrenaline soak है तुम्हारे पास? Yes. Now can you see the
annulus?
Annulus, है ना? The anterior part. इसका ऐसे रखो, बड़ा सिरा से रखो. हाँ, ये. Can you see that?
Yes, yes.
So the whole of the annulus is exposed now. Now I will drill this spinophilia a little bit. I don't want, but a little bit because it is hampering the. But as a landmark, it will be there. Suction. You should always try to preserve the landmarks as far as possible. Sickle ने भी लो दे जरा. Nice. That's it. See this, okay? So this is open now. So I have now reached the level of malleus. Okay?
Yes.
Okay? Now,
yes, elevated.
Elevated. The whole thing. Now I'll take a sickle knife and try to take out the whole thing. See the tympanous sclerosis.
Yes, temporal sclerosis. I
Can you
think
see that? Can you
yes.
appreciate the tympanous sclerosis here?
Very clearly.
This.
And
ऐसा कर, थोड़ा सा.
this is one of the commonest cause of graft failure.
Yes,
Suppose
yes,
you put
yes,
it-
yes. So that's why now I am clearing it. It's a big patch.
Hmm.
Can you see that?
Yes, yes.
Yes. Now. There's a big patch of tympanous sclerosis. I'm leaving it behind right now. I'll take it out separately. Okay?
Yes.
So I am just taking out the canal wall away from the annulus. So this is the dissection at the level of annulus. See this?
Yes, yes. There's one more technique is the TAE, total annulus excision.
Yeah, yes.
So that is on table decision. Suppose your annulus is not healthy, then you can take it out.
Yes, yes. This is what exposure is very important. And then when you see, when you expose the things then only you can see. That's why otherwise these investigations, they won't tell you how much things are bad there. Now how to take out the tympanic remnants from the malleus. For the juniors, you can see that I'm not hitting the bone hard. Slowly you have to dissect like this. Take out.
Even right angle, small right angle also helps at this level.
Yeah. It depends on how
bad is it?
which instrument you want to use. But see, I have taken it out now. Okay? So the whole canal wall is out.
Yes.
Okay?
Yes.
ऊपर कैमरा दिखा जरा, कैमरा ऊपर वाला, ये चलो छोड़ दो, ला मुझे दो. I'll show you how you fashion the canal wall. Rajiv, you were asking na that the whole posterior canal wall is so thick.
Yes.
This, I'll show you what to do. Now you see this, है ना? So this trimming will be done. Are you able to see?
Yeah, very clearly. This is Dr. Mahadevi technique actually. He used to do it. Means he used to take it out the canal wall. Dr.
Yes,
Mahadevi
yes.
and Dr. Evia Desai also.
Now this can also be trimmed down.
Yes.
Okay?
Yes.
Satisfied?
Yes. Boss is always right.
Salib. Clean. Cut फेंक दो. Now I'll take out this. I could have taken out this piece along with the canal wall.
Yes.
But just for the demonstration's sake, I am not going to take it out now. See this?
Yes, it's beautiful.
Come out. Now, give me the ball probe. I always try to put the ball probe to see the patency. Okay?
Yes.
So there is always some edematous mucosa or something is there, which is because when you put water inside with the pressure, it goes. But
It is a good way actually. We can use the cotton balls also, small cotton
yeah.
ball.
But again, if you leave the fibers there, you never know. So squeezing with the help of ball probe, you are not damaging the mucosa, but you are squeezing the fluid. Okay, na? So now the water test.
Not very good.
Okay. Eustachian tube. I always flush Eustachian tube. I'll show you the Eustachian tube opening. Can you see that?
Yes, yes.
2 cc, 2 cc. One of the causes for recurrence also is there is a small polyp somewhere, or when you flush, you see the pus coming out. So I always without fail try to. अरे सुनो, कहाँ गया? आदित्य, अनसेटिस कहाँ गए? अपूर कहाँ है? वीए में डाला हुआ ना, वो क्या पानी चला जाएगा. जब लोकल में करते हैं तो मरीज को बोल देते हैं भैया गले में पानी आएगा, खांस देना. पानी डालूंगा गले में. डालें? तब ठीक है. हाँ. पूछ लें भैया, नहीं तो अभी डांट लगा दूंगा मुझे. So how you do it? This is the cannula. You enter the cannula and don't push, and see where you can go easily. Yes. And you push the water there. It is clean. Okay. Now give me the ball probe. I tried always to squeeze the hypotempanum like this. So if there is any edematous mucosa which will cause problem later on, will be squeezed. Okay? So now the mucosa and everything, the mucosa over the promontory, and it looks good to me. Now I'll move to the chorda tympani.
Some patches are there.
Hello?
Some patches are there. Tympanosclerotic patches are there.
So to find out the chorda tympani now. I think this is the chorda, the white structure you are seeing
Yes,
here.
yes. What about the hearing, sir? Means how
Hearing
much
is about 30 decibel, 30 to 32 decibel loss is there.
AP gap is there. Then I
Yeah.
think vesicles must be fixed little bit.
Let me see that. First I will clear this and then yes, this is chorda. So yes, you have to separate it out and then clear the bone. Now give me the curette. Now It can be done with the help of a drill.
Curate is very good. Curate, small curate is.
Then I'll show you right now. It can be done by both methods. A drill can be put here, a small, slowly, like this. Okay? Yes. Now give me the curate also. I'll show you how to do it with the curate. Engage the curate like this. Separate the nerve and then away from the nerve. Suction to other. Wash करा दो. बस. So it should be away from the nerve so that you are not going to damage the. Is the picture clear or hello?
It's very good. It's very good.
Okay.
Not healthy, actually.
Give me the curve pick and I'll see how. Watch the यार जरा. मजा नहीं आ रहा इसको.
IS joint is gone, I think.
वो suction का मोटा.
In all the cases, we should see all the osteocases because we have to see the sinus tympani also. If you don't check the sinus tympani, you can find some, you can miss the granulations in that area. It is not, it's still not visualized. IS. Of course, we should do because there's 30-40 dB gap is significant. So we should expect something is wrong with the osteocases. Depends how much gap is there. Even suppose there is no gap, even we should see because sometimes part of temporal patch.
Now see the granulation tissue over the. Maybe it is a edematous mucosa and granulation tissue. Hello.
Yes, yes, yes.
So now I can see the incus.
Incus we can see the
IS joint is here.
Yes.
Okay. This.
Suppose we leave this part like this. Suppose we put a graft without seeing this. After 6 months or maybe a few months,
definitely,
we will start
definitely.
having some discharge from the ear because it will be a weeping ear actually.
Slowly, you have to clear the whole thing from here. See this? You have to be very gentle here because nerve is there.
It is just like a biofilm. We have to break this biofilm.
Yes. Now,
you can take it out. Respect the chorda. People say respect the chorda. Don't stretch it. If you are feeling uncomfortable, then cut it. Cutting is better than stretching.
Yeah. See, again, emphasis on that we are working for the patient.
Yes.
So whatever God has given you, respect that. If it is not possible, then it is fine. But that too, okay?
Yes.
So this is clear now. No, I'm not happy with this. I have to remove it. Yes.
Now antibiotic will work because you have broken down the.
Oh, there. WhatsApp.
Actually, success. People say, I have a 99% success rate, 95, 9. Success rate doesn't mean that your graft is at place.
Yes,
You
yes.
should have a patient who has dry ear forever. That is success rate.
Yeah.
Suppose even with us, means 1 out of 20 patients come with that we have a discharge from the ear. Means occasional like rainy season discharge. That is not a success. Something is being left inside that is creating problem. Not needed because I think incus is ossicles are intact.
Let me see. Watch it. Wherever you are in confusion, watch it.
Yes.
इतना पानी पिलाओ बैक्टीरिया को सालों को निमोनिया हो जाए.
साथ में फंगस भी लेके आएगी सर.
बस ला कट पे कर सक्शन मतलब.
Company is coming up with the debrider, medullary debrider. This 0.8 mm debrider blades are there.
Okay.
And for this mucosa like this, we can debride that part. And now we are becoming lazy actually. For the nose, I think you are when you were in at that time there was no debrider. So the debrider came in existence in 2002. Since then we have become lazy now. We don't want to take out every mucosa with maybe every part of the polyp with the debrider. So I think within 8-10 years, every bit of this mucosa we will take out. We will try to take out with the debrider.
Yes. Now for the juniors and the learners, see this. I have freed the malleus. It's absolutely clear. The incus is clear. And ischiodoccipital joint, IS joint is also clear. See this? And if I am moving, the whole assembly is moving freely. Okay? Now you have to be very gentle here when you show these movements because it is directly getting communicated to the cochlea. So this is fine. Now, again there is an inspection. If there is any disease process you are seeing, no tympanous sclerosis. We have cleared the eustachian tube. Wash. Any suggestions? Any questions?
Sir, in these long-standing cases, that malleus get medialized because it just either comes either very close to the promontory.
Okay.
So what you do is, like in this case, what you will going to do with the malleus?
See, again,
because suppose you put graft, right now the chance of graft getting adhered to the promontory or very close to the medullary space will be less. So what's the plan for the malleus right now?
No, I am not going to do anything for the malleus right now. It is, I will just lift it like this.
Lateralize.
Lift it like this and put the graft under the
malleus.
And I have not touched this mucosa.
Yes, yes.
So there is hardly a chance, and I'll only put the graft and show you how the graft will be tenting.
Yes,
so
cone of light, on table cone of light.
Yes. And this is very important to understand. With the graft, the tympanic membrane is at angle. So you cannot put graft here, somewhere here, no. It has to go on the annulus. You know, graft law.
When you do Malleus nibbing,
yes, if it is required and it is eroded, then I do. Now it is not looking like diseased here. See this? Oh, this. Good, it came out. See, if you see this, it is not looking diseased. So I will not do it here. My graft.
dried one.
Dried. It is not. I just squeezed with the help of a gel foam, and since then it is kept like that only. Make a incision here.
You can do one thing. Well, okay, that's a very good technique. One more, you can make a small hole in the drum and just tuck with the Malleus. That's one more option.
Yeah, that is also there. That is also there. Yes.
Oozing is there.
ये बेटा इसको बंद करो जरा.
हाँ, कॉटरी
करो. Now the placement of graft.
There are many studies regarding wet graft, dry graft. Again, no issue. Whatever you feel comfortable
means comfortable, and ultimately the dry graft will also become wet.
Yes. But it should not be crushed. It should not be crushed. It should not be kept for heat.
So see this. For the bigness also, it has gone inside under the Malleus head, and then you turn your curved pick like this, and then you can push it. And suppose it is not going in, there is a technique. You can put the suction like this. Lift the Malleus up, and then it will go in. Did you see that?
Yes.
Now I am putting it under the Malleus.
In spite of doing all these things, sometimes in very one out of 50 cases, 1 out of 100 cases, you get anterior superior small perforation or posterior superior. So we get
yes. That.
So just before finish, what we do we just put a small again part of that graft, because we just a small piece of cartilage under the head of Malleus. So that also work like a.
Yes, you can do that. You can do that. Now, the graft is there and it is lying on the annulus. See this.
Ideally, it should be a bloodless field, because sometimes what happens that the blood in between graft and canal wall
but
delay your healing.
Yeah, that is true. But see, okay. So the graft is on the annulus again. Another thing with this thing I have noticed that there cannot be any anterior retraction because the graft is lying here. Okay?
Yes, yes.
And I am seeing it, I am visualizing it where my graft is. It is not that is something I have done blindly. See, again I have tested that. Okay?
Yes.
Okay, fine. Now I'll put the skin. Now, many things you can do with the suction, which is helpful. Now, how to recognize which is anterior, which is posterior? So it is not very difficult here. See the hairline, and you know that this is the posterior part. And when you clear this, at that time you can see which things were, and this is the cartilage. A small portion of cartilage is there, which I am going to remove now. See, there is a look. This has to go in and this is out. Okay? Rajiv, do you have any?
Yes, sir.
Do you have any suggestions to recognize this? No.
Now we can see the hairs also on the external surface.
Yes. Now you have to be very careful here while you are putting this skin, because nothing should be embedded. If a small portion will be embedded, it will form the epithelial pearl. See how I did it. You have seen that? Now I'll show you again. Take a suction, hold it, and do it like this. See this. So, yes. And you have to push it down. Little bit of bleeding, that is hampering the. So where I did give the incision here. So this should snugly go here. Okay, like this. Now you have to see the whole circumference like this. Okay?
Praveen. Dr. Praveen. Praveen.
You have to squeeze it so that there is hardly any blood in, between the bone and the canal wall. Okay?
Yes, yes.
So again, I'll show you this. I have given the incision here, and the canal wall is now placed there only. Okay? Fine? Yes. Gel foam. Now I'll put the gel foam here. Now, I am not afraid that if I push little more, the graft is going to get medialized. It will not, because it is spread all over the canal. Okay? Yes. La.
Was and wonderful case, wonderful. So you don't keep anything in the middle here, any gel form?
Not at all, not at all.
Okay, that should not be.
Not at all. Because making a middle ear and then putting a graft and then over it, the skin is there.
Yes, yes, yes.
Okay? It's over now. Thank you very much.
Thank you, sir. All are, most of us are PGs here, na?
Yeah.
PGs.
Okay.
So we have few topics. One is how to improve result in your otology, nose, head and neck. All was I'm not talking to you. I'm talking to the whole. So we have this and osteoplasty also, head and neck. So we have half. Kitna time hai? So what you want to have is you want to fully anti head and neck, otology, or osteoplasty? बदमाश लोग हैं ओके ओके now because I have thanks.
Was you through?
Yeah.
Huh?
Yeah.
चलो.
नहीं
तो टमाटर बंद करो. फिर लोग ही नहीं वहाँ पर.
लोग हैं 40-50 पीपल हैं. कनौलिया साहब बैठे हैं.
अरे हंस रहा हूँ यार.
ये माइक ऑफ करो. क्या बात है, वहाँ जा क्यों नहीं रहा है? हेलो डॉक्टर पचौरी.
Hello.
हाँ डॉक्टर पचौरी.
Yes, yes, we are here.
Okay, so wonderful demonstration by Dr. Rajiv as usual.
Super demonstration, I think. One of the best.
And so now we are moving to a case of cholesteatoma, CSOM with cholesteatoma. So are you giving some presentation or we straight away shift to the other table?
Sir, there is a presentation on ossiculoplasty and moderators. I will be calling.
Presentation by?
Sir, Dr. Pachori, sir.
Acha,
on ossiculoplasty.
Ready, sir.
Sir, if the case is ready, we can take the case.
No, ask Dr. Pachori if he is presenting, he
Yes,
can.
yes, sir, he is presenting.
Praveen?
Yes, sir. We are ready with the presentation, sir. First.
Okay, so go ahead with the presentation. We are going ahead taking the graft.
Yes, sir.
And preparing the cortical, and then you can come back.
Yes, sir. Yes, sir.
Okay, done.
I would now like to request Dr. Sumit Sharma, sir, and Dr. Kanojia,
नहीं
sir,
चलने दो.
HOD, GSVM, sir,
हाँ, मेरा
GSVM Medical College, and Dr. Jagriti Kumar, ma'am, to come, sir, Dr. Jagriti Kumar, sir, to come on the stage as moderators. I would like to call Dr. Ajay, sir, on the stage as moderator.
it is not a presentation actually, it is just sharing of some surgical steps and videos, and it is time limit, there is nothing like time limit. So whenever you, Praveen, Dr. Praveen, just ask me to stop whenever you want. So it is just, one is this, how to improve results in your ENT surgery, ENT means overall. So in between we'll just discuss about the osteoplasty. Osteoplasty, I think it's a big subject actually. It will take at least, I have a 2 hours presentation. So since we have only half an hour, so I'll just discuss about the, or you want osteoplasty videos? Okay. Then go to, I will share the videos only because presentation is big. आ रहा है इसमें? So let's start with some basic. No, I don't need any details. So I have to just very common finding is when we do mastoid, like today's case. All the ossicles were intact, but in most of the cases we get a necrosis of your IS joint, and we get some space in between. And the grading of the space is very subjective. Sometimes, like it is very common finding, like this case. Why marker hai kya? Pointer. So like, here na? Yes, green. Okay. This is very common finding. And you feel very sometimes whether you should go with this thing, whether you should not go, because when you touch it, you get a positive movement. But think about the future, maybe after some time, just like this. This is very common, I think. One of the commonest finding when we get this disarticulation or the necrosis of this joint. What we should do? There are so many options for this thing. So there are so many options for this thing. And the second thing is second finding is that your necrosis is there and your incus is also short. So at this level there are many ways. One is that you take out your cartilage, either the tragal cartilage or conchal cartilage, part of the conchal cartilage, big piece, and put in between your stapes head and the incus. In this case, incus was short, and the one more option is that I am using this 70% preserved cartilage, this septal cartilage, since many years, almost 18-20 years, and till date no issue. So this is one more option you can use in your practice. So always keep those with compatible, then you can preserve these cartilages with you, and it is safe theoretically. And there are so many issues as per literature, but you can use it. This is a conchal cartilage taken from this, and it is there's almost 8 years. This patient is doing very well. Second is as same I discussed just now. One more case like this, where you can use the cartilage, make 2 holes in the cartilage. One goes into your incus and one hole on the stapes. Again, it is wonderful, and you can keep it, and the vascularity, everything. Again, 2 options. Either you can use your conchal cartilage and use the cauda for the support, for the stability, and for thing. Again, the same case. Actually, this is a, video. Actually, presentation is very long. Actually, I told you I use preserved cartilage. It is wonderful. You can manipulate it very well, and it is just like a semi-soft after doing the canal wall reconstruction. And this is your stapes. This is the cartilage, and the drilling part, the manipulation part, and the compatibility. The life is very good, and the length you can decide as per your. But it is good for keeping on the stapes, but not for any canal wall reconstruction, because the vascularity is an issue. So you cannot keep in the you cannot reconstruct the posterior canal wall or anything. But just for the osteoplasty, it is wonderful. And almost I think I have done 500, 600 cases of the record. On the record, maybe less. And till date, all are doing well, except 1 or 2 cases where we don't know well because of this ossicle or because of the infection, the issues that you can put on the stapes, you can put under the malleus. So that is one more option. But keep in mind that your graft, the flap, should be behind the ossicle. It should not be directly on the mid ossicles. So, and we get almost 20-15 decibel gap. That means this, I think because of it, we do in more than 30-40 decibel gap, but we get up to closer up to 10-15 decibel. That is, I think, one more option you can do in osteoplasty. When we don't have incus, when you don't have any stapes, when you don't have any malleus, one more option is that, I think one word is that boomerang. Boomerang is a term given by Satish Jain and that new generation of this thing. There are almost 20 varieties of boomerangs we have tried till now. Like in this case, the incus was missing, stapes was there, but your crura was not healthy. So I had to put, I cannot take, because you cannot take out the remaining part of the stapes from the foot plate because chances of avulsions. So you have to use that, you have to use that remaining stapes, and you have to put the graft, and you have to put the prosthesis over there, whatever cartilage you're using. So and how we do it, I will just show you another graft. We make a groove in the inferior or anterior canal wall. Keep one end of that cartilage in that groove, and I will show that in other videos. Make a L-shape cut in the cartilage. The one end side of mucosa should be intact, and try to put it on the foot plate. If your foot plate stapes is absent, even if it is present, then you can keep it either inferiorly or superior to it. And must check, just always check that round window reflex is present or not, and give support to these processes. But again, and the follow-up, I have observed that the gap, AB gap closure is not very good. It's around 20 decibel. So it is not very good. I mean, I'm not satisfied with this process because the contact area is not up to the mark, because that graft touches that longer part but doesn't go, the transfer doesn't go to the foot plate directly. So the AB gap is not very satisfactory, but it is good for revision cases where you don't have any other issue like that. This is the one more way. When we cannot, that is better option when you don't have any ossicles, all the ossicles are absent. This is a tent ossicoplasty. We don't make any L cut. We just make a soft cartilage, again attached to the inferior groove and directly on the foot plate. But keep in mind that it should not be very strict or very tight ossicoplasty, otherwise chances of foot and this foot plate displacements are there. And okay, this is a canal wall reconstruction, because it mostly we do in inside out mastectomy, and we have to reconstruct the because if the child, this patient is under 15 years old, then we have to we should not give a big cavity to the patient. Try to make canal reconstruction, and you can use a concha cartilage, but it should be, and your one side of mecoperineum should be intact, and you can reconstruct such type of case. That is again one more big topic on the canal wall reconstruction or combined approach. So this tent osteoplasty is doing very well. Almost we get a closure of almost 10 to 15 decibel. And like I told you that there is failure of the boomerangs. We do good reconstruction, but if your medullary ventilation is not good, if your post-operative infection part is not very good, then we get such picture. Everything is intact, patient is hearing well, not bad, but your graft is gone. So it was a post-surgery failure, and we get such cases. So whatever osteoplasty you do, if your medullary reconstruction means your post-operative care is not good, then you can get such cases. It is a healed osteoplasty. I told you that the first video, when we put graft and that cartilage on the stapes, and post-operative, the medullary ventilation was not good. Patient is okay 3 years post-op, but we are not satisfied because we are in the future it's going to create problem because of retraction. The AB gap is around 18 to 20 decibel. She is absolutely normal, but we know that after maybe a few years we have to revise this case because retraction will create problem. There is one more way of doing hinged osteoplasty. These are self-made terms. The MIS, all the things are absent, and there are many ways. Vertical strut, you can use vertical strut. I'm talking about the natural material. I'm not about the processes. Process is a different topic. In this case, we just took a small piece of cartilage, make a small hole in that, and we kept it on the foot plate. If you put any cartilage on the foot plate directly and in contact with the graft, chances of migration, chances of bending, chances of post-operative after 2-3 years, and that bending of do occurs. So just that small piece of cartilage was kept on the foot plate, and one more cartilage, just like a vertical strut, was kept on the foot plate. Will support. So that was a stable. It was a stable alliance, and it will not bend forward or downward or backward. It will stay like this forever. That is, if suppose until unless there is no proper medial ventilation or secondary infection. These cases do very well, and that is just physics, or you can say physics, or you can say just your anatomy should be well favorable for all these alignments. That is interposition osteoplasty. Interposition means I told you that when your stapes and your incus is not. In this case, I think 50% would not go for any reconstruction or osteoplasty. We have cement, I use bone cement, we have some adhesive material. But why to take chance? Because these are normal cases. You do operate after 4 years, 5 years, suppose there is a small perforation, a small discharge. Again, the patient will come to you with a hard of hearing because the necrosis part again will go off. Just put a small piece, and if you don't have anything, just take a small cartilage, make a hole, make a groove, and just put in between these two ossicles, and you can get a good vascularity also. Chances of getting good results are better than not doing anything. So it takes hardly 5 minutes to take a small cartilage and put over there. So these are interposition cartilage osteoplasty. These names are not written in the book, just made by ourselves and just for this thing. Modified boomerangs, because boomerangs, as I told you, we are not satisfied with the boomerang. So just same step, the one end in the inferior groove, a second end after making L shape on the foot plate. Again, the stability is not an issue, but results are not good. So we have to push something from above that should go on the foot plate and make a small, take a small cartilage and make a slit between on the other end, and one end you can keep on that L shape, and one end the slip with the slit in the posterior canal wall. So that will be a stable, and your posterior superior retraction, there will no posterior retraction later on. Hearing what, hardly there was a gap of 10 to 12 decibel, and the patient is doing very well since many years. This is almost 4-5 years old videos. These are the modified version of boomerang, and you can get a better results and more stability, and chances of proper conduction are there. This is actually these are videos. Actually, presentation is definitely there is a long presentation. This is double end. As I told you, that suppose you can take a cartilage also, preserved cartilage. Manipulation is better with this preserved cartilage. Again, same case where the incus was short, and one end in the stapes and one end on the incus, and supported by the cauda. And these thing is stable graft. Chances of necrosis are very less because small cartilage, preserved cartilage works very well. And again, the hearing is very. This is a fresh case, so I think hearing, but patient was satisfied because we do these cases under most of the cases are done under local anesthesia. So you can check hearing on table. Okay, the one interesting case was there where the facial was dehiscent, the incus was absent, and the stapes was there, lots of granulous tissue was there. In such case, you cannot put a big cartilage or on the stapes, chances of facial nerve compression are there, though it doesn't make a big difference. If you suppose your dehiscent facial nerve is compressed by any soft or any cartilage, doesn't make a facial paralysis, but why to take chance? Suppose in future some granulation tissue do happen. So in this case, facial was dehiscent, and what you will go for this? Either you can put graft, type 3 to plastic, you can put graft on the stapes intact stapes, hearing will be okay, but to get a better results, just carve your preserved cartilage, that one end, it's a bigger one, and the middle on the facial was a smaller one. So compression was enough, the rounded reflex was good without compressing the facial nerve. These are modifications you can try, you can do on table, nothing that is written on the books. So there's a facial dehiscent was there. Okay, and okay, Y cut. One more osteoplasty again. All are preserved. All are means concha cartilage or the thing. In this case, the stapes were intact, but crura was not very healthy. So chances of secondary necrosis were there. And suppose you put any cartilage or any processes on this, chances of migration, chances of secondary necrosis are there. So foot plate was intact, crura were not healthy. So just we made a small Y-shaped cut in that cartilage. Again, it was a tent osteoplasty. One end on the inferior groove, second on this thing. So from both the sides, it was pressing the foot plate and without damaging, chance of damage to the crura was not there. So these cases do well, and what else we do in this case? It was a radical cavity. Okay, so it was a modified radical case. So we just obliterated the cavity, put the graft over there, canal wall, the cavity obliteration was done. So these are cases we can do our modified radical or radical cases also, modified radical or in normal cases also. I'm not touching the processes part. These all are naturally done. Okay, again, small, because I'm just sharing this video because these are very common findings. Again, I think for more than 70% people will not go for anything. But you can use, there are so many options we have that we use that cement also in many cases. You have nothing, just put a small piece of perichondrium also, you can put a small piece of cartilage also, you can put a small piece of, even you can put your temporal fascia around it, and that will help it, that will give you proper analysis. But in this case, a small piece of cartilage was more than enough. And at least when you go home, then you feel comfortable that, okay, I have done something that good for the patient, and his hearing, his or her hearing would be better for the long term. Because secondary infection are very common. And these are the post-op picture in most of the cases. Like in this case, graft is there. This step is bypass osteoplasty. Maybe sometime I forget which case is this one. Okay, this was inside out, and it's nothing. All malleus incus stapes were there absent, and step is again very unstable. Kept a graft over there. We put graft first, then we do osteoplasty, and again small. It was the graft was that osteoplasty was put just inferior to the stapes, but in all the cases we just say even with slight pressure the round window reflex should be there. If you are not getting good round window reflex means you are not going to get good result in such cases. So whatever you do, just check round window. Again, one more technique. In which case, in this case, it was new, and we have published this, presented this somewhere, and we are just trying to get more than 15-20 cases for the publication. We have done almost 12 cases till now, 11 cases, and this just normal L shape cut was there, but we were not satisfied with the round window reflex. So we tried everything. We just, but again, and by mistake, this part was gone. Like the perichondrium was gone. So it was looking like an unstable cartilage, unstable alignment. So what we just made a small groove on the one side, and we took that part and stitched in a L-shaped manner with 80 proline, and though it looks easy here, but it was difficult to stitch that cartilage, and that cartilage, that L part was on the stapes. We made a hole in that stapes also. So now it was a stable assembly, and we have done 11 cases. I think 9 are in follow-up, 2 are not in follow-up. So let's see how they work. We are just checking how much AV gap is there. If it is satisfactory, then we'll share with, officially we'll share with you all probably. That suture was covered by the perichondrium. Again, the posterior canal reconstruction was done. So these cases are doing good, but see how much that whether there is a material, suture material does any effect on this, and that we are just checking it. Again, 10 osteoplasty with different angle. Tent you have to see with slight pressure, the round window reflex would be there. But if the pressure is high, suppose you have to check on the table whether it is very tight or not. Suppose if it is tight, then you have to take it out. Otherwise it will create problem later on. Unnamed, I don't know why it is unnamed. I will share one more video which was done yesterday. Okay. Sometimes we get my patient see conductive deafness without any evidence of otosclerosis, and tympanic membranes we see intact, and that is the exploratory tympanotomy. We find what exactly could be the cause. CT scan doesn't show anything. And those cases, again the same thing. The incus was necrose, it was lateralized, and so why it is unnamed? I will check it. Why it is unnamed? Again, we just took a cartilage, and again 2 holes on both the ends, and we cannot give any name to this. That's why it is unnamed. And it is actually just craft work, nothing. Like a craftsman does the same thing you can do on the table. And these alignments do work very well, provided your material is good, provided your post-operative care is good. Because we do care in the form of post-operative antibiotic, and we give some sort of subcourse of steroid also in this case because of foreign body material, especially in this thing. And one thing was okay. One yesterday's case, where is gone? Yeah, this thing, okay. One case was there, it was again a modification, but the was not getting good alignment, good angle of that thing. So this is the inferior canal wall or anterior canal wall groove to hold the cartilage in that area. Again, the concave cartilage was taken, and it is not difficult to take it out. Just try not to damage the canal wall skin, and again the shape of the try to take it soft cartilage from the concave cartilage is very heavy, natural curve actually, so that is a good point. Again, you can try to take a bigger one, so at least you should have two pieces of the ossicle material. Suppose your one piece is gone wrong or something by mistake, and you just made a small groove in the posterior canal wall like this. So you have two ends, like one groove in the posterior canal wall or attic wall, you can say attic wall. This is an attic wall, and this is about 1-2 millimeter groove. So one groove on the anterior canal wall, one is the attic wall, and nothing amiss. All the ossicles were absent. Again, L-shaped cartilage was put on, the boomerang was put over there, and that L-shaped cartilage, the angle, can be supported by this small piece attached or engaged in the posterior. So you have a good pressure, put a graft over there, and it should be entirely graft like Dr. Chitranji showed us today. We do different technique, so no problem. That is subjective. So after putting graft, taking the part of anterior inferior angle, and the one end is placed in that groove, the L-shaped part or on the foot plate. So suppose I stop here, chances of AB gap would be around 15-20 decibel, and with this pressure on the cartilage in between the L shape, like this thing. So have a good pressure, enough pressure, not good pressure, and one end is attached to the attic groove. So it is a stable assembly, and just check the round window reflex, even with minor, with just touch, and it is very stable assembly, and small touch you can see, you can appreciate that round window reflex. And these are the cases which give you very good result, stable as well as compatible with the hearing. So these are the cases we do, and boot shape, double support. Time हो गया बस? हाँ हो गया ना? Actually, these are there's one more actually. Again, if you have a steppies, again, but to give more stable assembly, you can put a single like vertical stud, or you can put a cartilage on the steppies foot plate. You can put the graft over there, but again the stability and the put gettable. Same thing, inferior groove was made, and the cartilage piece was kept between one groove was on the one side to hold the steppies head, one groove for the inferior wall to hold that, make the stable assembly, and one small groove was made on the cartilage. Though that now it is a stable assembly, but to give more stability, to get the more pressure, to get a better hearing result, a small cartilage piece was put between that groove on the steppies, and the slit was made on one end of the cartilage to cover the posterior. Now it is a stable, and you can see in such cases get 10 to 12 decibel gap only. These are the few assemblies, and that nothing is written in books. You can choose, you can decide on table. Keep your innovation on the table, and you can get so many assemblies. So nothing is written in books. Again, you can innovate at least 20 types, 20, 30 types of such osteoplasty from your own, you can name yourself. So the main purpose of sharing was just don't go directly to the processes, expensive processes. You have own so many processes in your conical cartilage. You can use tracheal cartilage. In radical cavity, we try to use tracheal cartilage because it is more stable and stable. So just few glimpses. We have osteoplasty means presentation of almost, I think there are almost 40 videos are there. But that is a different topic. It will take at least more than 1 hour. That's why I was asking for this thing. So I think time is over. More than enough time is over. Thank you very much for. Still few are left. Leave it. Thank you very much. We will permit for this category.
Very nice presentation, Dr. Rajiv. Very informative, and we encounter these problems daily, more or less daily. Especially the IS joint discontinuity or partial or complete discontinuity, and we saw at least 15 to 20 methods of correcting that situation. Thank you.
Sir, please wait. Thank you, sir. I would like to call Dr. Praveen Saxena, sir. I would request moderators to please felicitate sir with a token of appreciation.
Hello.
Presentation is finished.
Sir,
Hello.
back to OT, sir. Yeah, sir, you're on the screen, sir.
Yeah, Praveen.
Yes, sir.
Can you see?
Yes, sir.
So this is a case of cholesteatoma. So what we did was we have already taken the graft.
Sir.
We have done the cortical here, sickle.
Sir.
And if you see, नीडल दे दो, सिकल दे दो, कुछ दो, जल्दी दो. Okay, so just to orient you, this is a case of complete adhesive otitis media, and you can see the tympanic membrane adhered to the middle ear.
Yes, sir.
And the retraction pocket in cholesteatoma was coming here. This you can see it.
Yes, sir.
Correct?
Yes, sir.
So what we have done is, cortical has been done. Dr. Rohit Mishra is a expert graft taker, and he has taken a big graft for me.
Yes, sir.
And so we are going for canal wall down. Anyone in the audience who would do canal wall up in this?
So no words, sir. Everyone is in the favor. Canal all down.
Anybody wants to do canal wall up? So there is lot of debate between canal wall down and canal wall up, and this debate, Dr. Pachori is there?
Yes, I am here.
This debate is there for last 5 decades.
Canal wall up and down.
Up and down, and I don't think it will ever finish.
Never, never.
Now, Rajiv, there are 2 schools of thought. One is which says never do canal wall down, try and clean everything and go for canal wall up in almost all cases. There is one school of thought that says do canal wall down if you remove the incus, and if you have cholesteatoma. So I belong to the second school of thought, that we go for canal wall down, because our patients, several of them are from long distance, and like in the Western world, you can go for a check CT scan or a check MRI and see for residual disease. We don't have that luxury, and the patients there are ready for surgery whether you do 4, 5, 6 surgeries. That is not the case here. So here I feel, that has been my experience. Rajiv, you add to this, that if you have granulations, if you have canal cholesteatoma, you go for canal wall down and reconstruct your cavity.
Yes, that is the main thing.
So that is what we are going to do today. We will do a canal wall down and then reconstruct the cavity, a soft tissue reconstruction, using soft tissue as well as using temporalis muscle flap.
Actually, the concept of down or up depends on the how old is the patient, how skilled you are, because it depends, because suppose if you cannot take out even if you are leaving even 1 millimeter of some tag inside, that is going to recur. So your experience also, that how far his patient is from. Suppose this patient cannot come in follow up, then it is risky. And nowadays with the good concept of modification or modification in the mid cavity, the canal reconstruction, canal wall reconstruction, cavity obliteration, so many things are there. But I think we should not take any chance to leave the disease inside and ask for the second surgery or third surgery. So go for straightforward, go for modified radical, do the reconstruction, and you can give a very good cavity later on. Or you can give very good middle ear, or we can give very good ear without non-discharging ear forever. But don't take any chance, or just for the name that you are going to means maintain the canal wall. I will go with the canal wall up and I will do the surgery, because I think it is risky. If you are 100% sure that you can take out your disease, each and every bit of mucosa, each and every cholesteatoma, then go ahead. Otherwise, these granulation cases are not good actually. They do discharge later on also. So take out each and every part of the granulations and then do the reconstruction.
Okay, so for the juniors, when you are doing canal wall down, the only thing that you are worried of is the facial nerve sickle, which is actually much lower down. So make friends with the facial nerve, do temporal bone 100 times. If you do temporal bone 100 times, I can tell you, your fear of the facial will go away. The problem is we don't do temporal bone and we directly come to the patient, and then we are scared, and then we do half surgery. Panini. So the best way to learn otology is through dissection and through temporal bone. Only this is the way that you can learn. So I am using a larger burr, and we are drilling the superior canal, and you can see that we are almost near the dura. Now you can see the change of color, and this is the sinodural angle. So you want each and every cell to be removed. Unless you do that, your canal wall will continue to weep. So the best way to do canal wall is that you remove each and every cell. So keep following cell. Any questions, especially the residents? This surgery is for you. And Praveen? We have a very good case of bilateral otosclerosis, And Dr. Chitranshi has agreed to do steppies on the other table.
Great, sir.
So we are taking the other case on the other side. By the time we'll finish this, we will start the steppies case.
Okay, sir.
So I think whoever has taken time out on a Sunday gets to see 2 cochlear implants, followed by a CSM with central perforation, followed by CSM with cholesteatoma, followed by stapes, followed by a frontal sinus mass, where we'll use navigation and show you how the navigation works. And then we have a revision DCR and we have a mastoid.
It's a great, sir.
So that's the program for the day. Audience जल्दी थकेगी तो हम लोग रुकेंगे.
Sir, we are not giving them any break, sir.
हाँ?
They are enjoying, they are mesmerized.
बस till they are enjoying, till they are in the hall. जब प्रवीण अकेला बचेगा तब रुकेंगे हम लोग.
सर सब तब तो हम अकेले बचेंगे सर आपके साथ नहीं जाएंगे.
Now Dr. Rajiv has really enjoyed the response so much that he said नहीं steppies मैं करता हूँ.
Sir.
So that's good. So for the juniors, this is the dura, and you see the change of color here. So I have not opened the dura, but we have reached the dura. This side, almost all cells are gone. We are near the sigmoid. This is the sinodural angle. Then you see cholesteatoma coming in. So I am drilling the superior part a little bit more. Once we have created enough space, this is the lateral semicircular canal, and we are lowering the ridge. Now if you are obliterating, then don't lower the ridge right up to the facial canal. Stop a little bit above, because then you will be obliterating it. छोटा ऐसा. Okay, so now let us focus on what we have here. How is the focus, Praveen?
So fine, sir.
Okay.
Focus is
fine,
not
fine focus.
A little bit of fine focus.
Yes, sir.
Better or worse?
Better, sir. Better.
Better?
Yes, sir. Fine.
Fine?
Yes, sir.
Okay. 18 लगाओ. 18 लगाओ और साइड नाइफ. So this patient is under GA. There was a little discussion on GA and local in the morning, but if the local is good and you have given a good in between use of adrenaline, then there is hardly any bleeding the way we do. We do all our cases under GA, under laryngeal mask airway.
But these cases, like this case, we cannot do under local, because sometimes the patient gets vertigo on table because the lateral canal, we never know, because sometimes you get to.
Correct. So for the juniors, now removing this cholesteatoma with a side knife, and you just keep on elevating it, and it will keep on lifting. It's very, very simple. Similarly, now it is all then a cotton ball. So looks okay. So in between use these adrenaline soaked cotton balls, and this is pure adrenaline. So little semicircular canal looks good. Facial is intact. Now for the juniors, they keep asking how to identify the facial nerve. That is always the challenge. So in this case now you will get to see the facial, very simple. You see this reddish hue? So this is the facial covered by the facial bone. The facial canal is very, very clear. So now we look for the stapes. There are only two things here, facial nerve and stapes. Once you have cleared both, then there is no problem. So here we want to just elevate the annulus, because I want to see the stapes. Because you don't want to lift from here, because along with that the stapes may be avulsed. So first you want to make sure, although I don't see the bulge of the stapes. हाँ अंडे कराओ हाँ अरविंद कौन सी साइड उसकी थी, कोई स्पेसिफिक साइड तो नहीं है ना, उसमें लिखा नहीं है, तो कोई भी कर सकता है। पेशेंट से वैष्णवीज को एक बार पूछ ले पेशेंट से। Sickle. So you see I am elevating the epithelium from this side, not approaching here. First I will approach from here. I want to be very sure that any questions for the juniors? Because see, this will be your bread and butter surgery for life. So ask questions if you are not understanding anything. So this is the processus cochleoformis here. Here is the first genu. This is the horizontal segment. Then the second genu, and this is the vertical part. Okay? Now you see we are lifting the intact TM. So now step is here. So all ossicles eroded.
Hello, Rohit sir.
Yeah.
Sir, what precaution we need if facial canal is eroded?
Okay. So
to remove the cholestoma.
Yeah, so this is a usual story. Many times this facial canal will be eroded. No problem. You lift the epithelium from the facial nerve, not damaging the facial, and no problem.
Okay, okay, sir.
That's not a problem. So we are now elevating here and elevating here. You can use sickle, you can use side knife, you can use whatever instrument you want, but epithelium has to be removed in toto. So remember that. Circular knife. I will remove this part of the ridge. So we have removed all the epithelium from here, and now we see so this was the cholesteatoma epithelium, this is the handle of malice. So sickle. So this is also broken. There is no handle. So we remove this. If handle would have been there, I would have kept it. So this is the head of malice, no handle, gone. Circular knife. Side knife. For the juniors, I and Dr. Rajiv were having a chat just now, and Dr. A.B.R. Desai, Rajiv used to say that do every year as if you are operating your mother's ear. So then you will give your patient the best. Sickle. So keep lifting the epithelium. Now see, this epithelium has gone into the foot plate area. Many times the facial it descent here, the question that was asked. But here it is all good. तो आप सर हमारी तरफ टर्न करो, माइक्रोस्कोप ढीला करो. हाँ. The picture is clear, Praveen? Hello?
Yes, sir. Sir, picture is clear.
Okay. So gradually lifting the epithelium. This is my favorite instrument, the sickle knife, and you can see the foot plate coming into the picture. There was a cyst here. Dry gel form. Yeah. Can you make out the foot plate?
Yes, sir. Yes.
Can you make out the foot plate?
Clear, sir. Clear.
Moving?
Yes.
Moving well.
Yes.
Now we can see the round window area also. Cotton ball. अरे इतनी बड़ी कॉटन बॉल तो छोटी छोटी कॉटन बॉल दो दो. और छोटी दो डियर. So just putting cotton ball adrenaline. Now we have to clean this, drill this completely, and then reconstruction. So what reconstruction does the audience suggest? How do you want to reconstruct the hearing? Suggestions please. Praveen, ask the residents. Cotton ball.
Sir, I'm just opening the session for everyone.
हाँ क्या कह रहे हैं रेजिडेंट, क्या कह रहे हैं भाई?
Use of cartilage.
Cartilage.
Yes, sir.
So how cartilage? How? One cartilage, two cartilage, three cartilage. How do you want to reconstruct?
Sir, two cartilage, sir.
Two cartilages. Okay. So.
सर एल शेप कार्टिलेज भी यूज कर सकते हैं सर, एल शेप.
Correct. So Rajiv was talking of lot of ways of ossicloplasty. Now the choice here is a single cartilage, standing cartilage, single cartilage, and put a graft. One. Use two cartilages, one horizontal, one vertical. Choice 2. Choice 3. Use a total ossicular replacement prosthesis, whether Teflon or whether titanium. Choice 4. Standing incus. Remodel the incus in a way that you can put it on the foot plate. I have seen surgeons using body of the incus over the foot plate and it is vertically up. So these are the 4-5 choices that we have. If the audience wants to see a torp, I can do that. And if they want to see a double cartilage, I can show that. Pucho Praveen.
सर इनकस रिमॉडल यदि करते हैं तो उसका वेट का एक इशू आता है कि वो वेट की
I don't like it. I don't like it, Raj.
अच्छा.
I don't like that choice. I just gave you the choice. I don't do it. I don't agree with it, that concept at all. I can do only double cartilage technique or I use the torp.
Sir, the vote is for using a cartilage, sir.
Yeah, cartilage.
Yes, sir. Yes, sir.
अरे मैं सोच रहा था ये लोग टॉर्प देखना चाहेंगे.
Sir, this is a consensus. Cartilage, sir. Everyone is on cartilage, sir.
Everyone is on cartilage.
Sir.
So can you see the round window reflex?
Yes, sir. Yes, sir.
So the stapes foot plate is moving well. You can see the round window reflex.
Yes, sir.
So this area is clean, and this was the graph. This was the flap that we were using. So most of the TM is intact.
Yes, sir.
Only where the retraction was going, there is a space that you can see from where the cholesteatoma is gone.
Yes, sir.
Okay. So everything is good. Now do you want me to elevate this also or not?
Sir.
Do you want me to elevate the anterior annulus or not?
Yes, sir. Yes, sir. For seeing the stitching tube patency, we want to.
Correct. So always we have to elevate the annulus 360 degrees. Any case, don't take a shortcut. You have to open the eustachian tube area. You have to see this area. So this is the annulus, sickle. You saw Dr. Chitranshi taking off the canal wall outside. I don't do it. So there are many ways you can bell the cat. I like my flap here only. I will keep it here, I will keep it here, but I will not remove it. And it will remain attached at one place. Because I feel that removing the wall entirely requires a little bit of skill to put it back in place. But it was beautifully done by Dr. Rajiv. So in his hands, it's a good technique, but I don't do it. So you can follow any of the techniques. There are so many things. Wet graft, dry graft, in the implant, putting the implant from the round window or cochleostomy. These debates go on. The best way is do everything and then do what you decide what is best for you and the patient. Cup faucet. Sickle. So hardly any bleeding. This patient is under GA. Laryngeal mask airway, he is under GA. And I says, this is another debate, local versus GA. So it is also what you are comfortable with. I do all my cases under GA, under LMA. And I am quite comfortable with it. My patient is quite comfortable with it. So this is another area where we want to clean. This is a good patient to show anatomy for the juniors. So all my flap is sitting comfortably here. This is eustachian tube. It's perfectly clear. Okay. Now should I stop drilling or do I need to drill more? Resident, what are the areas you want me to drill more? Smaller diamond.
They are saying anterior buttress.
Correct. So anterior buttress and posterior also, Rajiv.
Yes, lots of drilling.
Lots of drilling, yes. So this is a senior person speaking.
All residents are saying this.
Lots of drilling, lots of drilling. क्या बात है भाई ये where is the drill? क्या हुआ स्पीड का क्या हुआ? Okay? Done. 80,000 कर दो. So we are using this drill. It's 80,000 RPM. A good drill. This is the Kia drill. Morning was the Metronics. So Metronics is a good drill. Rajiv. Rajiv is there?
Yes, I mean.
Rajiv, Metronics is one of the sponsors.
Yes, they are always supportive.
Okay. So they are very supportive. Facial nerve monitor and but without saying one sentence I will not close. So high maintenance, high cost.
That is true. One is here from Metronics.
In the morning I was saying that it is like Mercedes-Benz. You keep 3-4 cars in your house, use Mercedes to take out your girlfriend. So use Metronics when you have a good patient who can pay for the bus.
Yes, that's true.
So this I am drilling over the semicircular canal and then I am drilling over the, getting close to the facial now. You can see the bleeding a little bit.
Yes, yes.
पानी डाल, पानी डाल. Now the one fear is that this will get into the drill. So some people use aluminium foil, some use whatever, and some take it out and put it in saline. I do nothing. I just keep it away. Sickle 18. So this looks okay. Wash. Mota laga. So what I do is I wash with vinegar, acetic acid, and then we'll wash with betadine. So vinegar I have found a very good thing. Acetic acid, all seniors will know, they are all using it. Inhibits bacteria and is a very, very good tool to have in the ear. So we keep vinegar.
Now we have, I think, acetic acid drops also.
Acetic acid.
So most of the cases, in post-op cases, where the doubt, we use the drops for weeks actually.
Yeah, and got convinced by Satish and started using Manuka honey also to wash per-op. But then somebody pointed out that Manuka honey has rifampicin as well, and per-op it may be ototoxic, I don't know. So we don't use it per-op. Per-op vinegar and betadine wash, and then post-op vinegar drops, antibiotic drops, and when he comes for cleaning, we clean with Manuka honey. It has improved our results tremendously.
Okay.
Rajiv, Manuka honey, whatever Satish does, there is science behind it and lot of thought. Only then he will recommend something.
Almost 6 years back, we explant one implant, and it was a biofilm around it. Manuka honey was used, and we could save that implant. And during, you remember the Agra workshop.
Oh, great.
And the child is doing very good.
Wonderful, Rajiv, because I have had 3 explants in my series, and I have not been able to save even one infection. And I strongly feel that if it gets infected, then you have to take it out.
Take it out.
So it's very nice if one you could save.
I think you were there during that Clark Siraj workshop, and Satish did that case. Manuka honey implant, you were there at the time.
Okay. Now what I am doing is I am doing the myotoplasty. Can you see it?
Out of focus actually. Please find focus. Now it's okay.
Better?
Okay, better.
Okay. So I take it to this level, okay, because it should be cosmetically good. And Rajiv keeps posted this large myotoplasties, which are cosmetically not very good. So I totally agree that this is the level that you should reach. Don't make a very large one. It should be adequate. And then a little bit what I do different is I take tissue from here.
Inferior canal wall, cartilage also.
Yeah. So I will take a little bit of tissue. If there is cartilage piece also, all this tissue will go into reconstruction. हाँ बिल्कुल. Dr. Rajiv, boss, when you are ready to show, we will shift to you. And then when I am ready to, I will change again. So we will keep changing. So what we will do, Rajiv, is Dr. Chitranshi is ready with the stapes case. Hello?
Yes, yes.
Yeah, so we will keep shifting. Whenever we want to show something, we will keep shifting between each other, so that you get the best out of both surgeries. Agreed?
Yes, totally agree.
Okay.
And we know Sir Chitranshi will do that step is in 15 minutes.
मेरा ठीक है? घोड़े पे बैठा दो तुम मुझे. Hello everybody, now can you hear me?
Yes, yes.
So I'll give an incision from 12 o'clock to 6 o'clock.
So infiltration, I think, you gave the infiltration?
Yeah, it was infiltrated, then only the paint and dripping was done. So I gave only one injection here with 2% xylocaine with adrenaline. Hello?
Yes, yes.
La. So give me the circular knife. बेटा इसको ऐसे पकड़ लो जरा. इसको ऐसे पकड़ो. हाँ. नहीं इसको स्पेकुलम को पकड़ लो. So I'll take an incision here from 6 o'clock to 12 o'clock. Okay?
Yes, boss.
It's a deep, bone deep incision. I'll show you how. This. Beta ऐसा रखो. Yes. Are you able to see? इसको पकड़ो बेटा.
Centralize, please. Centralize.
हाँ, yeah. The moment you are not able to have good picture, just let me know, okay? So from 6 o'clock to 12 o'clock, go up here, okay? And start pressing up to the bone. See this. This should be the movement. बेटा एड्रेनलिन बॉल दोगे हमको, एड्रेनलिन जेल फॉर्म डालो अंदर. These are adrenaline soaked gel form. बस कर जाओ.
Even we can use cotton ball at this place.
Actually, I don't use cotton balls. It is a good idea, but yes, sometime you might leave some fibers there, cotton fibers. BP ज़्यादा है क्या इसका? Always gel form. See, you keep on dissecting the canal wall. The moment you reach the annulus, yes, I am almost there. See this? I am almost there at the annulus. The trick is that you have to press against the bone. Keep on suctioning with one hand and you reach the annulus here. Can you see that now?
Yes, sir. Good afternoon, sir.
Oh, Saurabh, how are you?
Good, sir. You recognized the voice.
अरे मेरे कान काम करते हैं यार.
सर एक बार ये भी चेक कर लीजिए.
क्या? क्या बेटा पवन? कोई बात नहीं, ऐसा ऐसा रखो, ऐसे. हाँ.
परफेक्ट सर, परफेक्ट हेयरिंग है आपकी.
बेटा ऐसे पकड़ो इसको, ऐसे ऐसे ऐसे.
चित्रांशी वर्ष की जब 35 क्या 34 कितनी सर?
अभी?
हाँ अभी है जब
16 के आगे बढ़ा ही नहीं मैं.
सर अंडर एज सर्जरी नहीं करवा सकते आपसे प्लीज.
इलीगल.
हैं? अब मुझे कहना पड़ेगा, मेरे दोस्त जो हैं वो ऐसे ही मानते हैं मुझे, मैं क्या करूं बताओ. देख रोहित क्या कह रहा, नाच तो ऐसे रहे थे आप. हैं? मुझे लगता है कि जब दोस्तों के साथ होता हूं तो बिल्कुल एनर्जेटिक हो जाता हूं बिल्कुल. So this is the level you have to reach, and here you have to see that you don't enter between the annulus. वो
no tear.
Yeah. So you have to lift along with the annulus. Rohit Mishra, where is he? बेटा सक्शन दूसरा दो मुझे, पतला करो. पतला सक्शन, yes. See, you have to elevate along with the
Rohit, can we have two screen, means one in PIP?
Yes. Rajiv.
Yes.
See this?
Yes, we can see.
Along with the annulus.
Annulus.
And you separate it out.
And chorda we can see.
Chorda you can see. So there should not be a tear. Yes.
यार संजय सर, यार रोटी में रहो सर, थोड़ा खाना खा. अच्छा छोड़ आए. नहीं सुनो, छोड़ के नहीं आओ. अभी खोला ही था सर वो. ऐसा करो, यहाँ की जो हमारी स्क्रीन है जी सर, उसको भी PIP में कर दो. ठीक है. और माइक वॉश का चलता रहेगा, पिक्चर दोनों रहेंगे.
बेटा ऐसे रखो.
Rajiv sir.
हाँ.
You are doing very nice and very fast.
See the chorda? I am separating chorda here. Can you see that? Yes.
Cutting an healthy chorda is more dangerous than was.
Yes.
In mastoid, suppose if you damage the chorda, then it doesn't make a big difference. But this is a healthy chorda.
Yeah.
It should be preserved by any cost.
See, whatever nature has given, you have to preserve as far as possible, unless until it is mandatory that you have to cut. So I have now reached up to the malleus. Okay.
It's more than enough, I think.
More than enough. बेटा हमको जरा जेल फोम दे दो जरा, स्वामी का फ्लैप चिपका दें. I'll keep adrenal soaked gel foam for some time, just so that bleeding is minimized. डालो.
Dr. Rohit, which cartilage you have taken? Okay, okay. Homologous septal cartilage.
आ बेटा. वो दे दो ना भैया. देख के ऐसा ना करना.
These are wonderful cartilages actually.
सर ये फील्ड बाहर जा रहा है सर मॉनिटर के.
किसको बोल रहे हो, मुझे रोहित को?
आपको
हाँ आपका सर.
अब ठीक है?
रोहित ने तो एक कोना पकड़ लिया.
अच्छा अब ठीक है?
जी जी.
रोहित कोने में ही है भैया.
आपकी आवाज कुछ भी दे यार. ये क्या साइड नाइफ? नहीं, इससे क्यूरेट है. So okay. So I can see the IS joint. And it has to be cleared, but ऐसे रखो बच्चे, up to the malleus. This is the cauda. I can see the cauda. See this, है ना? Okay. This is the only place where I use the hammer and gouge.
मतलब
हैं?
कानपुर की यादें छोड़ोगे नहीं आप?
नहीं, कानपुर की नहीं है.
I think gouge and hammer is again very good tool actually, but it should be very small and very good gouge.
Yes,
it's big about it. It's very big.
It is big, but yes,
No.
I can manage it. I'll manage it.
Ashim uses the same thing.
See, you have to pull it up and pressurize on the down. See this. Okay.
But I think we will not recommend to juniors to use it.
No, see,
but actually, that hammer is different actually. That is 1.5 millimeter hammer. So gouge, very sharp.
I know.
And very small slip will create problem.
Just hold it like this, beta. ऐसे पकड़ो, बच्चे. See, you have to have good control on the gouge. Yes, this gouge is big, but and you have to practice it. Yes, I am able to do. बेटा फारसेट देना जरा. This is good. It's a very thick chunk of bone. Yes. वो तो बेटा जरा मुझे कर्ट पे के सक्शन. Yes. So now this is out. बेटा वो देना मुझे जरा कुछ ऐसे जिस इसको हम फॉर्सेप दे जरा. It is बेटा छोटी नहीं है फॉर्सेप से. कब फॉर्सेप नहीं थी नहीं. Rajiv, it makes your life easier because otherwise curating. वो दे बेटा राइट एंगल देना जरा. हेलो.
Yes, yes, we get.
It is a difficult proposition, but yes, if you learn it, then it makes your life easier. So let me see this. Yes, the movements are restricted. Give me the oh beta curate देना चाहिए. Curate. अरे बाप रे. इससे छोटा क्यूरेट नहीं बेटा तुम्हारे पास. हाँ. So again away from the nerve. Even if you are coming here like this, your motion should be away from the nerve.
Here the value of good instrument comes. The Stoll's
Yes.
curate is ultimate. Like it just cut the bone like butter.
Okay.
Man behind the machine is important.
What are you saying?
Man behind the machine is more important.
We are talking about common men, not men like Chitansi was.
देखो.
ये क्या है?
हाँ.
Sclerotic.
नहीं नहीं नहीं, ये बोन चिप है। Carrot दे बेटा, carrot.
Rohit, when you show that osteoplasty, just we will make it zoom.
Yeah. साफ करा सको।
Zoom, zoom, zoom. Rohit, zoom. ये कॉटन अच्छा है, it is cotton.
हाँ बिल्कुल बिल्कुल भैया, बिल्कुल ले लो।
ये हमारा माइक और हमारी स्क्रीन कर दो।
हाँ
डालो एक ऑर्डर। हाँ Rajiv, you are with me?
Yes, yes.
Okay. So we are nearing the completion now. So what I have done is, see, I have this was the anterior, the posterior based flap that we had.
We saw it. Okay.
So I have now cut it, and this will fall like this. This will fall into the cavity like this, and the muscle flap will fall like this.
Yes.
And before that I have a little soft tissue and cartilage which will be filled up here. So now we will place the double cartilage assembly that I have formed. Now it is a little different, but this is what I feel is good in my hands, so I don't go for a longer assembly.
नहीं, longer, I mean, both all are good. But
See, I use this one.
Yes, yes.
I use this one, and this will go like this. Soft tissue.
Then how will you get the middle layer space?
So this horizontal cartilage is giving you the middle ear space.
Okay, okay.
So tissue, and this tissue will give you the middle ear space.
Okay.
This is coming here. So this is kind of giving you the attic reconstruction.
Yes, yes.
Or tissue.
This is a golden tissue.
These are all betadine soaked soft tissue and cartilage from the canal. जब म्यूटोप्लास्टी कर रहे थे तब ये सब निकाल लिया था. So now you have the assembly in place, and you want to put the graft and the whole thing back. Now this has to fall on the cartilage. This graft is very huge graft.
Yes, yes. It will cover the muscle.
So it will cover almost everything. And ऊपर से ये flaps आ जाएंगे, तो everything is covered. There are no raw areas.
So you keep graft under the flaps.
Yes. So if you want to have a relook, you see this is my on the stapes, and this is the graft that comes here, gel foam. So this we will put gel foam here first.
Looks good.
And this will fall here, and this will fall here. So after a year or so, you will not see any cavity here. Gel foam. Okay, Rajiv?
Yes, wonderful.
Looks good. We can go back to boss.
Yes, yes.
Okay, thank you.
Big boss. राजीव बॉस
चेंज करो.
कर दिया.
हाँ.
हमारी स्क्रीन छोटे में और माइक डॉक्टर राजीव का.
सर की आवाज नहीं आ रही, मीठी आवाज.
मेरी आ गई आवाज. मैंने क्या किया, थोड़ी देर एड्रेनलिन, अरे तेरी तो हमारा माइक्रोस्कोप हिल जाता है यार, नाराज हो जाता है कभी कभी. क्या I had just put adrenaline soaked gel foam to stop bleeding here, है ना? So I can see the foot plate from here. Are you able to see? No.
Yeah, we can see.
And facial is just peeping in. This is the facial. Can you see that? No.
Yes, yes.
Hello. Rajiv sir.
हाँ.
Can you increase the magnification?
भैया कर रहा हूँ, वही कर रहा हूँ भैया, मैं खोज रहा हूँ, वही खोज रहा हूँ. इधर क्या मैग्निफिकेशन? Now it's better?
Better sir, better.
हाँ, suction देना बेटा. So if you see that, बेटा इसको यहाँ हाँ पोज कर रखो ना, बच्चे दिखता है ना वहाँ पर. You see the stapedial tendon?
Yes sir.
See the posterior crura?
Yes.
See the incus?
Right.
See the foot plate, and this is the facial. फेशियल मैं इधर से दिखाता हूँ थोड़ा सा और. अब देखिए.
Yes sir. Canal is not dehiscent.
हाँ, not. जरा कर्ड पिक देना, कर्ड पिक.
Inside the bone.
अबे यार ये तो बहुत, ये देखो, दिस इज द फेशियल, है ना?
Yes,
द
yes,
कैनाल, बोनी कैनाल इज इंटैक्ट, इट इज नॉट एक्सपोज्ड.
Sir, what is the definition of adequate exposure in stapes?
You should see the foot plate without tilting it.
Okay, sir.
Without, I'm seeing straight now.
Right.
Because you have to make a hole here and then put a this piston here. So you should not making your neck curved so that you can go inside. If you are seeing directly here, this is the adequate exposure. Now give me the perforator.
Posteriorly we should go.
How posteriorly?
Yes sir. Till the pyramid?
Yeah, till the pyramid.
Right.
If it is, हाँ. ला, वो दो. Perforator. 0 number. Number नहीं है, perforator नहीं तुम्हारे पास? ये क्या है? What is this? Perforator तो है ये. Now, I should go posteriorly.
Sir, when will you measure the distance between the incus and the foot plate?
Actually, I don't. For the demonstration sake, I can do it.
कितने सारे स्टूडेंट never calculate.
ला भाई यार वो दो. गेज ये है ना तुम्हारे पास? See this. Okay. So I am there on the foot plate, and this is the measurement. Okay, Saurabh?
Yes sir.
Did you see that or not?
Yes sir.
Suction.
Sir, can you tell the audience how to use this distance measuring rod?
So I have to show you. नहीं वो गेज दो जरा. See, this is the gauge, no?
Yes, sir.
So there are 1, 2 and 3.
Right.
So this portion will touch the foot plate.
Right.
Okay?
Yes, sir.
And you have to see your incus has reached which level.
Right.
You have to gauge it one more, because there will be thickness of the foot plate, and it should, see, if it is like this, your piston should just enter the hole. It should not go in like this. It will cause sensory loss later on. So if it is, the hole is like this, then you have to just suppose this is the wall, this is the foot plate, it should just enter like this. So one more, suppose this has come here, you have to take the distance from here, so the second one.
So the first one is 4.25, sir, or 3
Yeah.
point or 4?
This is 4.
Then 4.25 and then 4.5.
Yeah.
So we have to add 0.25 mm more.
Yes, yes, yes.
Right, sir.
ला बेटा परफोरेटर दे रहा, इसको ऐसे पकड़ो, सिर बैठा ऐसे सिर रखो, परफोरेटर. Now the movement is drilling movement. You reach there and do the drilling movement like this. Never put pressure on that. Never. Just drilling movement.
Yes, sir.
And see where are you drilling. Again you go there. Again drill it very softly. It is hard because of otosclerotic patch there. Just drilling movement like this. Slowly, slowly, slowly you drill it. Yes.
So you are making hole in the just in the center of the foot plate?
No, posteriorly.
Posteriorly.
बड़ा suction पतला करो बच्चा. लाओ दो हमको. Picture is there, good.
Yes, sir. Very nice picture.
And in step is never suck over the fistula. वो दो perforator दे बेटा.
Sir, you are doing this case in under local anesthesia or general anesthesia?
This is in general anesthesia.
Okay, sir.
Slowly, slowly you, if you can see this, okay, the hole is made. Yes. Okay?
Yes, sir.
Now piston खोलो भाई.
Which perforator is this? 0.5, 0.6?
This is 0.5. 0.5. ड्रिल नहीं, पिस्टन चाहिए. ये हाँ. So now give me sickle knife. Now I'll cut the stapedial tendon. You have specific instruments also for that, but sickle knife दिया. You can cut it with the sickle knife also. अरे इससे छोटा sickle knife नहीं है, यही है. चलो कोई बात नहीं. Now again you can do it like this. Can you see the?
Yes.
Slowly, slowly you cut it Again, I will बेटा सक्शन साफ करके रखो बच्चे, सक्शन साफ नहीं है, फील्ड क्लियर नहीं तो अच्छा नहीं लगता ना, देख रहे हैं सब लोग वहाँ पर। ला ला सेकंड लाइन ला। Slowly you cut the yes. Can you see that? I have cut the stapedial tendon. I'll show you. Okay?
Yes, sir.
Little bit is left. No, no. Give me sickle knife. The sickle knife is too big. Yes. यार कुछ भी दे यार, बहुत बड़ा है सिक्के भाई। पिस्टन निकाला बेटा? Yes. Another thing, you give me the right angle now. Small right angle. Right angle. Now you have to dislocate the IS joint. Now see the movement. Slowly, 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 slowly you enter there. Are you able to appreciate? Hello?
Yes, sir. Yes, sir.
Slowly, slowly you have to go in the joint and dislocate it. Yes. It is done?
Yes, sir.
So I am able to, yes, the whole, la. So I am now ready to put the piston. बेटा कुछ साइड नाइफ दे दे जरा। हाँ ला पिस्टन खोल के देना। Piston. Now straight वो दे उधर हमको उसको, ये क्या है? What is this? हाँ ठीक है। Now how to open up the piston? you have to put the straight needle there. It has a memory, so you have to ask the piston to forget the memory for some time. WhatsApp दो. The another way is to do it like this. Okay? You yes. बेटा इसको देना मुझे पकड़ा के, है ना, पकड़े रहो उसको जरा. Suction देना जरा. Yes. So I am now again I am showing you the anatomy, the incus, the dislocated IS joint. I have already cut the stapedial tendon. This is the chorda, facial, a perforation in the foot plate. दे बेटा. So now it should go inside, but still it is longer. Got it?
Yes, sir.
Straight needle दो. Straight needle. जल्दी दे बेटा. क्या करता है? How you can see is you can push it slowly. It is inside the hole, okay? Perforation. Okay, now it is little longer now. So I'll take it out and cut it. La. वो दो forceps. 11 नंबर ब्लेड लाओ और एक वो लाओ जरा हमें रुको ठीक है नहीं Are you able to see the piston? No. Hello?
Hello, sir.
Are you able to see the piston?
Yes, yes.
Now, I use a 11 number of blade and this much I have removed. Okay?
Okay, sir.
Now, yes. बेटा इसको रखो अपने पास संभाल के गिरे ना
Which piston is this one?
Which means I don't know रोहित कौन सा पिस्टन मंगाता है यहाँ पर टेफ्लॉन पिस्टन ही है ये
Which company?
Company I'll tell you later
Memory
on.
looks good.
Let me put it inside and then I'll that information Rohit is going to give you. ला बेटा ला straight, straight. अरे यार परफोरेटर नहीं देते बेटा, तुम क्या करते हो यार? बेटा स्ट्रेट नहीं है तुम्हारे पास कोई? Little difficult. बेटा सक्शन दोगे जरा मुझे, इसे पकड़ो। जरा इससे पतला सेक्शन मिल जाएगा बेटा, और इससे पतला सेक्शन और दे, सेक्शन 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 सबसे पतला। Yes, I am in, but still no. Good. Gone in.
Yes, sir. Sir, out of center, a little bit out of
Okay.
center. Yes.
ठीक
sir.
है?
Perfect. Perfect, sir. Perfect.
बेटा इसका पकड़ो ऐसे बच्चे, तो माइक्रोस्कोप ठीक करो, मैं एक हाथ से माइक्रोस्कोप ठीक नहीं हो पा रहा, इसे पकड़ो। नहीं नहीं इसे पकड़ो, स्पेकुलम को बच्चे। बे यार तुम ढीला करो ना इसको थोड़ा सा। बस बस टाइट करो बच्चा, शाबाश। ना सक्शन देना जरा मुझे। सो नाउ यस, Okay, I can.
Sir, can you focus on the lower end of the?
यही करने जा रहा हूँ. इसको पकड़ा दो बेटा, ऐसी स्पेकल पकड़ो तुम. अब दिखा? And now I will be testing it because is it going out or not?
Bending test.
Yeah.
Test.
Yes.
Yes.
ठीक?
Yes, sir.
It's okay?
Looks okay, sir.
ठीक है? देखो ये it is not coming out.
Right, sir. Right.
Okay?
Sir.
And this is there.
Correct, sir.
Now the next step is I have to
remove the
break the
yes,
break the so yes. बेटा right angle है तुम्हारे पास छोटा.
Sir, you don't use powered instruments like Skeeter in this step?
नहीं sir. Slow and steady movement, it will break the suprastructure. पिक्चर क्वालिटी ठीक है?
वेरी नाइस सर, बहुत बढ़िया.
Slowly and steady. Yes, it has broken down.
Sir, is there any risk of fracture of the foot plate in this step?
Yeah, why not?
If
that's why it is.
It happens. So what should we do?
If the whole foot plate has come out,
yes,
then you have to pack with the fat. And if you can do, put a graft there, fascia graft.
Okay, sir. So, is there any difference between using fascia graft and the perichondrium?
No, not at all. Anything you can use.
Right.
This is the.
This is the remnant of the posterior crura?
Yes, posterior crura and the head.
Right, sir.
So the movement is like this.
Right.
Slowly, you have to separate it.
And pressure on the neck towards the promontory.
Yes.
Right.
Pressure, yes. It will come out. भाई कहाँ जा रहे हो यार? बेटा जरा जो तुम्हारी फॉर्सिप्स है, लंबी वाली छोटी वाली, ठीक है? पिक्चर ठीक आ रही है अभी?
बढ़िया सर, बहुत अच्छी.
फॉर्सिप्स दो जरा, पतली छोटी, मोटी वाली मत देना, वरना रास्ता ही नहीं दिखेगा नहीं तो वहाँ पर. अबे यार, अबे ये तो बंदरिया के बच्चे की तरह चिपक गया. गुड.
सर आप शिफ्ट हो गए एनिमल प्लैनेट की ओर.
ये देखो, ये सीधे
सर्जिकल प्लैनेट.
निकल आई सर, बंदरिया का बच्चा निकल आया।
बच्चा निकल आया, इधर गया, ठीक है। पोस्टीरियर क्रोरा जो टूट गया, एंटीरियर क्रोरा सामने निकल आया। ओके,
यस सर।
चलो भैया, बंद हो गया काम।
You will make some, you will put some fat.
No, not at all, not at all. It
Fenestration,
is no. So no, see, I'll tell you why not. The whole button ऐसे करो, suction. There is no space here. See this?
Okay.
The piston, the shaft is snugly fitting the
in the fenestra.
In the fenestra, okay?
Right.
And this is, so you don't have to put anything here now.
If there was some space, then
yeah, then if you can put gel foam there, you can put some connective tissue, whatever you feel like. It is snugly fitting there. So cauda is there, lavilla. With a side knife. So now, time to close. जल फोम लाओ बेटा।
very well demonstration. Thank you very much.
Thank you very much for patient watching me. Saurav?
Yes, sir.
You are a very good boy.
Thank you, sir.
ला, जल फोम।
सर ये बड़ा
वो दो, straight. ठीक है? What is this? हेलो, जल फोम। अबे थोड़े थोड़े दिया करो यार। राजीव चला गया?
हाँ सर, चले गए वो।
अच्छा, ला, चलो ठीक है। नहीं, क्योंकि जिस समय मैं एनुलस वो कर रहा था तो उसने कहा था टीयर नहीं होना चाहिए टिम्पनिंग मेम्ब्रेन। सो डिफरेंस हियर इज दैट यू हैव टू एलिवेट द एनुलस। ला, along with the annulus you have to elevate the flap.
Yes, sir.
चलो भाई।
So do you have any experience with the endoscopic striptease?
No.
Okay, sir.
ला, जेल फोम लगा। वो एंडोस्कोप से देखो, another thing is it depends surgeon to surgeon. If you are trained with that and if you are comfortable, is fine.
Yes.
See, if the tool is in your hand, you can utilize it.
Right, sir.
Like in mastoid surgery, in cholestoma, also wherever you want, put a scope inside and you can see the facial recess, sinus tympani. बस क्या करना, तुम कैसे करते हो, क्या करते हो तुम इसको? छोड़ दें? हाँ, और क्या? हाँ।
स्टार्ट द लेक्चर। हेलो
बैंडेज करोगे? बैंडेज कर दो, बस एक गॉस पीस रख के चुप कर बैंडेज कर दिया।
pleasure to now invite our esteemed faculty member, Dr. Sumit Sharma sir, to the stage to deliver his talk on publishing. Please give a huge round of applause.
After you, sir. No, thank you. You did a wonderful job there. ये भैया निकाल लो.
ये सर सर गाउन खोल दीजिए.
गाउन खोल.
जुगलबंदी अच्छी रही.
नहीं वो नहीं हो सकता ना फिर तो आप वेट कर.
सर वो जेब में. इधर है निकाल.
Hello. Hello, good afternoon everyone. After regular surgical sessions, Dr. Rohit wanted me to talk something about publications for the undergraduates. And this topic is important because it is grossly neglected part of our practice in ENT. So, escape करके फिर से करो. Okay. Fine. So, I'm thankful to Dr. Rohit for giving me this opportunity. Research paper has multiple aspects to its process, and this is what the society thinks about. The question to ask yourself before you start the process in your mind of publication of your hard work is why are you publishing this paper, and the entire process depends upon the why are you publishing it. So either the objective is share knowledge and findings, you want to share the advances in the field, gain recognition, contribute to evidence-based practice, critical and evaluation, or just NMC requirements for both faculty and the students. It's a long process, it's a very long process, and a good nicely published article requires a lot of endurance, both in making out the paper and in publishing it. So the balance of scientific paper should be that the research work should be much more than the paper. It should not be the other way around. We start with the presumption that you have completed the final draft of the paper and it is ready for publication. The process of evolution as far as the medical profession is concerned has evolved. Initially it was just publish, later on it became publish or perish, then it became publish in high index journals or perish, and now it is published frequently in high impact journals, and maybe you won't perish. So this is the spectra, this is the scenario today. These are the NMC guidelines of indexing. That is the PubMed, Medline, Science Citation Index. Good thing is for the undergraduates, the indexing criteria are a bit liberal, and they just say that the publication should be in any of the index journal. Steps to take before submitting. Now your paper is ready, now you're deciding upon selecting the journal for publication. The process is to be followed is something like this. Choose the right journal, read author guidelines, finalize the manuscript, format according to the journal requirement, check for plagiarism, proofread and edit, prepare supplementary material, verify authorship and contributions, attach ethical certificates, register for the ORCID, and write a short covering letter and decide on open access policy. So this is all that is goes on in your mind when you are submitting a paper for publication. Now, tips for selecting the right journal: scope and aim, you have to look for it. The target audience, you want scope means that it belongs to your specialty, and target audience mean that you have a topic on the rhinology, don't publish it in the otology journal, and don't publish it into a journal. Preferably you go for the rhinology journal, because the basic purpose of publication is to get recognition of your work, and they say that publication make you immortal. You have to have the opinion about the impact factor in the H index. You have to look for the indexing. You have to see the peer review process, open access or subscription, publication speed, article type accepted by the journal, ethical standards, and publication, and predatory journal. Predatory journal means a journal that do not pay much attention to the process of publication, that is peer review process and other things associated with that. Impact factor, and there is a two words very commonly used, impact factor and the H index or the H factor of the journal. To briefly describe the impact factor, it is the average number of all the citations received by all the articles published by a journal, whereas the H index or the H factor is the minimum number of citations received by all the articles of that journal. Means that if there are 5 articles in which one journal has one article has received 2 citations, the other has received 5, some has received 7, and some has received 10, then the H index will be 2. Whereas the impact factor will be an average of all the citations. So this is the difference between the two. Indexing and citation, we have already said that. And the significance of publishing in index journal is you have to have the credibility, visibility, citation potential, academic recognition, global research, and research integrity. It's always good to publish in an index journal. Index to minimum requirement postgraduates के लिए भी है. Why would you need to finalize the manuscript as per the author guidelines? Because you have prepared your manuscript for publication, but the publisher wants it to be modified as per his requirement. So you have to modify the ready part of your publication to as per the requirement of the journal. It ensures acceptance, fast acceptance, speed up review process, maintain professionalism, facilitates indexing, and avoid delays. COPE guidelines are, if you have written in your article that in writing this article I have followed the COPE guidelines, then it becomes a standardized method of saying that okay, fine, you have followed the internationally accepted method for publication, for writing the paper. Abstract is an important part of your paper which you have to have the maximum emphasis on, because whosoever reads your paper will have a look at the abstract before he goes into the details of the paper. So if he finds the abstract interesting, then only he will read the whole paper. And how will you make your paper visible to the academic community? That depends upon the keywords. Keywords are, this is सर्च इंजन में जो आप वर्ड्स डालते हैं उससे आपका आर्टिकल डिटेक्ट होता है इंटरनेट पे. सो अगर आपने पुअर कीवर्ड सेलेक्ट किए हैं तो आपका आर्टिकल भले ही कितना अच्छा हो वो डिटेक्ट नहीं होगा. तो डिटेक्ट करने के लिए आपको बहुत कॉमनली यूज्ड और बहुत स्पेसिफिक अपने टॉपिक से रिलेटेड ही कीवर्ड्स यूज़ करने चाहिए जिसमें आपका डिटेक्शन ऑफ योर आर्टिकल इज़ मच ईजियर. Say for example the impact of social media on academic performance among university students, ये हमारा topic है paper का. Then the keywords could be social media, academic performance, university students, digital distractions, online learning, social networking, and student engagement. So on an average 3 to 5 keywords are acceptable internationally. Proofreading is grammar correction and sentence formation, spelling mistakes. These are either you can do it yourself or you can use any of the software related to proofreading. Ethical concern, there are 2 things, ethical concerns and the second thing is ethical standards. Ethical concerns जो होते हैं, एक तो ensure work is original, free from plagiarism, we'll talk about plagiarism. Properly cite all sources, quotations and ideas taken from others. One mistake that we commonly do is that say you have written a paper and in which you have cited someone. Now if someone else opens your paper and instead of citing the person who has written that, you cite you, he cites you. Okay, this should be avoided. You should cite the original person rather than the person who has cited the original person. So the credit should go for the main part. And in academic, in publication context, the extent or the more the number of citation, the more valuable the research is. ऑथरशिप ट्रांसपेरेंसी होनी चाहिए, घोस्ट राइटिंग नहीं होनी चाहिए, बहुत कॉमनली प्रैक्टिस्ड है आजकल, स्पेशली अंडर ग्रेजुएट लेवल पे, पोस्ट ग्रेजुएट लेवल पे भी काफ़ी कॉमन है, फैकल्टी लेवल पे भी कॉमन. आई हैव सीन इट माई सेल्फ दैट घोस्ट राइटिंग, गिव इट टू समवन, गिव द टॉपिक एंड गिव इट टू समवन, दे विल राइट एवरीथिंग अबाउट इट. सो दिस विल नॉट हैव अ वेरी significant academic value except for that you will be able to appear in your examination. Okay. Ethical approval is obviously very important. If you are having a drug trial, the drug trial का retrospective recognition नहीं होता है, ethical का retrospective नहीं होता है. You have to have, अगर आपने study कर ली उसके बाद ethical clearance लिया और उस certificate लगाया, paper will not be accepted. This ethical clearance has to be made before the study starts. Ethical standards to be followed, there should not be duplicate submission, means one article should not be submitted to multiple journals. Avoid salami slicing. Salami slicing is publishing the same data in multiple papers. You have changed the context, but the data remains the same. The study, जो ऑब्जर्वेशंस हैं वो सेम है, लेकिन हेडिंग चेंज कर दिया आपने और कंटेक्स्ट पूरा चेंज कर दिया. ट्रांसपेरेंसी एंड मेथोडोलॉजी होना चाहिए, रिस्पेक्ट फॉर इंटेलेक्चुअल प्रॉपर्टी होना चाहिए, एंड प्रॉपर एक्नॉलेजमेंट ऑफ फंडिंग सोर्सेज होना चाहिए उसमें फॉर अ गुड जर्नल. Significance of ethical clearance is that no ethical clearance, no publication. Ethical approval is not optional. It is a fundamental responsibility of any researchers to protect participants and uphold on the standards of science. Plagiarism guidelines. Plagiarism is that we were talking and just I took away your idea. You have published something and I copy pasted in my paper. So plagiarism is stealing of the text, stealing of the data and figures and concepts or ideas without citation. I'm talking about this without citation. Okay, plagiarism category 0 to 10% is internationally acceptable. So if you put your article in the plagiarism checker and it comes up to 10%, it is normal. 10 to 40% is level 1, 40 to 60 is level 2, and above 60 is level 3. And there's a grade of punishment for if plagiarism. अगर आपने हमारा copy paste कर दिया and if I want to catch hold of you, I can easily catch hold of you. वो नहीं करते हैं, वो एक अलग बात है. But I can easily, if I detect my content in your paper without citation, then it will, I can claim that this is wrong deed that has been done. And the level of up to 10% it is acceptable. From level 1, you have submit revision work without any specific timeline. Level 2 is suspension from submitting work for 1 year. And level 3 is cancellation of registration or expulsion. This was for the students. For the faculty or the researchers, it is different. Up to 10% it is normal. Level 1, withdrawal of the manuscript. Level 2, barred from publication for 1 year. And level 3 is more severe, dismissal without withdrawal of the degree, if applicable. So avoid plagiarism. ऑर्किड आईडी क्या चीज़ होती है? आजकल शुरू में बहुत चला था ऑर्किड आईडी, बीच में फिर थोड़ा ट्रेंड कम हो गया, बट इट इज़ रिवाइविंग अगेन. व्हाट इज़ एन ऑर्किड आईडी? इट इज़ अ रिसर्चर्स आधार कार्ड. जैसे आपको हर चीज़ से आपका लिंक्ड है, आपको होटल में कमरा भी चाहिए तो आधार चाहिए, कहीं भी आइडेंटिटी चाहिए होती है. ये एक इंडिविजुअल की आइडेंटिटी होती है रिसर्चर की, एंड इसी से सब कुछ रिलेटेड होता है. आपने एक ऑर्किड आईडी क्रिएट करी, और ऑर्किड आईडी जब भी आप अपने किसी रिसर्च पब्लिकेशन पे मेंशन करते हैं तो वो ऑर्किड आईडी ऑटोमेटिकली उस पेपर को अपने टेकअप कर लेती है और अपने उसमें पुल बॉक्स में रखती है. सो उस टॉपिक पे जितनी बार भी लोगों ने साइटेशन किए वो ऑटोमेटिकली रिफ्लेक्ट करता रहता है. जैसे आपको हमारी रिसर्च कैपेबिलिटीज़ देखनी है तो आपको हमारे सिर्फ ऑर्किड आईडी चाहिए. आप हमारा ऑर्किड आईडी से हमारी ऑर्किड आईडी ओपन करेंगे और आपको रिसर्च क्रेडिबिलिटी हमारी पूरी पता चल जाएगी उससे. सो दैट इज़ द सिग्निफिकेंस ऑफ द ऑर्किड आईडी, विच इट्स अ वेरी सिंपल थिंग. इट्स अ फ्री थिंग टू बी डन. गो ऑनलाइन, fill a form and the ORCID ID is generated. Selecting the right peer review process is very important. Single blind review, double blind review, open review, post publication review and collaborative review. These are the types of reviews. Single blind means reviewers know the author but the author doesn't know the reviewer. Double blind means दोनों को नहीं पता एक दूसरे के बारे में. And open review means Identities of the authors and the reviewers are known to each other. And post publication review means पहले review नहीं किया गया, publish कर दिया, उसके बाद it was reviewed and any changes done in the manuscript. And collaborative reviews and authors interact directly along with the editors. The most internationally accepted method is the double blind, which we also follow. Copyright, ये थोड़ा सा complicated है. Copyright means आपके पास पेपर है और हम पब्लिशर हैं, आपके राइट्स हैं उस पेपर को लेके हमारे पास, हम आपके राइट्स लेना चाहते हैं उस पेपर से रिलेटेड. सो द कॉपीराइट अप्लाइज टू बोथ द ऑथर एज वेल एज द पब्लिशर. ना आप किस एक्सटेंट तक कॉम्प्रोमाइज करना चाह रहे हैं पब्लिकेशन के साथ, ये डिपेंड करता है. वो आपसे कॉपीराइट फॉर्म भरवाएगा, किस एक्सटेंट तक आप उसके साथ कॉम्प्रोमाइज करना चाहते हैं, ये आपकी कॉपीराइट पॉलिसीज डिफाइन करती हैं. ओके नो, ये कॉन्सेप्ट चीज़ें आती हैं. रूल्स फॉर ऑथर्स इन पब्लिकेशन ओनरशिप में आती है, राइट्स में आती हैं, एग्रीमेंट्स में आती है, क्रिएटिव कॉमन्स में आती है, रीयूज में आती है. लाइक से फॉर एग्जांपल ये वो राइट्स हैं जो रिकमेंड किए जाते हैं कि ऑथर शुड रिटेन. वी टेक इट फॉर ग्रांटेड कि हमने पब्लिकेशन अपना किया है तो उस कंटेंट को हम चाहे जहाँ यूज़ करें, ये तो मेरा पेपर है. लेकिन अगर आपने कॉपीराइट फॉर्म सबमिट किया है जिसमें आपने ऑथरशिप उसको दे दी है, तो आप उसको यूज नहीं कर सकते हैं, वो क्लेम कर लेगा आपको यूज अगर आप करेंगे तो. इट इज योर प्रॉपर्टी यूज बाय समवन विच यू हैव लॉस्ट ऑल योर कंट्रोल ऑन. ये राइट टू रीयूज योर ओन वर्क, राइट टू शेयर प्रिंट्स एंड रीप्रिंट्स, राइट टू डिस्ट्रीब्यूट और डिस्ट्रीब्यूट टू स्टूडेंट्स और कलीग्स, राइट टू ट्रांसलेट द वर्क इन अदर लैंग्वेजेस, राइट टू आर्काइव, पुट इट इन योर ORCID ID or somewhere else, and rights to be credited. These are all rights that the author can take away from you. How can he take away from you, and how you can prevent is like this, or like this. Just a minute. ओके, ओपन एसेस वर्सेस कॉपीराइट, विल कम टू दिस. दो चीजें होती, ओपन एसेस और एक कॉपीराइट होता है. ओपन एसेस मींस जहां पे कोई भी आपके आर्टिकल को उस वेबसाइट पे जाके पढ़ सकता है, आपको पैसे नहीं देने उसके लिए, आप उस आर्टिकल को डाउनलोड कर सकते हैं, आपके पास आ जाएगा. लेकिन कॉपीराइटेड अगर होगा तो सब्सक्रिप्शन फीस आपको उस आर्टिकल को देने के लिए ज़रूरत पड़ेगी. बेटर है कि आप लोग आर्टिकल्स ओपन एसेस में पब्लिश करें, क्योंकि पैसे दे के आपका आर्टिकल पता नहीं लोग देखें कि ना देखें तो आपको साइटेशंस नहीं मिलेंगे अगर ओपन एसेस में नहीं है तो प्रेफरेबली चूज द ओपन एसेस पॉलिसी फॉर पब्लिकेशन योर वर्क. नाउ यहाँ पे दो चीज़ें हैं, जो कॉपीराइट रूल्स हैं वो ओपन एसेस पे भी अप्लाई होते हैं, और कॉपीराइट रूल्स हैं वो कॉपीराइटेड में भी अप्लाई होते हैं. लेकिन यहाँ पे ओपन एसेस पॉलिसी के जो कॉपीराइट्स हैं उसमें आप अपना वो जो हमने पहले बताया था, ये सारे राइट्स आपके पास रहते हैं. ओपन एसेस कॉपीराइटेड में आपके पास ये राइट्स सब अपने पास हैं. वेयरएज इन केसेस ऑफ कॉपीराइट, अब आपको पता कैसे चलेगा कि ये जर्नल में हम सबमिट कर रहे हैं तो किस कैटेगरी की कॉपीराइट है उसके पास, ये डिपेंड करता है इस पे, क्रिएटिव कॉमन्स पे. ये लाइसेंस देता है कॉपीराइट का, जो कॉपीराइट पब्लिशर यूज कर रहा है उसको ये क्रिएटिव कॉमन्स एक लाइसेंस देता है. तो कौन कौन से लाइसेंस होते हैं? सीसी होता है, बाई होता है, एसए होता है, एनसी होता है, एनडी होता है. सीसी इज क्रिएटिव कॉमन्स एंड बीवाई इज एट्रीब्यूशन. अगर आप किसी को एट्रीब्यूट करके उसका काम ले रहे हैं तो ये सीसी बाई में आता है. ये जो फर्स्ट वाला आप देख रहे हैं, ये वाला, दिस इज द, अगर ये वाला साइन आपको किसी जर्नल की वेबसाइट पे दिखे तो दिस इज द बेस्ट जर्नल टू पब्लिश. यहाँ पे मैक्सिमम राइट्स आपके पास हैं आपके अपने आर्टिकल के. सीसी बाय, फर्स्ट सीसी एंड बाय. अप्रूव क्रेडिट दे रहे हैं आप किसी के काम का तो आप उसको यूज कर सकते हैं, कोई प्रॉब्लम नहीं है. जहाँ पे ऐसे आता है शेयर अलाइक, यू कैन रीमिक्स, अडेप्ट एंड बिल्ड अपॉन द वर्क बट मस्ट लाइसेंस न्यू साइटेशंस. एक फिर से आपको लाइसेंस लेना है. ये इसके नीचे से थोड़ी प्रॉब्लम शुरू होती जाती है. और non-commercial, NC is non-commercial. You must not use material for commercial purposes. So these are the licenses for the copyright. So अगर open access है तो वो हमेशा CC BY में होगा. It will not be in any other category and most of the rights will be retained by you. So this is थोड़ा सा इंटरेस्टिंग चीज़ है, एंड वी टेक दिस थिंग फॉर ग्रांटेड कि हमारा पेपर है तो हम पब्लिश करेंगे जैसे चाहें. दिस डज नॉट अप्लाई टू ऑल द कंडीशंस. जो हमारी जर्नल है वो CC BY है, तो इट इज़ ओपन एसेस एंड कैन द कॉपीराइट is retained by the author, and we take the right of publishing the article. We do not retain the right of non-reuse by the person. We do not retain the right of non-commercial use of the paper. He can use the paper commercially, he can use the paper to reproduce, but we only take the right of publication, and this comes in the, this comes in the CC BY. So this I think I'm थोड़ा सा क्लियर हुआ आप लोग को. How copyright and Creative Commons are related, this we have already talked about. That when you look at the Creative Commons, you come to know about the copyright type of that journal. So this is how they are related to each other. Two common models of publishing: traditional method, where the publisher is the copyright owner, and the open access model where the author has all the right, that we have already talked about. So using AI आजकल बहुत commonly use हो रहा है. Artificial intelligence को किस तरह से use करना है अपने पेपर राइटिंग में, इसके भी गाइडलाइंस हैं. लाइक आइडिया जनरेशन के लिए आप यूज कर सकते हैं, वो एक्सेप्टेड है. लिटरेचर समराइजेशन नॉट लिटरेचर जेनरेशन, लिटरेचर समराइजेशन के लिए आप उसको यूज कर सकते हैं. ड्राफ्ट राइटिंग के लिए थोड़ा सा पार्शियल वैलिडिटी है इसकी, कंप्लीट वैलिडिटी नहीं है. डाटा एनालिसिस के लिए आप यूज़ कर सकते हैं. इनफैक्ट सब लोग डाटा एनालिसिस, जो हम लोग स्टैटिस्टिशियन को पैसे देते आ रहे हैं अभी तक, वो हम लोग ने अब देना बंद कर दिया. वी यूज़ AI फॉर डाटा एनालिसिस. स्टैटिस्टिकल एनालिसिस इज़ वेरी ब्यूटिफुली डन बाय AI, चैट GPT. अगर आप लोग भी ट्राई करना चाहते हैं, जस्ट एंटर, वो कुछ रिक्वायरमेंट्स आप अपना डाटा फिल करिए चैट GPT में, वो अपनी रिक्वायरमेंट देता जाएगा, वो रिक्वायरमेंट फुलफिल करते जाइए. इन द एंड यू विल गेट द स्टैटिस्टिकल एनालिसिस or the p-value of the study. Then plagiarism rights नहीं है, authorship ethics उसके पास नहीं है, and reference generation partially कर सकते हैं, reference generation but not completely. And then writing style and language you can use, definitely use. And factual accuracy तो बहुत ही poor है. It is intellectual property आपकी है ही नहीं वो, अगर आपने पूरा content बाहर से लिया है. And final submission is obviously invalid if generated by the AI as of now. How do publishers detect AI content in the paper? जो आपने submit किया वो publisher detect करेगा. Now AI डिटेक्शन सॉफ्टवेयर्स आर देयर, जो कि आप उस स्टडी को आप प्लेगरिज्म चेकर में भी डालेंगे और AI डिटेक्शन सॉफ्टवेयर में भी डालेंगे तो उससे पता चल जाएगा. एंड वन इंटरेस्टिंग थिंग इज दैट AI जनरेटेड टेक्स्ट ऑफन लैक डीप क्रिटिकल रीजनिंग, डोमेन स्पेसिफिक नुआंसेस एंड इनकंसिस्टेंसीज टिपिकल ऑफ ह्यूमन राइटिंग. ये 3-4 चीज़ें जो होती हैं बहुत प्रॉब्लम है, जो बहुत प्रिडिक्टेबल होती हैं किसी भी पेपर में, वो आप अगर देख रहे हैं तो आपको ये सस्पिशन होना चाहिए कि AI जनरेटेड है, तब आप उसको सॉफ्टवेयर में ले सकते हैं. दूसरा बहुत इंपॉर्टेंट पॉइंट है AI जनरेटेड पेपर सबमिशन में, एक बंदा बहुत फ्रीक्वेंट पब्लिकेशन कर रहा है. द सेकेंड इंपॉर्टेंट पॉइंट इज वन पर्सन giving up multiple papers repeatedly. A strong degree of suspicion arises of a use of AI. So experienced reviewers can often detect these things very easily. Now what are the international UGC and NMC rules for the AI content in your research paper? That declare that you have used it, and in which category, in which part of the study you have used it. You can write you have used for grammatical correction, you have used for sentence formation, drafting of your research. You can claim. And how do you declare? I have given two citations. How do you declare, and how you declare you have used it, and how you declare you have not used it. These are the formats. And the author affirms that no generative AI tools were used in writing of the content creation for this manuscript. This we have also making necessary for our journal also. That in the end, one line जो disclaimer ethical concepts होते हैं, उसमें एक ये भी होता है, AI content not used. These, if there are some postgraduates, they can take the picture of this. These are agencies and sources offering sponsorship or funding for paper publications. And these are the top Scopus Index journals without publication fees. So if you submit in your research paper in any of these journals, you will not be charged because charges of PubMed, Scopus and PubMed are very high. So they charge in a lot of money. And this is the top PubMed journal. वो Scopus था, ये PubMed journals हैं जो कि फीस चार्ज नहीं कर रहे हैं. I'll go पीछे भी जाके मैं दिखाता हूँ आपको. You take a picture of this. PubMed index journals हैं without annual processing charges. And this is for the Scopus, those of you who have not taken the picture. And these are the indexing sources. This also you can take the picture of. These are the sources of funding. ICMR भी देता है, आपकी थीसिस के लिए भी देता है ICMR. किसी को कुछ लिंक चाहिए उसका तो हाँ, you can contact me. I'll give you the link for the ICMR who gives money for. Thank you very much.
I would like to request Dr. Praveen Saxena sir and moderators to please felicitate sir with a token of appreciation. Up next we have senior representative from MEDEL who will be giving a lecture on middle ear implants. Shifali from MEDEL, please come stage.
ये वाला, ये हाँ, this one. ये वाला ना? Second last. Yeah.
Switch करो फोन.
अभी चलो. Oh yeah, done. Thank you. Good afternoon, everyone. My name is Shifali. I'm a senior specialist in Special Projects Department working with MEDEL for more than 8 years now. And yesterday during my talk, I spoke about different hearing solutions that MEDEL provides. Today, I'm going to focus on passive middle ear implant that MEDEL has. And before I begin with my presentation, I'd like to thank the organizers for this opportunity to talk about PMEI by MEDEL. So to begin with, our mission in hearing is to overcome hearing loss as a barrier to communication and quality of life, and to do so we have wide range of hearing solutions available. For people who have severe to profound hearing loss, we have cochlear implants. For people who have sloping kind of hearing loss, we have EAS or electric acoustic stimulation. For people who have issues with auditory nerve or cannot utilize cochlea, for them we have auditory brainstem implant. For people who have issues with middle ear, we have middle ear implants, both active as well as passive, and today I'm going to talk about passive. Similarly, if bone conduction has to be used, then we have bone conduction implant and bone conduction hearing aid, which is AdHear available. So you see, we have multiple hearing solutions available because we understand that hearing loss is very individual in nature, and if we want to cater to this need of variety across type, degree, then we need to have multiple hearing solutions available. Recently, we have also added passive middle ear implant into our portfolio. And the reason why we have done this is because we wanted to offer a solution to every patient and every surgeon despite pathology, despite severity, and despite the type of hearing loss. Okay, so that's why we have now in our portfolio passive middle ear implants, and all these passive middle ear implants are made up of titanium. Why titanium? Because we understand that the high rigidity and low weight of titanium implants actually make up for very good sound transmission, and MRI can be done up to 7 Tesla in all of these implants. We understand that PMEI has been in market for a very long time, and we have tried to learn what works, doesn't work, and based on that we have introduced sophisticated design which have optimal visibility, intraoperative flexibility, and easy handling. And that's how we have introduced our tympanoplasty prosthesis, both partial and total, as well as stapes prosthesis. Now let's have a sneak peek on the prosthesis that Medal offers. In tympanoplasty prosthesis, we have 4 partial prostheses and 3 total prostheses. So today I'm not going to talk about all of them. I'll be talking about M-Clip Arc and M-Exact Pro line. M-Clip Arc is actually one of its kind prosthesis because you see the shaft and the head plate are connected by super mobile microball joint, and what this does is this makes the head plate movable in omnidirectional mode or in any direction possible. Okay, so that means it's a super mobile and it can adapt to the movement of tympanic membrane, and it will always lie flat against the tympanic membrane no matter how the tympanic membrane is positioned. Then we have clip coupling structure, which you can see here, right? So this structure actually is based on coupler based on VSP clip couplers. Okay, so we have used since 2014 we have used this clip coupler in VSP, and we know that it provides very high stable and very highly stable connection with the head of the stapes, and we also know that there is no necrosis which is seen in the head of the stapes. Also, the head plate is circular and symmetrical, due to which the handling is pretty easy, and different lengths are available starting from 0.75 to 3.50 millimeter functional length. To summarize, now what happens here is that because of this clip coupler, the stress on the annular ligament is really low, right, and which is very important for sound transmission. Similarly, the stress on the tympanic membrane, because of this microball joint here, the stress on the tympanic membrane is really low, which is very important in order to avoid extrusion. So this particular prosthesis in a nutshell has been made for efficient sound transmission, designed for long-term stability and intraoperative handling and easy access. As you can see, this prosthesis can actually go flat against one wall or the shaft. Okay, so that means entire view is visible, so hence intraoperatively handling as well as visibility is a good as a positive point in this particular prosthesis. The second prosthesis is the length adjustable line, which is M-Exact Pro line. It comes in 2 variants, M-Exact Pro Total and M-Exact Pro Partial. So this basically means that the length of this particular prosthesis can be adjusted, okay, based on the requirement. Now logistic is very simple here, right, because all you need to do is you need to have one prosthesis, you measure how much of length is required, measure the length in the prosthesis and cut rest of the shaft. So the logistic is pretty simple. Now this type of prosthesis has been there in market for a long time now. Then what have we done different? What different we have done is we have actually made the process of length adjustment really simple, and also you do not need any kind of additional tool or accessories for this length adjustment. There is no variable length no preset increment needed. With any amount length adjustment can be done. Let's look at how this is actually done. Now this is what the implant box looks like. You see the implant is right here along with the adjustment tool. The sizers that's needed, they are also sitting right here. So everything you need is in this particular box. There is no additional cost at all. So in order to adjust the length, you just need to push and pull the prosthesis until the required length is achieved. Then rotate the bell according to your need. Close the head plate using delicate titanium tweezers and cut rest of the shaft using 15 number blade, right? So that's it. And then take out the implant and use saline water to remove your electrostatic discharge. And I know it looks really easy, that's because it is. And to summarize M-Exact Pro line, logistic is simple, no special tool required, handling is very easy, so this is a prosthesis that has been designed for simplicity. Now that was the tympanoplasty prosthesis that Medal has. Moving on to stapes prosthesis, we have prosthesis that requires manual crimping, 3 in number, and we have one prosthesis that is crimp free and does not require manual crimping. So in total we have 4 prostheses. Today I'm not going to talk about all of them. I'm going to talk about M-Fix and M-Axis. Let's look at M-Axis. So basically if you look at M-Axis here, the loop width is wide, right? And what this wide loop width does is it distributes the pressure across your long process in a wider area. That means the focal pressure on the long process of incus is actually really low. Okay, that means that there is low chance of necrosis. Secondarily, you can see there are perforations here. Okay, so they have perforations here. Now these perforations make it very easy for this prosthesis to be handled, and they also reduce the chances of necrosis. So the advantage of using M-Axis is that it is easy to hold, and use intraoperatively, and at the same time the chances of necrosis is really low. The loop width is 0.5 mm, functional length are 3.5 to 5.5 mm, and the piston diameters are 0.4, 0.5 and 0.6 mm. And the last prosthesis that we have is M-Fix, which is the crimp-free prosthesis, right? So all you need to do is put this prosthesis just over your long process of incus and push it so that it sits well. There is no need of manual crimping. So here you can see the clip design is different. Now this clip design we have taken from long process coupler in Vibrant Sound Bridge, which was introduced in 2014, and since 2014 we did not have even one single case of necrosis using this particular coupler, and we have used the same coupler here. So now we know that the chances of necrosis is really low. The second benefit of using this is the harmonica design. You can see in the rear end there are many curves here, right? Now these many curves, what they do is they save space, okay, in the middle ear, and they do not touch the posterior canal wall no matter what. So that is again advantage of using your M-Fix prosthesis. Now functional length is from 3.5 mm to 5.5 mm, and piston diameters available are 0.4 and 0.6 mm. And lastly, the inner loop width is actually designed in such a way that it resembles to the loop width of the incus, so that it sits closely to the incus and does not cause any kind of damage. And this is what we are trying to do. We are trying to connect what belongs together with our passive middle ear implant. Thank you so much for your attention.
और इस पे फोकस करिए। हेलो प्रवीण, हेलो इन द हॉल, एनीवन इन द हॉल? क्या हुआ, आवाज जा नहीं रही क्या? सब चले गए क्या?
हेलो हेलो।
अरे सब चले गए?
हैं सर हैं।
कौन? प्रवीण? बड़ी धीमी सी,
हेलो सर।
बड़ी धीमी सी आवाज आएगी हॉल में, हैं सर लोग?
Sir, actually, sir, I was pushing Rohit to go to you, sir, for the revision asteroid, sir. He was about to leave. That was taking the workload.
Sir, all are interested to see the surgeries further.
ओके
रोहित बैठे हैं अभी।
सो देखो डॉक्टर राजीव तो पहुंच रहे हैं हॉल में।
रोहित
हाँ,
दूसरा रोहित बोल रहा है कि मैं पूरा केस करूंगा आज। Let him do full revision.
हाँ भाई रोहित, रिवीजन मस्ट राइट।
आ रहा हूँ सर।
आ जाओ। नहीं राजीव, आई थिंक दिस इज frontoethmoid mass and we will show navigation on this and I think should it be the last case?
मैडम निकल।
क्यों प्रवीण, राजीव?
Yes.
This can be the last case.
जी सर।
रोहित की बहुत जल्दी आवाज आई। यस सर। ये कैमरा लगाओ, फोकस ऑन द एमआरआई। नहीं नहीं, इसको नहीं कनेक्ट करना है आपको, इसको नहीं दिखाना है, आप इसको दिखाइए ना। ओवरहेड कैमरा इधर लगाओ ना। इसकी फाइल लाओ पेशेंट की, और ये चालू करो, हमें दिखाई दे वहां क्या दिखाई दे रहा है। सो आफ्टर a good case of cholesteatoma and a very good case of stapes, I think we had a good session today. What do you say, Rajiv? डॉक्टर राजीव पचौरी।
यस बोला।
हाँ भाई राजीव, we had a good session today.
Ultimate, yeah, ultimate.
Okay, can you see the MRI?
Especially the stapes surgery.
Excuse me, sir. We need a moment to felicitate for one session, last session, sir.
हाँ करते रहो, felicitate करते रहो।
Sir, we like to invite Pachori sir and Dr. Chitraji sir on stage, sir.
मेरी तरफ से
Shifali from Medal, please come on stage.
मेरी तरफ से स्पेशल थैंक्स टू डॉक्टर राजीव चित्रांशी। रियली enjoyed surgery, doing surgery with him. यार ये दिखाओ ना हमको। हाँ और रजिस्ट्रेशन कर दिया उसका?
Connect to OT.
Praveen, let me know when the felicitation is done.
Rohit, it is done. You can start.
Okay. So this is a 64-year-old male with a nasal mass and nasal discharge, occasional epistaxis. ये माइक ठीक है? हाँ हाँ उसको बाहर करो, इस पे फोकस करो, इस वाले पे, और सामने दिखाओ यार हमको। हमको नहीं दिख रहा ना कि वहाँ क्या दिख रहा है. साढ़े 7 नंबर ग्लव्स लाओ. ग्लव्स नहीं रखे यहाँ पे. नीरज हटाओ. ये कुर्सी हटाओ यहाँ से. चेयर हटाओ. चेयर. चलो उस टेबल को उधर कर दो. हाँ हाँ. So can you see the pictures? Can you see the picture?
Yes, sir.
So you see a nasal mass, frontoethmoid, blocking the maxillary sinus and the frontal sinus.
जी sir.
So looks good, and now we can focus on the CT. तुम्हारा सब रजिस्टर हो गया. फोकस करो. थोड़ा सा पीछे हो जाएगा. So we are using the navigation, and just to show the navigation especially to the residents, that this is a tool that is available now especially for skull base surgery, is also useful for routine sinus surgery, especially revision surgery and difficult cases. So I think you can see the scan. क्या हुआ? वाइट बैलेंस हो गया? हाँ? गॉच पीस रखो. Endoscopic picture to go there now. Are you seeing the endoscopic picture?
Yes, sir.
You are seeing the endoscopic picture?
नेविगेशन पिक्चर आ रही है.
Navigation आ रही है.
जी सर.
Okay. Section. इन्फिल्ट्रेशन दे दो. इन्फिल्ट्रेशन दे दो. सुनो प्रभु. एलिवेटर दे दो तक. सर थोड़ा सा हमारी तरफ. लाओ भैया लाओ दे दो. अपूर्व थोड़ा लोकल अटेंडेंस दे रहा. ला प्योर एडेनल बड़ा एडेनलिन यूज़ करना ना. थोड़ा एडेनलिन पैक यूज़ करना. यस कैन यू सी? रोहित.
जी सर.
हाँ भाई क्या स्क्रीन पे क्या है?
एंडोस्कोपिक पिक्चर आ रही है सर. आप पैक निकाल रहे हैं.
हाँ निकाल नहीं रहे हैं, पैक कर रहे हैं.
पैक कर रहे हैं.
हाँ. So what I'm doing is I'm just put adrenaline packs. And then I will go through the navigation. So navigation is an important instrument from Medtronics, and पहले stars का भी आया था. Rajiv knows about it, but it was not very successful, and Medtronic's navigation is quite successful and is being used all over the country. So first you have the tool here where you have to register, and then you have the monitor where the CT scans are there. So wherever you will touch the probe, they will show you on the screen where your probe is in 3-dimensional. That means you will see it axial, sagittal as well as coronal. थोड़ा सर मेरी तरफ मोड़ो. थोड़ा सा ढीला करो. हाँ ठीक है, नाक बंद करो. नाक दबा लो. So how many people in the audience using navigation? रोहित.
जी सर.
यार माइक पकड़े रहो रोहित, तुम अब जाना नहीं कहीं.
बंद हो जाता है माइक सर बीच बीच में.
उसको दूसरा माइक लो, है ना.
जी सर.
क्योंकि हमको डर लग रहा है, सब भाग रहे हैं. अच्छा, हाउ मेनी पीपल आर यूजिंग नेविगेशन? हॉल में पूछो तो.
हॉल में सर कोई नहीं करता.
Okay, so navigation we are using today and showing you how to use it. Okay, so this is the left side section 2 number. So you see, looks quite good, only the turbinate is a little so a little bit of secretions, and you can see the polyp here. So seems like a case of polyp. Elevator. Okay. So polypoidal mass coming here. Okay. Coming here. This seems to be the middle turbinate. Okay. Uncinate is gone.
जी सर.
So all this looks fine. Law divider. So we start with the divider law. पहले वो दे दो probe. Navigation वाला लगाओ. एक probe दे दो हमको. Probe कहाँ है? Which I can show. और इसका कैमरा जो है इस पे फोकस करो. इसको थोड़ा सा ऐसे कर लो, ऐसे. हाँ, परफेक्ट. ओके, इसको पीआईपी में ले लें. छोटा क्या है? नेविगेशन वाला. ओके. So we introduce this navigation and try and put it here. कहाँ दिखा रहा? हाँ? metal se batao, katori hatao. So all metal instruments have to be away from this, otherwise it doesn't work. And you see you will get green lines. So when you see, you put it here and you can see it is on the tub net.
जी सर.
नहीं आ रहा अभी. So that is how navigation can be important. With a simple tool, you can know exactly in the scan where you are.
जी सर.
Okay.
जी सर.
So like I am going here, so we are going into the frontal now, right?
जी सर.
So this is the significance of this law divider law. So we will use the divider. अब like Satish showed yesterday, put कहाँ? यार ये हमें ब्लॉक कर रहा है, ये हटाओ, ये कैमरा हटाओ, हाँ ये स्टैंड हटाओ, हाँ. So Satish showed beautifully yesterday the use of divider and the use of cobbletter in the nose. So simply we will start taking down the polyp. So divider has solved lot of problems.
Sir, endoscopic picture is not coming.
Endoscopic picture is not coming. ऐसा मत करो भाई. ये कटोरी इधर रखो. Coming now?
नहीं, no. आती जाती बीच बीच में आ रही है. हाँ, आ गई.
अब एंडोस्कोपिक पिक्चर फुल कर दो. एंडोस्कोपिक पिक्चर फुल.
चली गई.
क्या बात है? थोड़ा टाइम लोगे? रोहित, जस्ट 2 minutes.
ओके सर.
पैक दे दो तब तक. Endoscopic picture coming now. रोहित.
हाँ सर, आ रही.
हाँ तो बोल दिया करो भाई.
लाउड स्पीकर बंद हो जाता है.
अब ठीक है?
जी सर.
अब बस तुम पकड़े रहो माइक. 5 मिनट दे दो बस. इसको बाहर करें.
जी सर.
ओके. So anybody who wants to do endoscopic sinus work must have this debrider tool. It is a must. Section. So we have cleaned up the nasal cavity. Cleaned up the nasal cavity completely, just to see if there is any polyp in the nasopharynx. Sometimes a piece will fall in the nasopharynx and later on the anesthetist will give it to you or the patient will give it to you. So let's not make that happen. Okay, ballpoint probe. So for the juniors now, this is the inferior turbinate.
जी सर.
This is the middle turbinate.
जी सर.
This seems to be the remnant of the
uncinate.
Uncinate.
Accessory ostia.
Okay. No, not accessory ostia. Just the remnant of the uncinate, and
या ऊपर से आया
polyp going up, okay, not going down, okay. One maneuver I did here, which you did not see, I just pressed the eyeball. Now, brother. So press the eyeball, just for the juniors, always press the eyeball and see whether it is orbit that is opened up. So you need to be a little careful here.
जी sir.
So we remove this. Looks good. So debrider makes the whole curved section tip. So one thing that I was talking of earlier also is the Caroline's window. Now many of you would have heard about it, some of you would not have heard. इसका मोटा लगा यार curved section tip. So Caroline's window is a window given by, the name is given by William Harvey, who is a famous endoscopic surgeon in Australia. And this Caroline is the name of the nurse who gave the name to this window. And what they say is, they say that you approach the frontal sinus directly. So this is all the fluid that was the muck that is there in the maxillary sinus. You can see it? Rohit?
जी sir.
See, all of this inside the maxillary sinus.
Yes sir.
So now you see the maxillary sinus opening well, and then you can use a reverse backward biting. I like the backward biting here. I am still with the zero.
Okay, sir.
I like to work with the zero unless I am pushed for the 45 or the 70.
Okay sir.
So beautiful picture of the maxillary sinus. And see, maxillary sinus is good.
जी sir.
Inside it's all good. So it's basically the polyp that was blocking the opening of the maxillary sinus.
जी sir.
Debrider. थोड़ा तुम्हारा ब्लॉक हो गया, सेक्शन इज ब्लॉक. दूसरा 45-60 लगा दो, तब तक इसको साफ करो. So maxillary sinus opening is quite big enough. Now there is another question always, how big, how small. So a decent opening is, the size can be vary, but what is important is well mucosalized. Dr. Meghnad was so good yesterday. It was a beautiful presentation of 1.5 hours on what to do and what not to do in sinus surgery. So there is nothing more that I need to do. ये पानी कहाँ से आ रहा है यार? There is nothing more that I need to do for the maxillary sinus.
जी.
Is the audience agreeing?
जी sir.
Reverse cutting. राजीव बॉस कहाँ है?
बैठे हैं.
बॉस कमेंट करते रहिए.
अरे अच्छा करो, कमेंट क्या करेंगे?
अरे अच्छा ही कमेंट कर दीजिए. So maxillary sinus is open. I am still with the zero. Now we go up, kerosene sponge. So what they say now is that if you have to approach the frontal, you approach it like this. So still you can reach it, but it is always better that you remove this area and reach axilla and then reach the nasal beak.
Yes.
तो ये एरिया को वो ड्रिल करने को कहते हैं.
हाँ.
तो हम लोग पहले ड्रिल नहीं करते थे. So recently I started doing it, and I am really enjoying frontal sinus since then.
Yes, yes, yes.
क्योंकि पहले क्या होता था, we were compressed for space.
पवन कुछ कमेंट कर रहा है.
अरे पवन के कमेंट बहुत खतरनाक होते हैं भाई.
अरे वो मार्ट की बात बता रहा है वो, मतलब
ये हमारा खास दोस्त है भाई.
अरे
wash. Wash. Okay. Section. So we have removed the polyp and we are already in the frontal. This is the polyp that is inside. So debrider 60 degree. So the turbinate is intact. So one junior was asking me where would we go for the posterior ethmoid, so it will be medially and inferiorly. And the other way is to medialize this turbinate and then reach the end 1.5 centimeters above the choana to reach the sphenoid. I am still with the 0. Curved section tip. So we have cleared all the polyp.
लैटरली थोड़ा सा ये बीक को और यहाँ ये
इसको और कर दें.
इसको क्लियर कर तो ठीक हो जाएगा, दिखने लगेगा.
So we get more view.
Yes, yes, yes.
So we can drill it also.
Yes.
केरोसिन स्पंज दो और ड्रिल लगाओ. बड़ा हलन.
Sir, for juniors, will you please show the frontal glow?
Okay. Let me open it wide first.
Ji sir.
Okay. Then we will show you the frontal glow. Drill.
And also sir, please show the anterior ethmoidal artery if possible.
Okay. ड्रिल पे करो, ड्रिल पे, डिवाइडर पे। करा? हाँ हाँ, अब आवाज ठीक आई। The only problem with this drilling is it's quite safe, but the drill bits are expensive. So you can't use them in every case. Okay, section straight. More drill. I think that should be it. Section. Divider. So this can all go. हाँ, जो लगा होता तो नहीं, ड्रिल हटाओ। हाँ, चेंज करो, चेंज करो, डिवाइडर पे करो। तुम्हारा सेक्शन नहीं काम कर रहा बहुत अच्छा। स्ट्रेट कट। So bone removal with the forceps and tissue removal with the debrider. Never remove the bone with the debrider, gets clogged. So now we are into the frontal sinus. Still I am using the 0. You can see the frontal buttocks as they call them. हैप्पी? रोहित, ये लाइट बंद करो।
जी सर।
लाइट बंद करो सब। लेट्स शो देम द फ्रंटल ग्लो। ये कैमरा इस पे फोकस करिए। ये जो लाली आ रही है उस पे फोकस करिए। ये जो चेहरे पे लाली आ रही है, कैन यू सी इट?
जी सर।
कैसा है?
बढ़िया आ रहा है सर, एकदम फर्स्ट क्लास।
You can appreciate the glow?
Yes sir, we can appreciate.
So a huge frontal sinus, and you are seeing the endoscopic picture, and you are seeing this.
जी सर।
Now if we turn to, this is just 0 degree. Abhi we are still with 0 degree.
जी सर।
Now if I change to 70, then you can go inside and you can have a look in the entire frontal sinus. I think we are nearing the end. Just show you with the frontal sinus and then we are through. So Praveen and Rohit,
Sir.
I am coming in the hall.
Yes, sir. Waiting for you, sir.
Okay. Curved section tip. Ah. So that's the picture with the 70. So you can see the entire frontal, absolutely good, well mucosalized. So this chap will not have a problem anymore.
Yes, sir.
So we
Very
put,
nicely depicted, sir.
yeah, we put the 0 and we just check the navigation. To confirm what we have seen. कौन सा दिया है? हाँ लाओ इनका. अब फोकस इस पे करो. कैमरा ऑन दिस. नीरज. Metronics. ये फिर करना पड़ेगा. कटोरी हटाओ, कटोरी हटाओ. कहाँ आ रहा है? So all these tools are very good tools, but initial you have to, maybe it has moved a little bit. Karu? Huh? Kare? उस पे फोकस करो सीटी स्कैन पे. सो आई एम टेकिंग इट राइट इनसाइड द फ्रंटल साइनस and you see I am in the frontal. Can you see? Rohit?
जी सर.
I am in the frontal.
जी सर.
You can see the two green crosses on the sagittal section
जी
showing
सर.
you exactly where I am.
जी सर.
ठीक है ना? So navigation can be a good tool to guide us and ultimately help us in surgery.
जी सर.
So I think we are through. We'll just put Marocel
जी सर.
and then come to the hall. Give me 10 minutes. Have a cup of tea, all of you.
अरे कितने का आता है ये नेविगेशन सिस्टम?
हैं?
कितने का पैसा?
Navigation system is costing about 50 lakhs. क्यों नीरज?
यहाँ सबको सांप सूंघ
नहीं.
गया.
नहीं, मैंने सस्ता बता दिया शायद. कितने का है? 75 to 80 लाख. सॉरी, हाँ ये वाला मॉडल 75 to 80 lakhs. और 4 लोग मिलके लेंगे तो 25-30 का मिल जाएगा. राजीव बॉस, क्या हुआ, आवाज चली गई?
मेरी
नहीं, पब्लिक की।
अब मैंने बताया ना, सांप सूंघ गया सबको।
अरे आपको थोड़ी सूंघेगा।
राजीव
बॉस, इनको हम लोगों ने ऑफर किया था, राजीव पचौरी, पंकज, मैं और राजेश यादव, मेरे सुन, 1 करोड़ में 4 मशीन। 25 lakhs ईच।
अच्छा,
ये इनको ऑफर ऑलरेडी किया हुआ है, दे नहीं रहे। हाँ, एक सेकंड, नेगोशिएशन चल रहा है। पारस में नेविगेशन है बस?
भी नहीं है।
हाँ,
लेकिन वो कॉर्पोरेट का देंगे तो इतने थोड़ी मानेंगे वो अपने अपना रखना पड़ेगा, जैसे तुम रख रहे हो। मेरा नाम भी ऐड कर दो उसमें तो 25 दे देंगे तुमको।
नहीं, मेरे ख्याल से रीजेंसी ने ले लिया है। रीजेंसी में उनका जो स्कल बेस है, राजन है नहीं, सौरभ?
नहीं नहीं नहीं, कोई नहीं।
Nobody from Regency. Okay. So we have packed it with Marocel. ये डॉक्टर मेघनाथ ने कहा was 5 days of pack.
डिपेंड करता है आपने कितना काम किया है।
नहीं, उनका कहना है कि 5 दिन पैक इज मस्ट, बिकॉज वो कहीं ना कहीं, चलो हो गया, चलिए बस, आई एम कमिंग टू द हॉल।
ओके
ओके,
गुड जॉब डन।
थैंक यू।
थैंक यू रोहित।
थैंक यू। माइक? नहीं, हम कुछ नहीं, वाइंड अप।
थैंक यू
सब ऑल वाइंड अप। थैंक यू।
Thank you all for this such a wonderful evening we had, 9th, 10th and 11th, such a good ENT fest. Thank you Pawan boss, thank you Chitranshi sir, Raj boss, and all the pharma company also who coordinated with us and made this day possible with such a good learning curve. Thank you once of all. Thank you. आप लोग अभी प्लीज एक फोटोग्राफ लेते हैं। बहुत the students have worked very hard. Finally, the UHM and the DNB residents, come here. एक फोटोग्राफ तो ले लें दो।